alaikum and good morning, everyone. Good morning, Professor Lionel. I would like to invite our Chief Transplant Surgeon and Director of Renal Transplant Unit, Dr. Rashid bin Hamid, for his welcoming address.
Assalamu alaikum, everyone. We start with the greatest name of Almighty Allah, most gracious and merciful. A very warm good morning to all of you, distinguished guests, esteemed colleagues, and fellow healthcare professionals. It is with immense pleasure and gratitude that I stand here as the Director of the Renal Transplant Unit at our University Hospital Boja campus and welcome all of you in this second International Kidney Transplant Symposium. I'm thankful to all of you that we spared some time for this symposium. I'm thankful to our friend who came from outside Karachi, from Lahore, Multan, and Islamabad, and Hyderabad to attend the symposium. I would like to extend our special thanks to our international speaker, Professor Rostaing, for his come here, and this is our sincere hope that we shall be seeing more of you in future in Pakistan. This gathering of brilliant mind, medical expert and dedicated professionals from all around the Pakistan and beyond the geographical boundaries represent a remarkable opportunity to share knowledge, inspire innovation, and collaborate in our shared mission to enhance the field of renal transplantation. As we gather here today, we must acknowledge the landscape of healthcare and transplantation is continuously evolving. Advances in medical research and technology have expanded our understanding and capabilities in this field. We have witnessed the development of more effective immunosuppressive regime, improvement in organ preservation technique, and the growing use of living donor. However, challenges are still there, including shortage of organ, ethical dilemmas, and disparities in access to transplantation. Our mission as a healthcare professional and researcher is to navigate these challenges, overcome them, and ensure that renal transplantation become a viable option for all who need it.
It is our shared responsibility to continue pushing the boundaries of medical science, to foster ethical practice, and to enhance the accessibility and affordability of renal transplantation. Renal transplantation represents a mission of all those suffering from end-stage renal disease and offering a second chance in the life. Today we have the opportunity to engage in and widen this discussion, share groundbreaking research, and learn from one another's experience. I encourage you all to actively participate in this symposium, ask questions, and exchange ideas. This symposium is a crucible of knowledge and innovation where the foundation of improvement are laid. I also want to indicate my heartfelt appreciation for all the experts, donors, and care professionals who have joined us here today. Your dedication is appealing, and your presence at this symposium are instrumental in shaping the future of renal transplantation. Let us seize this opportunity to learn from one another, to inspire and re-inspire, and to collectively work toward a future where renal transplantation becomes not just a medical procedure, but a beacon of hope and a symbol of the best left healthcare has to offer. I also want to express my gratitude to the organizers and sponsors for their unwavering dedication to the cause of renal transplantation. To conclude, and want to reiterate that we as a healthcare professional researchers have a collective responsibility to continue improving the lives of those in need. Our journey is long and our mission is challenging, but with the spirit of collaboration, dedication, and commitment to ethical practice, we can bring about meaningful changes in the lives of patients suffering from end-stage renal disease. Thank you for joining us at this symposium. I'm excited to learn from each of you, and together let us pave the way for a brighter and healthier future in the world of renal transplantation. Once again, welcome to all of you in this second International Kidney Transplant Symposium. Thank you. Thank you so much, Dr. Rashid, for your kind words. It's our honor to introduce and call upon our first panel of experts for this session to take their respective positions on stage. And we are very thankful for them for being here. Professor Ahmed Sumani Sahab, please take your seat on the panel. Dr. Bilal Naveed Sahab, IFS, and Dr. Khan Mohammed Babar Sahab.
Professor Ahmed Sumani is the ex-head of neurology, Jinnah Startup Medical Center, and the ex-principal of Sir Syed Medical College. And we can say that Sumani Sahab is the father of neurology in Pakistan. Dr. Bilal Naveed is serving as the medical director and consultant nephrologist at Khawar Kidney Institute, Karachi. And Dr. Khan Mohammed Babar is the senior transplant surgeon from Hamid Mehmood Jilani Institute of Medical Sciences, Kumar, Airport. Welcome, sir.
Now we will begin our first scientific session of lectures, for which I would like to invite our first speaker, Dr. Naranjan, for his lecture on the topic of navigating surgical complications in renal transplantations.
Dr. Naranjan has been working as a urologist and a transplant surgeon in Dr. Rashid's team since 2017, and he has a wide experience and good expertise in duodenal nephrectomy.
I'm Dr. Naranjan, and I'm a renal transplant surgeon at the University of Health Sciences. So at this moment, I'm going to share my surgical experiences with you. And I want to share with you something very special that had happened in the last few days, that the University of Health Sciences has been ranked in top 201 to 250 by Times of Higher Education. So, the University of Health Sciences is the only university in Pakistan which has liver transplant, bone marrow transplant, and kidney transplant under one roof. And the kidney transplant was started in 2016, and the first transplant was performed in 2017. Since then, we have performed more than 570 transplants. So since then, we have been performing very challenging cases and trying not to refuse anyone who has been referred from anywhere else. So we have dealt with the complicated vascular anatomy honors. And we have always tried renal osteoporosis, even the smallest vessel. You can see that how small the vessel was there, and we tried to do as much as possible to save every part of the kidney. So we have removed huge kidneys as a pre-transplant. So it's a journey I'm going to share with you. The second and third transplant is always a challenge immunologically and surgically. So we have performed multiple second transplants, and we have performed third transplant, and that is probably first in Pakistan. You can appreciate that this is the first kidney which is lying over there, and this is the second kidney on that side, right side. There was another kidney on the left side. So we performed in the right leg fossa as well. So it was a big challenge to see the vessels and do the osteoporosis and do the redo surgery. And our immunologist and nephrologist performed well to help. And the patient is healthy now. This is the transplant we have performed under epidural anesthesia. You can see that patient is awake, and we were talking with the patient in between during our surgery. So they are already used to our anesthesia team who has managed to do transplant under just epidural anesthesia. These are certain challenging cases we have performed. So I move to surgical complications. Renal transplant surgical complications are frequent and can significantly affect lung performance. survivor and patient morbidity. We have performed a study which is aimed to analyze the frequency of early surgical complications, their diagnosis, and treatment options in renal transplant patients. This retrospective cohort study including all transplant patients with surgical complications from April 2017 to April 2022 at the Renal Transplant Unit at the University of Health Sciences. Information on patient age, gender, BMI, relation with the donor, surgical complications were extracted from the medical records and data was analyzed. So out of 500 kidney transplants, 76 patients, that is about 15.2%, experienced early transplant complications. Only one patient expired due to post-transplant surgical complications, so the mortality rate was 0.2%, which is in line with the previous studies on the kidney transplant patients. The morbidity and mortality, just we discussed that 15% had a morbidity of complications and 0.0% died secondary surgical complications. So this is the data about the age. The most common age in which we experience the patient had complication that is 21 to 30 years and 41 and 50. As most of the transplant patients were male, the surgical complications were also more common in male patients, that is 73%. And it's more seen in the blood group with the A positive, that is 47.74%. And it was not related to the BMI, it was more seen in the normal BMI range, that is 18 to 25. Most of the patients belong to Sindh province. These are the complications, urological complications we observed in our patients, that is urological complications were 1.2%, and we had 6 patients, 2 patients were of urine leak, and DNA constitution, urinary obstruction was not seen, and there was one patient of nerve rupture. So all of these patients were as dealt with as a protocol, that the urine leak was first dealt with the catheterization and the medical treatment, and when not really we had to take them back to the theater, and most of the time we performed Boris Platt for the urine leaks. This is one just picture that there was a urine leak, and we had to cleanse the PCN. Through PCN we had passed blue dye, so we can see that there was a leak from over there at that point. So we had to perform a Boris Platt in that case as well. The vascular complications were seen in 3 patients, that is 0.6%. Renal artery stenosis was seen in 1 patient. Renal vein thrombosis was seen in patient, and bleeding was there in 1 patient. And most of these patients were dead. Renal artery stenosis, we did angiography and angioplasty with the help of vascular intervention radiologist. And complications were hemorrhagic were dealt by reopening the patient and resuscitate it. These are the wound complications. Wound complications were wound lesions and seroma formation. It were categorized into superficial and deep. So the superficial wound complications were seen in 20 patients, and deep wound complications were seen in 5 patients. That is about 5% of the cases. So this is same deep wound complication was seen. This is just one picture of our one patient who had a deep wound complication, that abscess formation was going deep in the kidney. This is the fluid collection was seen in 40 patients. That is the highest in percentage, as we see lots of patients with the lymphocyte. There were 35 patients of lymphocyte with 8%, and hematoma was seen in 5%. gastrointestinal complication was seen in one patient and nerve loss was in one patient. So fluid collections were predominantly lymphocytes observed in 35 cases, in which 30 patients treated of conservatively and backside in the pyroline and ethylcrol installations, and only 5 cases need exploration and hematoma. That is one secondary to hematoma. And gastrointestinal complication was seen in one case, graft loss was seen in one case. Overall, the surgical complications were 2.1%. So, on conclusion, I'll say that the incidence of surgical complications was relatively mild, and suggesting that while complications were present, they were not excessively high in frequency. The occurrence of these complications was associated with delayed renal function, indicating the need for careful monitoring and timely intervention in these cases. Our study was also found that overall graft and patient survival rates were relatively good, which underscores the importance of establishing the transplant programs in developing countries to address the growing burden of end-stage renal disease. Thank you.
Thank you so much, Dr. Naranjan, for your speech. Now I'm inviting Dr. Sunil Kumar from Aisha Deliveries lecture on the topic of understanding and managing post-transplant diarrhea.
Dr. Sunil is a well-reputed consultant of infectious diseases at SIFD, and he has a deep understanding and vast experience in treating infections after renal transplant.
I'm Dr. Sunil. I'm working as an infectious health consultant. To me, diarrhea is big aliens because it's usually dealt by a gastroenterologist. So I will just focus on infectious complications or infectious organisms which can cause diarrhea. And we also will understand with the diarrhea in the literature where we look in the Western world, is it different than where we are living it? Whether we have different problems in diarrhea as compared to international world. So our game plan will be, we will see it is diarrhea different in our region as compared to international literature. We will also see epidemiology, what's the international organisms which can cause diarrhea and what's our local epidemiology say. We will discuss just 2-3 common opportunistic organisms which can cause diarrhea and more problematic transplant recipients. I will try to, with modification version, how can we approach diarrhea in our local setup, depending upon lack of availability of resources and other things. And also, does antibiotics, because it's a common practice to prescribe Cipro to every patient with diarrhea, does it really works in patients with diarrhea? And the most important thing in diarrhea is prevention. So if you look at burden of disease globally actually, we can see 2 different words actually. On the low-income countries, the top most organism which can cause burden of disease in the measure of disability lost is enteric infections, diarrhea infections. And in developed world, we don't have them. This means we have very huge burden of diarrhea in community, and then transforms in diarrhea deaths per 1 lakh population. If we see in our region, Pakistan, it's touching 200. So this means we, on the average per year, we lost 200 patients per 1 lakh population. And most of these is under 5 years of age. So that's how prevalent in Pakistan. This is on my left side is the bird in which less than 5 years. You can see, although it has reduced down since 1990 to better water sanitation facilities, but still the huge burden is on less than 5 years and above 70 years. But in Pakistan, as you see, under 5 years, this is a very big cause of mortality, having under 5 years causing the deaths actually. If you look at microbiology, what are the organisms which causes this? Because microorganisms tell us whether we can treat it or not. So the most common cause of diarrhea in that is rotavirus, and then followed by adeno and norovirus. So these three are the viruses which causes diarrhea worldwide, not related to transplant in the general population. And amongst bacteria, the huge amount is Shigella, for which we can prescribe antibiotics. E. coli, which is toxigenic, this means we don't need antibiotics. It's due to toxin production, you just have to IV. And crypto, probably this Cryptosporidium in community, not big cost, but in patients with transplant, it is actually important operational pathogen. So we will talk about in detail in later slides. And split component of Campylobacter and Salmonella. So, but this Salmonella is very actually important for us actually. If you look at our own Pakistan data, if we look at our own incidents, 5 to 50, 40 years, these are the few persons who develop diarrhea, but this is the age when the babies start going to school, they look outside school, so there is a huge incidence of that. But the mortality is actually under 5 and 5 to 20. These two last two, this actually causes the mortality, and we are touching around 20 deaths per 1 lakh population. We have this typhoid problem, and we will discuss later in the slides also, because typhoid is, to Pakistan, is a bit different than whole world. So back to diarrhea transplant. It's a potentially debilitating disease. Actually, it's more of a problem with patient than to physician. Because because there's a symptom which is cumbersome to patient, usually it don't cause that much problems unless there is a huge amount of diarrhea which causes lively threatened and affects our immunosuppression level, so not a big problem to us. And majority of diarrheal episodes actually have no identifiable HR, and they are sent over. They are sent on their own. Different studies have quoted different incidents ranging from less than 1 to very high, just 23% in developing countries. And prevalence studies also document up to 50% patients may have died. So, grossly, infectious causes, MG discussed Campylobacter, Salmonella, bacterial overgrowth, and E. coli. These are the common bacterial causes. Among parasitic, Cryptosporidium has got basically a main overshift pathogen. Rarely see Isospora and Cyclospora, and this entity, but this can be important in our whole country. And among viruses, CMV can cause diarrhea or cold affect poor GI, and the norovirus is most important cause of that. But we have to, on the same time, we have to look for non-infectious causes, amongst which the immunosuppressions are the most important component, in which microfiltrate is presumed to be more, but there can also be documented with tacrolimus and other anti-immunosuppressants also. But there are also the non-immunosuppressive antibiotics like antibacterials, antibiotic-associated diarrhea. Patient may this proton pump inhibitors. This is very important component causing diarrhea. We need to review this in our side. But we have also keep in mind that post-transplant lymphoproliferative disorders, inflammatory bowel disease, colon cancer, melaproph, these are the important cause of diarrhea. And in our setup, the one cause which I will discuss in previous slides, Mycobacterium tuberculosis, it is also one common cause of diarrhea in our setup. So if you look at epidemiology internationally, this is a very large study which is done from Belgium way back in 2006, in which 180 patients with diarrhea over a 2-year period were evaluated. And medications were the most important cause. 73% were medications caused to be caused. They have done a very good allocation to their approach to diarrhea. But 60% of that related to immunosuppression. Infectious cause was identified in 64%, in which 36% were bacterial overgrowth, 20% were bacterial infections. The CMV was on in 7%. But that is way back in 2006. If you look at our neighboring country in India, because that's have facilities of wash similar to us, in India, 50% of they were able to identify infections as a cause, in which the most important organism which they identified is Mycobacterium. Amongst the bacterial C. diff was 5 patients, drug-related 29%, but see at the bottom, 23% have no warrant, even after extensive work. And when we look at bacterial or infectious causes. The most common cause was norovirus study, followed by Diarrhea in their good populations. And if you look at community data from Pakistan, again non-transplant data, a biosurveillance done at Karachi, in which the Vibrio order was a predominant amongst infections, but the bacterial was only 14%. And compared to that, 30% Salmonella, 18%, Shigella was 15% amongst the infectious levels. At our own institute, we had 120 renal transplant recipients. The median duration was around 78 months post transplant with diarrhea. Because the majority of patients are male being transplanted for 76% of male, but we have equal contributions from Giardia and cryptosporids. And we do have 23% entamoeba, 11% patient have tuberculosis, and 6.5% has proof. So we have Giardia and cryptosporids, so they are most common. And also, there's also, when we review our endoscopic approach, what are the organisms which involves identified not on microbiology, but on histopathology, then CMP 11%, cryptosporids is 1.6%, giardiasis is 15%. So we do identify lots of these patients having invasive giardiasis on biopsy, not on that. And we do have tuberculosis and lymphoma as a cause of diarrhea. With about these two pathogens which are very important to cause diarrhea post-transplant. Crypto is everywhere, ubiquitous in natural water resources. And usually the source is contaminated food or water. Different prevalence in transplant have been identified up to 53%, 16 to 53%. We do have at one time 33% of patients prevalence of cryptosporidiasis way back in 2013 to 16 transplants. Diagnosis can be do if we do modified diarrhea scan or if we specifically look for that. Otherwise, the microbiology is not going to do testing on this if you don't tell them that you are suspecting cryptosporidiasis. Treatment would be reduction of immunosuppression. Nitrosamide has been tried with variable responses, and some people preferred combinations for very resistant cases. The structural lurches, this is very prevalent in India and Bangladesh. Not much data from Pakistan regarding this actually. But this actually occurs for contact of skin from soil infected with human feces actually. This is people who are defecate in the open air from air in contrast. In the patients with transplant, the mode of active case could be reactivation of asymptomatic patients. When we immunosuppress them, it could be donor joint or it could be de novo infections. It can involve hyperinfection syndrome with which the mortality is up to 40%. We do have identified a patient with E. coli bacteria, enteric organisms. When we did a stool that we find this. Diagnosis can be really in multiple stool examination. We cannot detect in one actually. We have to send multiple samples, at least 3 samples in the morning to detect this. Donor screening is incomplete by ELISA because the stool there is sporadic chance of taking. Infected donors, candidate recipients, if they are positive, they can be treated with ivermectin pre-transplant. And in post-transplant, if we are identified, we can give ivermectin. But in hyperinfection syndrome, which has got 50% mortality, we need to continue the 2 weeks more than beyond that actually. A bit about C. diff infection. This is very common in the Western world as a cause of diarrhea post-transplant. It has got some diagnostics problem because we detect through top cells which has got limitations. That's why the latest recommendation is you do highly sensitive GDH tests, which is glucuronidate, or you can get PCR. Then if positive, then you need toxin because it's a toxin which is causing this diarrhea, not actually that. This algorithm we should follow when we are evaluating studies whether they have done or not. International literature suggests around incidence of 1.3% in knees and kidney and liver that got about 3.7 incidence. And liver is 3.5. It's very common in liver in kidney. It do causes significantly more mortality, 4.3% versus 2.2% mortality. And it do increase the length of stay, hospital burden, transplant complications, and some may line up into collectively also if it's severe. If we look at the local data from Pakistan, I looked at literature from Pakistan. So we have this one in cancer patients from Lahore, which is in a immunocompromised population. They identified it with this PCR, and there were in 50K patients in 8 years. Not much common probably in our set. At our own institute, we are doing CD PCR, and we have done 98 in this year, and we have only one bottle. That makes a probability of 1.07%. And in that, this just a PCR part. We don't know if it's a toxin, but it's because toxin X-ray is not available currently in Pakistan, so we don't know the toxin in that. The real definition of CDI, C. diff infection was not. Probably we don't have that much CDI in Pakistan. Reason, and that's also we see in our own non-transplant operations. So, how to approach a patient with diarrhea and other side effects. So, when patient has diarrhea, this patient has 3 stools per day, we can honor first time metabolic. We can use CMD PCR, which we can easily do in our cycle. We can do serious PCR. That's actually the more data will contribute if people start publishing whether we have this problem or not. We can send bacterial culture and over parasite because to go to detect Giardia and actually by HCC. We can do modified dietary factors. This is basic investigation which we can send, and if we have available of this multiplex PCR which is biofile, and we can order. But at the same time, we need to also see whether which are the non-immunosuppressive medication which can diarrhea. We need to stop them at that. If CBPCR is positive, we can treat with value or again sexual depending upon availability and severity. And if no response, then we can go for arrest. But if among this workup, if it's positive for any mechanism, we should first detect. If no response, then we can move down and we can do second. We can send non-virus PCR, but if you're doing multiplex PCR, we can what it. Giardia is not visible. We can do blood tests, which is again still not in Pakistan, but this time you can bacterial overgrowth, which is very common cause of diarrhea in Pakistan. If blood test is positive, we can ask for bacterial overgrowth. We can prescribe fluoroquinolones or amoxicillin actually at this point. But if there is no response and diarrhea persists, then we need to adjust immunosuppressant. We should do in fact endoscopy, upper and lower. We can try empirical therapy with probiotics and antimotility drugs, and we also evaluate for maladaptation. So this is approach with which serially we can do it. This biopack, this is actually an excellent to pick infectious organism. Currently, it can pick bacteria, Diarrhea, E. coli, parasite, viruses, all variety. But it's available in Pakistan, but currently the cost is very high. So at this moment, not much units are doing this actually. There's not much data in Pakistan regarding this, but the utility of this because we need to make it cost effective. We can go for abdominal CT areas suspecting abdominal tuberculosis. We can pick abdominal lymphadenopathy, which can point towards tuberculosis. Histoplasmosis, again, not much in Pakistan, but we do have lots of TB here. And in fact, we can pick lymphoma also. But there are some rare or non-infectious causes which can diarrhea in Pakistan. So this is our experience, this is our algorithm that I showed you. We do this microbiology testing in that, and here we do VGD. We do see lots of neuronal illness at our site of it. So in neuronal illness we do exclude on the basis of Giardia was 17, 18 to have celiac serology positive. So we manage on the lines of it. But we have 68 patients in which we didn't identify any cause actually. So in this 68 patients actually, and we don't have this neuronal illness atrophy group, immunosuppressive were not significant. Both are groups actually. They were similar percentages in both groups, no significant event. So in these 68 patients, in which we think this is bacterial overgrowth, or other word we can call it tropical stool, we would write fluoroquinolone, which is ciprofloxacin and folic acid, and 50 transplant recipients complete response to therapy. and PTE patient won't have a response. We do have seronegative celiac at our setup. We have KCE, the Whipple's disease in our setup, which presents with diarrhea and endoscopy, chronic celiac, Whipple's disease. But about its antibiotics works, if you remember, the most common organisms, Campylobacter celiac, only 4 to 40% covering of ciprofloxacin. This means these are not for this. Ciprofloxacin don't work when we are treating for that. Shigella, Campylobacter, Salmonella. I'm coming in next slide. Okay, this is data from Pakistan. In Salmonella from Pakistan, we have lots of XDR. This means, in fact, cefixime is not working. The ceftriaxone resistance is stop touching more than 50%. So this means if you are suspecting Salmonella, your cipro is not going to work. The resistance is almost, this levofloxacin is touching almost 90%. So we need to focus on general precautions. Personal hygiene should be better. Avoid wastage. No freshly prepared or properly cooked food they should not eat. They should avoid salads, tea, food undercovered. Boiled water or bottled water should be drink only. And that's from, in Pakistan, that should be from rapid company. And avoid walking if we have barefoot with PM stomach. So take home, diarrhea result will be high morbidity. May not high mortality, but high morbidity. We need some local epidemiology. We do have radars, but we do, with this biofilm, we actually enhance our knowledge. Antibiotics do not work except in very few cases. And we need to counsel about safe drinking habits. So, thank you.
Thank you, Dr. Sunil, for this excellent lecture, which is you're going to have the question at the end. It was a very important, comprehensive talk and very well presented indeed.
Thank you so much, Dr. Sunil. Moving towards the third lecture, I am inviting video retired Dr. Hamid Mehmood to deliver some topics of tackling difficult cases from an anesthetic perspective.
Dr. Hamid is a leading senior anesthetist from Dhaka University Hospital and has been a part of our renal transplant team since our house transplant. He possesses deep understanding and expertise in administering anesthesia to difficult patients undergoing renal transplant.
This is my proud team with which I have successfully done more than 571 living kidney transplants since the start. And I would particularly like to draw your attention to this specific point. You have a look at this number. 76 of these patients were those which had an ejection fraction of less than 40%. And all of them have been done successfully, keeping apart, but the patient safety was never compromised. With a mixture of all the diabetic, hypertensive, and ischemic heart disease patients along with the list, we have successfully done it. And the major thing which I usually say to my students as well as to everyone else, there is no such thing as unfit for anesthesia. This term doesn't exist at all. Pros and cons are there, risks are involved, and you tell the patient, you explain the risk to the patient and let him decide. And a majority of the patients we have seen, they are willing to take up the risk. We optimize them properly and then proceed with extreme caution, and the results are good. But until and unless we develop that faith in ourselves, that yes, we can do it, the patient will be safe, it can be delivered. But that needs time with the patient, your experience at hand, which we have gained over the years, and practical involvement of all the necessary electromedical equipment and gadgets. This gets stuck. 568 cases were done under general anesthesia. However, 3 selected cases we did under epidural anesthesia. Now, one might ask, why epidural? Why not general anesthesia? When such a big surgery is going on and the patient why do you want to keep a patient at this stage where invasive monitoring is all involved, which you need to proceed with under local anesthesia, and you do not want to give it anesthesia? Why to take up this option? There are a few cases, like the first one we did, in which we offered epidural anesthesia to the patient. That patient had already gone through a surgery for transplantation, but the anesthetists involved the team of anesthetists, in fact, which were involved, weren't able to intubate the patient. An emergency cricothyrotomy was done to secure the airway, and the patient, the surgery was postponed. That tracheostomy was closed after 4 weeks, and the patient turned to us after a couple of years, and he wanted to undergo a transplant. He had a donor with him, but he didn't want to undergo that phase of general anesthesia. He didn't want to take that risk. But he did volunteer for epidural. We explained him that it might be uncomfortable to him. He was willing to take the chance, and that went on rather well. The patient responded to it well. The hemodynamics were not that much changed or altered during the course of surgery. The patient remained stable, and alhamdulillah is doing fine till now. So my job has become quite easy in a pre-anesthesia clinic when I have such wonderful team of different people involved who are willing to assess the patient and give their fitnesses. So before the patient reaches to me in pre-anesthesia clinic, he has all the workup done, all the necessary workup. The cardiologist has seen the patient, he has given his opinion about the patient. The stress echo has been done, which gives us an idea. The beauty of stress echo is now that if any of you have read the report of stress echo, it gives you the upper margin till that the patient's heart is able to tolerate the blood pressure. Like usually it's easier, but that sometimes even with a reduced ejection fraction, their systolic blood pressure touches 180 or 200 without any symptom to the patient, without any change in their ECG. And these are the patients who go on and become fine. But for these specific patients, the hazard is hypertension. Even transient hypertension, they can't sustain. And that can turn to deleterious effect. So my planned anesthesia, which works up at the end, is because of all these factors involved. Now, one thing most important which we have introduced and which we have is that the physician is not the one who is going to decide what is going to happen to the patient. According to the NHS guidelines, what we have started is a shared decision making, where the patient, a willing consent patient, has all the rights to know what is going to happen to him, and he is the one who decides along with the physician which course of action are we going to take, which specific drugs are going to be given to him. All the patients these days, they are well tuned, and they usually Google up all the options available, and once they come to a doctor, they are more than half trained in what options are available to the patient and how they are going to be treated, and what should not be done to them. So the patient's IQ has increased a lot, and keeping that thing in mind, we have to cater for this shared decision making, which needs to be offered to every patient for every surgery. Now with the spectrum of switch. Now, with the spectrum of end-stage renal disease, which a patient can come with us, and all these things need to be addressed of, a very careful chartered plan with a very careful drug history and very careful administration, and especially monitoring of the patient, is required to undertake such a big surgery. Most of these things can be taken care of if provided you do not try to overcorrect it. So once we proceed, when the patient is admitted for surgery, he is revisited by the team member. A video consent is mandatory for transplant, which is taken. The plan is re-explained to the patient and re-endorsed on the file, and specific instructions for the continuation of drugs, especially the beta blockers if he is taken. We do not stop it at all. We continue that, but usually with end-stage renal disease, the patients are taking 2 or 3 antihypertensives. And even with those 3 hypertensives, their blood pressure, their systolic touches around 200 or 180 millimeters of mercury, and the diastolic hovers between 90 to 100. Now, as the disease, with the chronic patients, their body is well settled with these pressures. So if we try to bring their pressure down to 180 by 80, their body is not going to settle. It will be a hypertension for them. So gradually, as a new kidney sets in, the new body starts accepting that kidney, the pressures automatically tend to tune down. If we plan to give an epidural to the patient, we usually avoid second and third antihypertensive, because as epidural anesthesia will set in, because of the systemic vasodilatation as well as a sympathetic blockade, the blood pressure is going to come down. So that catering needs to be monitored. Insulin, usually diabetes is there. They are put on insulin regime, which is to be followed. Now, most of the patients, they do require hemodialysis within 24 hours, but we have to take care of the fluid abnormalities, especially the hypovolemia and hyperkalemia, which increases the chance of bleeding. So post-dialysis weight near to the dry weight of the patient is mandatory to be kept. These patients usually have delayed gastric emptying, but for that, there is no need to go for a rapid sequence injection using succinylcholine. These patients usually have a potassium on the upper limit, so we do not intend to give anything which will increase the potassium beyond that. So prokinetic like metoclopramide or a simple omeprazole can work. Magnesium and ammonium containing antacids should be avoided in patients because in the presence of their toxicity in the presence of low GFR and low renal perfusion pressure can cause problems. Anemia is a common problem, and usually these people are on erythropoietin. But for microvascular anastomosis, with the experience, the people have said that the best hemoglobin or the best blood hematocrit of 33% is ideal for microvascular anastomosis, so that the sludging of the RBCs it doesn't occur. The laminar flow that is maintained. So we try to keep the hemoglobin around 9 grams per deciliter for these patients. Do not try to overcorrect it. Do not try to give blood transfusion beyond that. The anti-angina medications are continued. Oral hypoglycemics have said will stop. Standard general anesthesia with precautions. We gave a balanced anesthesia. Cis-atracurium is only used for patients who show hypersensitivity to atracurium or who have asthma or history of any reaction to, or they are more prone to histamine release, as atracurium causes histamine release. So to avoid that, we use cis-atracurium, but for specific patients. Other than that, the difference which we have created over the years is that we now use more of total intravenous anesthesia. Instead of giving halogenated compounds like isoflurane or sevoflurane, we try to reduce that and we maintain the anesthesia with propofol infusion. If you guys remember, just a couple of years ago, there was this scandal that a locally scammed with the name of Restine, isoflurane was in the market, which caused around about 50 to 60 deaths. And that caused a lot of havoc around. And so we were luckily able to avoid that part because we had already shifted to propofol infusion. So isoflurane can cause problems. So propofol infusion is better. With opioids, morphine, we do not want to give to the patient because of the delayed respiratory depressive effects. Luckily, we have fentanyl available with us. So all these patients receive fentanyl for analgesia, which is continued post-operatively also. Uh, um, okay. And with these patients, what we made sure is specific central line placement, which is done in all the patients. An arterial line is definitely passed for invasive blood pressure monitoring, but central venous pressures are no longer our key indicators for fluid resuscitation. We use non-invasive cardiac output monitoring. We use transesophageal Doppler for that. Cardiac machine is available with us, and we monitor or look forward for CVV, your central volume variance, which happens along with it. Now, a CVV value is far more better to be followed as compared to your central venous pressure. Aggressive monitoring, and we give aggressive fluid therapy, which is biphasic. Before the kidney is transplanted, we restrict the fluids, but as soon as we have the kidney inside the body, we try to give 10 to 20 ml per kg per hour with an aim of maintaining a urine output of more than 2 ml per kg per hour. Our target for the hemodynamic control is to maintain a mean arterial pressure more than 30% of the baseline. Now, usually for these patients, we maintain a systolic blood pressure above 160 millimeter of mercury and the mean arterial pressure above 110 millimeter. So the choice of fluids, we try to avoid normal saline because of the hyperchloremic intake. We do not want to give much of the chloride inside. So half-strength normal saline is usually preferable, or if we can get hold of a balanced salt solution, which unluckily is not available to us with the name of plasma light, but still half-strength normal saline works good for us, or normal saline can also be given at the end, but this is the console which we are looking forward to. We monitor the depth of anesthesia with BIS, bispectral index, which gives us exact sedation score, and we maintain it between 40 to 60, which is a target which is to be kept under general anesthesia. This is the non-invasive cardiac output monitoring, which uses transesophageal Doppler, the stroke volume variance, and cardiac output. Both are given per beat with us to the patient. So this helps in radically maintaining the pressures of the patient intraoperatively. You are able to respond to them quickly, and with that, we help the patient to remain stable. Special care is taken for the AV fistulas. That arm needs to be secured properly. It is susceptible to injury, so it is marked specially, and they are prone to pathological fractures also, so the shifting is done very cautiously. For blood products, we monitor ROTEM. We have the rotational thromboelastogram with us. As soon as the kidney is in place, we do one ROTEM reading. Now, this graph helps us to identify if the bleeding is there, what is the cause, and we give only specific treatment. Like if platelets are needed, this will help us, and we only give platelets. With that, we don't need to rush on to all the freshos and plasmas and the whole blood and everything. We try to maintain the normovolemia. We do not want the patient to get excessive fluid inside. So these gadgetries help us all the way. The immunosuppressants are given according to what the transplant nephrologist has prescribed. Usually a steroid, methylprednisolone 500 milligram is given intraoperatively just at the time of anastomosis, and either ATG or besimleximab, they are given slowly over a period of 2 to 3 hours. The diuretics, we give both the loop diuretic as well as osmotic diuretic. mannitol. Both of them are given once the anastomosis is about to be released. All of the patients are extubated on table. Out of those 569 cases, where there were only 2 cases which we had to put on ventilatory support, one had a proper delayed recovery. The patient recovered after 4 to 6 hours. For that, we had to put him on ventilatory support. The other one had a lot of bleeding in the surgery. And
we have 1 minute left. Kindly wind
sir,
up.
this is the last thing about this success story is the shortcomings which we are having. There is no central registry of any data around. If you try to Google it, how many pediatric kidney transplants have been done, you won't be able to find any data. Because unlike the West, where they have a proper unified network of organ registry, we do not have any such system. We do not share our data with each other. We do not have a proper team to look for that. We need to develop more centers. We need more students. We need more teachers. There are many dimensions which need to be covered. Safe surgery can be performed with vigilance, but it is high time for the developed center of excellence to now start fathering the developing centers. We need to develop more centers, but for that, the already developed centers have to, proper take over these centers, enhance unity among the different setups, enhance the fraternity. And when yesterday I was thinking how to send this last message, this can only be achieved if we are united among each other, if we have faith that yes, these surgeries can be performed, but for that we all need to be disciplined. And a living example for such is with us, Dr. Deep Brisby. He has proved it. And we need to just follow those steps, and that is all.
Thank you very
Thank
much.
you,
We'll have the question at the end of the session. Thank you.
Thank you so much, Dr. Hamid, for your time, and we truly appreciate your efforts for the patients. Now I'm inviting our 4th speaker of the session, Professor Asim Ahmed from the Kidney Center, Karachi, to deliver his lecture on addressing the ethical issues in non-related kidney transplants.
Professor Asim is one of the senior faculties in nephrology and a very valuable asset to the Nephrology Society. And he's probably the only nephrologist in Pakistan who has the understanding of the ethical issues related to the clinical scenarios. Please give a big round of applause to Professor Asim.
Good morning and Assalamu alaikum. Thank you very much for the invitation. This is our 2nd symposium, and hopefully we'll continue doing more. So kidney transplant, as we all presume, is the gold standard for the end-stage renal disease, where dialysis is an option, but clearly quality of life, and otherwise it's clearly better. Transplants are clearly better. But once you start doing the transplant, so when it was first done, it was said it was a miracle. Transplant was a miracle that happened in the 20th century. And I think in 1954, when the first transplant was done, a lot of ethical issues arose following that. But if you look at the timeline, I mean, it's really interesting. In less than 70 years, we are now talking of xenotransplantation. So from living related to cadaveric transplants to immunosuppressions, from different kinds of immunosuppressions to actually going on to porcine transplant or to xenotransplantation. And I think eventually the future of transplant eventually will be xenotransplantation or some kind of modified versions of xenotransplantation. So transplantations are clearly related, are divided into basically 3 types. So there is a living transplantation as well as cadaveric. And the living transplantation is by and large related or unrelated. And unrelated transplantations are clearly into 3 categories. I think one is a purely altruistic donations, which is rare and few. I think the only true altruistic donations that I've seen or have heard of is the is the monks in Sri Lanka who actually used to go to India to donate one of their kidneys to anyone who would want to have it, not a directed donation. However, there is emotional donors who are unrelated, like spouses or close friends and others. And then unfortunately there are transplantations that is done by people who actually sell their kidneys or do vending of their kidneys. So they're vendors. Cadaveric transplantation, of course, is heart beating and non-heart beating, and then there's xenotransplantation. So when the first transplant was done, I don't think everybody realized that it's the first time that a surgery is done for a benefit of somebody else. I mean, I'm sure somebody derives some kinds of psychological benefit when you donate the kidney, but actually for the physical aspect of kidney transplant, it's you go through a general anesthesia, you go through morbidity of the incision, you don't work for a few days, and then there is small risks involved over a period of time. But that's probably the only surgery that one does that has no direct physical benefit to the person that you're doing when the surgery is done. And so therefore the whole notion of how you actually accept this. So you're first you say, first do no harm. That's your first principle in such a way, is that you do something that, at least if you can't do anything else, at least do not do harm. So how do you go about asking somebody for doing it? And the only way that something is realized is that it does give you some psychological benefit. There is some greater benefit to the society. However, the person has to know why and how he's giving. So consent is essential. And of course, then there's a follow-up. Consent, asking somebody to donate a kidney or to give some kidney to somebody else, it's not just asking a kidney. It goes through a much better understanding of how it's done. When you're asking somebody to consent, he has to make that decision without any inducement or coercion or any other things, which is very difficult. I mean, even in related donations, it's extremely difficult to because many living related, if my child is unwell and somebody asks me to donate, I don't go through the sequence of understanding the rationale of what's likely, what is the benefit, what's going to be the harm. I make a decision very, very quickly. And also, if you have family pressures, for example, in live related donations, that makes a lot of difference. And therefore, you can realize in Pakistan, if you see all the figures that everybody use today, there is always the recipients is always, or most often, is male. And and if you look at the donors, I mean, unfortunately, if you look at the donor list, most donors would be women. There are some men, but the last study that I looked at, most men donate to men and most women donate to men and women. So autonomous decision making has to be not controlled by other aspects, which is utopian. You can't achieve that, but there is always going to be some influence. However, the acceptance of donation is that it is somebody's individual right to decide what one needs to do. So if you go through the consent process of somebody deciding, you have to have competence, you have to have relevant information, which is disclosure. Somebody has to have the understanding to understand what it means, and then the freedom to choose without any coercion. And then eventually you sign a document which says that you can do it. So for donors, whether living or unrelated donors, there has always been this issue of the concern of the validity of the consent itself. Because it is always under control of something else. So it's either relatives, or it's financial, or it's the need to protect your child, or you to give something else. And the degree of understanding that a donor has about what they are actually entailing and what is going to be the long-term consequences. So concerns have always been there. However, because it is considered to be a good act, it gives you a good results at the end. So both people are then, in some case happy, but it's slightly different when there is vending involved. So if you don't have living relations, and there are a lot of people who either don't have relations, or people who are donors who do not want to donate, or relatives who do not want to donate, then what do you do? Unfortunately, over a period of time, there is a lot of issues related to what I call vending of organs, or people who actually give their kidneys for remuneration. So they get some money and they give the kidneys. So there are enough people to sell, and this is my own emails that you can see that how people have responded over a period of time. They give you your age, they'll give you your blood group, they'll leave you a telephone number to call back. They somehow also get my phone. I don't know how they get it, and they say I'm an O positive, I'm good health. Can you help me? I want to donate the kidney. This is my own cell phone, and of course you've seen all this. So there is a rickshaw which says, I want to sell my kidney, my blood group is A positive. And then there are these pictures that you see, not only from Pakistan, but at one time from Philippines and other areas where you see large numbers of vendors who have given their kidneys, and they are showing that. There has been a large documentary from CNN. I don't know how many of you seen it. It's known as The Cruel Cut. It's an Australian gentleman who wants to buy a kidney from Pakistan, and there are many others like this. I think there is a book out by Dr. Farhat Moazzam on then she's done an ethnographic studies of all the vendors from the areas that I mentioned outside Karachi. So this is I was sitting in a lounge in Aga Khan once when I used to work at Aga Khan having tea, and somebody came in and gave me this note. I don't think anyone can read this note, but you can see that there are 3 things written. I want some money. They want money for his daughter who's getting married, and he wants to have a dowry, which is unfortunately something that you give to the bride when you're getting married, and it's a social stigma if you can't give enough things to the thing. So this is in the thing. But I've also had a gentleman who came in, he said, I want to donate my kidney and I want to sell it. I said, why? He said, I want to buy a motorcycle. So there are from dowry to getting out of bonded labor, there are also a spectrum of people who want to sell because they want to have other things in life. If you look at, and this is very old now, I think you can also, it's 2005 and 6. If you look at that period where you had the transplants at that time, suddenly there was a boost of transplant in 2006. Or from 2006 onward, and you can see that these are all, a large number of it was in the live unrelated transplantations, and a huge numbers were related to what were not Pakistanis. So there were people who were coming from Arabia, Saudi Arabia, and from Gulf countries, from Oman and other places who would come in. In fact, there was a hospital in northern parts of Pakistan which actually had an Arab floor, which had an Arab SAT. The nurses used to speak Arabic. It was easy, convenient. They would come in, they would have a transplant and then go back. So, and this is a slide that I took from, I think, from Fazl. And if you can look at the sources, and this is source from was the supplier of Santamune at that time, only Novartis, who was selling their products to different institutions. And you can see that the purple one is for those that are unrelated, and the yellow ones are the ones for that was related. So the largest amount of cyclosporin was being sold to that. So you can see there was a large number. An interesting slide is from Nabil from Oman, who used to see patients coming back to, after a transplant, coming back to Oman, and from where they got their transplant. So if you can look, if you see for the first part from up to 94, most of his patients who came back to Oman and he was following them were from India. And then Indian legislation came. And after the legislation, the large number of people started coming from Iraq. And then George W. Bush invaded Iraq and everything else fell through. And so the market shifted, and then it started coming from Pakistan. So the shifting sands, as somebody called it, is where you have the availability of the donor, and because of geopolitical situation or poverty and other things. So India, Iraq, Pakistan, and I think now, fortunately, at least the transplants that are people coming from the Gulf country to get transplant is, in my opinion, minimal right now. I don't know. I'm sure there's some still going on, but it's not in that large thing. So why do people have to sell kidneys? Unfortunately, the largest number of people who sell kidney are in bonded labors. So here we are telling them not to sell their kidneys, not to do things. But these are people who have taken a loan from the landlord, very small amount, 25,000, 50,000 rupees, and for basically for the health or something else. and then it is the interest is accrued, and they keep on paying the interest by actually working there. Their family gets involved, the family is also involved. So bonded labor is one of the bane of society that we have, and that's one of the things that they want to do. Unfortunately, when they get that, they try to get out of bonded labor, they still don't, because they still get that thing. The other most common is, of course, again, a social evil is about dowry. And the third one is the major thing is about treatment for other children or for something else. Somebody had wanted to have the child needed a bone marrow transplant. He needed the money, so the father was ready to sell his kidney to get that, and of course to buy small things like I said, motorcycle or something else. So does it actually help the vendor or the donor? Short term, it may. You get some money, you can get something done, but very soon they go back into their unfortunate situation again. So among the paid donors selling a kidney, long-term benefit was minimal. They all said their health declined. I don't think there would be any reason for a physical decline in health, but I think emotional decline in health was quite high. So if you look at first we said, it's very difficult to get a consent. You do something to a donor or a vendor which doesn't need the surgery, then there's difficulty in consent. But also it doesn't have the part of justice is not there too. Justice means fair, equitable, or appropriate treatment in light of what is due or to loved ones. Because unfortunately, if you are buying and selling, then the people who would sell will always be poor, and the people who would always get the kidney will always be rich. It cannot be the other way around. So no rich man is going to sell his kidney. So and it happens not in Pakistan. It also happens from Singapore and other places. I have 3 patients who have their secretary and who is so indebted to their family that he was willing to give his kidney. And I'm sure money must have been exchanged, or something must have been exchanged. It just can't be that a secretary would be willing to give his kidneys. So these are the receipts that I used to see at that time. And this is a payment receipt. I've taken out the numbers and I've blurred the things from Abu Dhabi for a person who had a transplant in Pakistan. So the Abu Dhabi consulate had said that they were going to pay the money and it didn't say transplant. It actually says slightly something different. It says, I think, for treatment for kidney disease or something like that, because they didn't want to put the word transplant and then you have buying and selling. So Iran has tried a model. The Iran model is basically, what they have done is taken out the middleman. So they've made a society or an NGO, government-based NGO, that actually does the middleman part. So they get the money or they give the money to the donor or the vendor, and they don't do any foreigners. So it has to be local. They have to be there. The donor gets insurance. The donor gets everything else, including some money. So what they've done is try to get rid of the middleman, because middlemen in Pakistan are the ones that make most money. Or not most, but they make large amounts of money, and it's, as I said, it's controlled by that. They get about a bonus of about $12,000. This is a long time back. I don't know what they do now, for a period of absence from work. Also, the recipient has his own way which pays some money for compensation, which normally they do. For those who wanted to donate to an underage, the government gives cash. They give a lot of things. They look at the follow-up and they try to do everything else. However, when somebody actually looked at what happens, everybody said if they had another chance, 85% said definitely they would not vend again. And 75% strongly discouraged potential vendors from treating. Half the vendors were ready to lose greater than 10 years of life, and 76% to 100% of their properties to regain back their kidneys. So there's some kind of guilt involved in that, I think, because that's what they think. So they do give it, they are taken care of, but there is a lot of things. I don't know whether we've actually done a study on related donors. So we don't know what they feel after some time and why they donated, because there's also this big pressure of why people donate in the kidney. So the actual dilemma, I think, is not the dilemma from the patient, it's the doctor's dilemma. Because physicians should not be just mere instruments of patients' wishes. So just because everybody is willing and they've given a consent, also the moral agent should be held accountable to their actions. So therefore, The real dilemma is the living organ is not simply whether the subject's choice is reasonable. It is whether the doctor is morally justified in helping the subject accomplish it. So whether we actually think vending and things are acceptable to us or not, because people would still sell, whether we would agree to help them do that, this thing. I hope this is I think it's 1960, where actually blood donation was controlled by individuals who used to sell blood, used to get donors to sell. Blood donation was clearly just by, you could give money, and I think the money wasn't large at that time, 175 rupees for one bag, which was at that time probably about $1, $2 at that time, or $3 at that time. But fortunately, that part in many large in cities have now disappeared. So I'm presuming, and it had the kidney vending also had come down, and I think it's still down, but it's still surfacing again. So I thank you very much for your kind words, suggestions.
Thank you very much, Dr. Asim, for this excellent presentation of legal and ethical aspects of renal transplant. We'll have the questions after the session.
Thank you so much, sir, for your valuable time. Now I would like to invite our guest of honor of this symposium, Professor Lionel Rostaing, who has traveled from France to attend this symposium and to enlighten us with his valuable work.
Professor Rostaing is a well-known nephrologist from Grenoble University Hospital, France. He has expertise in renal transplantation and immunology. He possesses a deep understanding of difficult aspects of renal transplant, and he loves to share his experiences. Also, he's a very good teacher. A big round of applause for Dr. Rostaing.
Assalamu alaikum. Good morning. First of all, I would like to warmly thank Dr. Tassaduk and Dr. Rashid for inviting me to this second international symposium. It's always a pleasure for me to be in Pakistan. And well, I have good friends in Pakistan, and this is a real pleasure for me to come here, especially with my mentee, Dr. Naveed. The first talk will be dedicated to HLA-incompatible kidney transplantation. So, is it a very weird idea for Pakistan? Indeed, it has some risk regarding the amount of immunosuppression we are giving to these patients, but very often here you will have some shortages of potential living donors, because you have a lot of sensitized patients, HLA-sensitized patients, and maybe you may be facing with these HLA-incompatible kidney transplants. So we have two types of patients who are very high immunological risks. First of all, those who are ABO incompatible, and so this afternoon in the last session there will be two presentations, one by Dr. Naveed and one by myself, regarding ABO incompatible transplantation, and this is feasible. This is already achieved in Pakistan, at least in one center. And secondly, HLA incompatible. So what is it, HLA incompatible? You may be HLA sensitized against a lot of HLA antigens, but without any specific donor, without any specific antibodies against the donor. And so in this case, it's not HLA incompatibility. So we have to differentiate to be HLA sensitized versus to have donor-specific alloantibodies. And desensitization will be only for those patients who have donor-specific antibodies pre-transplant. So this is a study that we conducted in France some years ago, showing that those patients who have very high PRA, greater than 80%, but without DSA, according to the type of induction, if the induction is to be with IL-2 receptor blockers, daclizumab in this case, you've got twofold higher rate of acute rejection as compared to having ATG induction therapy. So it means that when you are HLA sensitized, even though without any DSA, you are more prone to having acute rejections post-transplant. Okay, so in 2023, the way to assess HLA incompatibility goes through the good definition of anti-HLA antibodies by using the Luminex platform, which is very sensitive in order to pick up very low levels of donor-specific antibodies that might rebound post-transplant and might end up with acute rejection. And there is a good correlation between the MFIs of DSA and the positivity of a CDC cross-match or the flow cross-match. So indeed, the rationale for having HLA incompatible transplantation is for those countries in which there are no swap programs or only living donor programs. And so therefore, it's very difficult in some cases to have a suitable living donor. Conversely, when we have a deceased kidney transplant program, it's slightly easier to find a suitable deceased donor. But sometimes patients are so HLA sensitized that they will never have a deceased donor. And in those cases, we can desensitize them, and thereafter, they lose for a while their anti-HLA antibodies, and we can offer them a deceased donor kidney transplant. It's what we're doing in my center. Okay, so first of all, we have to differentiate having high CPRA or high PRA versus having donor-specific alloantibodies. And this study was conducted in Switzerland some years ago, and the patients were classified according to PRA level pre-transplant, 0, 1 to 50, and above 50, and having or not having, in addition, donor-specific alloantibodies. And if they were to have DSA pre-transplant, they were induced with ATG, and they were treated with rituximab in addition to that and IVIG. And what is very interesting is that regarding the incidence of TCM or T-cell mediated rejection, this is the right panel, you see that regardless of the level of PRA, the acute rejection rate T-cell mediated is actually similar. Conversely, so it means that providing you've got a good induction therapy, the acute rejection rate or T-cell mediated rate is similar across PRA strains. Conversely, with regards to the incidence of antibody-mediated rejection, PRA has no importance. The only important factor resides in having or not having pre-transplant donor-specific alloantibody. And so you have to differentiate having high PRA versus having a single or multiple DSAs pre-transplant. And with regards to graft survival, you can see a graft survival rate was very similar across the PRA strains. No difference at all. Conversely, if you were to have a DSA pre-transplant, even though you induce a patient with ATG, PER4, IVIG, rituximab, and so forth, the graft survival is significantly lower. So we have to keep that in mind. Okay, so indeed, if you want to have a state-of-the-art for HLA incompatible transplant, you need to have a Luminex platform first. And secondly, you need to have very good transplant immunologists in order to interpret in the right way the results given by the Luminex platform. Otherwise, if it's not possible or too costly, you can rely on flow cytometry cross-match. If it's properly done, T cells, B cells, with or without DTT, this could be a surrogate for Luminex technology. So when we have DSA pre-transplant, the question that arises is it worth the risk of desensitizing this patient? And this is an editorial that I wrote with my friend Paolo Malvezzi some years ago in the New England Journal of Medicine. And in those days, the question was is it worth the risk to desensitize these HLA incompatible patients who have a CDC positive cross-match pre-transplant? And recently, we published this review paper on the various techniques we have to desensitize cross-match positive kidney transplant candidates. And so I will review with you some of these means we have to desensitize the patients. But as I said a few minutes back, the CDC cross-match indeed is mandatory. This is very specific, but not sensitive enough in some patients. Why? Because some patients might have been sensitized by previous pregnancies, previous transplants, previous blood transfusions, and indeed they have donor-specific antibodies, but at the very low level, and this low level of antibodies will not be picked up by the CDC cross-match. Conversely, They will be picked up by the Luminex technology, single antigen bead assay. And these antibodies are very harmful. And they result, if they are not taken into account, they result in delayed ABMR within a few days post-transplant. And indeed, to make the cross-match more sensitive, you can use the flow cytometry cross-match that indeed is much more sensitive. And when we have pre-transplant donor-specific antibodies, they might or might not bind complement. And if they do so, indeed, they will result in hyperacute rejection, if not eliminated. So you have a kidney transplant candidate. He or she has donor-specific alloantibodies because it was sorted out even because the CDC cross-match is positive, or because the flow cross-match is positive, or because you've got the SAB test that tells you that there are DSA around. So what can you do? So first of all, we have to bear in mind this meta-analysis that was performed some years ago, dealing with patients having a negative CDC cross-match, a negative flow cross-match, but having indeed pre-transplant DSA as detected by Luminex platform. And if nothing is attempted, and in those series of patients, nothing was attempted, it was shown that the risk of ABMR was almost twofold, and the risk of graft loss is almost also twofold. So it means that if you do not take into account these low levels of DSA pre-transplant that are picked up by Luminex platform, this might result in poorer outcomes. Okay, so what has been shown within the last 10 years is that if you have a DSA pre-transplant with a mean fluorescence intensity greater than 1,000, as evidenced by the SAB test, you have to have on board rituximab therapy pre-transplant in order to avoid the rebound of that DSA post-transplant. And immunosuppression should rely in those cases on ATG and TAC, MPA, and steroids. So the first evidence that there was a survival benefit for desensitization was evidenced by this paper from the New England Journal of Medicine in 2016. It's a series of patients of more than 1,000 living kidney transplant recipients in the US that had CDC positive cross-matches, that they were desensitized with various regimes, including PLEX, rituximab, IVIG. And their survival is there. This is the yellow curve, as compared to the orange curve, which is the survival for patients who were placed on the kidney waiting list and that were subsequently transplanted, as compared to the blue curve that were those patients on the kidney waiting list that remained on hemodialysis at the end of the study period. So there was a survival benefit. And this was not duplicated by this UK analysis. However, in the UK, because the quality of hemodialysis in the UK is superior to that in the US, they found that those patients who were HLA desensitized in blue had the same survival as compared to those who were not desensitized. And the survival of the patients who were remaining on the kidney waiting list was slightly poorer, but there was not a huge difference as compared to the US data. Sorry. So how can we desensitize? We're going to focus on living kidney donors. So we can desensitize by using IVIG rituximab, which is the UCLA protocol, or we can use our protocol, which is based on apheresis, rituximab, and standard immunosuppression. However, before addressing these two main protocols, I would focus on IVIG, because many centers are using IVIG to desensitize patients, but it's absolutely, thank you so much, non-efficient. So, thank you. So this is a study from, So this is a study from Johns Hopkins Hospital on the right side, recent paper, recent, 10 years back. So they took patients who had a CPRA of 100%. It means that they are sensitized against everything except themselves. And so these patients were given huge amounts of IVIG, 2 grams per kilogram every month for 4 months. And when you look at class 1A panel or class 2B panels, anti-HLA antibodies, there was no decrease at all in the antibodies. So IVIG alone, it's pointless. It's too expensive and useless. Conversely, if you were to use IVIG plus rituximab, this is the UCLA experience. On the upper panel, you see that almost all the patients had a significant decrease in PRA. Okay, so it's more efficient. And the same group has conducted a limited randomized control trial in highly sensitized patients. They were desensitized either with IVIG rituximab or IVIG without rituximab, and the study was stopped after 15 patients had been included because in the no rituximab arm, post-transplant, there are high risk of ABMR. And so what is really efficient in this protocol is having rituximab on board. And in their series of patients, a huge number of patients, they found that those patients who were desensitized had a very good patient graft survival, even though 1/3 of them had at some point ABMR that was easily reversible. But in fact, we can use apheresis in addition to that. It makes the things easier. And so with regards to apheresis, we can use a plasma exchange, conventional one, filtration or centrifugation. We can use, it's not available, I know, in Pakistan, double filtration plasmapheresis, which is at least twice as much efficient as plasma exchange at removing IgGs, IgMs. And we can use semi-specific immunoadsorption, which is using columns that trap IgGs mostly. And indeed, it's very efficient at removing the anti-HLA antibodies. And so this is the type of circuit that we have. So the patient is on the right side, or to the right side. You've got a centrifuge machine to separate out the blood from the plasma. And then the plasma is going onto the first filter, which will be trapping some IgGs and IgMs. And then it goes to these 2 tiny columns here that work into tandem. When once is working, the other one is rinsing. And so the plasma is desaturated from IgGs, and thereafter the plasma is going back to the patient. And after a few sessions, as such, because the columns are reusable, the patient will get rid of anti-HLA antibodies. Okay. So we do as such in the setting of living donation when the recipient has donor-specific antibodies. So we start with immunoadsorption, then rituximab plus immunosuppression, and then the number of immunoadsorption sessions is according to the decrease in the anti-HLA antibodies. Yeah. Okay, so the proof of concept was that patient in 2012. So the patient was highly sensitized against class 1 upper panel and class 2 antibodies, and the threshold we want to achieve retransplant is below 2,000, okay. And it was submitted to immunoadsorption only. And so you can see that there was some effect on the DSAs, but not that much. We start, there was a huge rebound, and then we came with rituximab, immunosuppression, and immunoadsorption, and after a few weeks, 2 or 3 weeks, the anti-HLA antibodies have gone, and the patient was successfully transplanted, and is doing fine 11 years later. Okay. Is tocilizumab active at desensitization? Well, IL-6 is a pleiotropic cytokine that targets the T cells, B cells, plasma cells. It's a pro-inflammatory cytokine. And the assumption is that if you target IL-6 pathways, you will reduce the synthesis of anti-HLA antibodies. And to try and demonstrate that, we took 10 kidney transplant candidates who were not, this is the study from Stanley Jordan. It's not our study. So 10 kidney transplant candidates were unresponsive to IVIG and rituximab. They were submitted to tocilizumab, and at the end of the day, 5 patients responded and were subsequently transplanted. So we did the same work, but without IVIG, without rituximab, tocilizumab only, monotherapy, monthly infusion for at least 6 months. And we found that it did not change at all the anti-HLA antibodies profile. However, there was a huge immune modulation on B cells and plasma cells, as we evidenced that in the blood of these patients. And when we came later on with our protocol, rituximab immunoadsorption, the patients were easily desensitized. So it means that blocking IL-6 pathway is a sensitizer to having a very efficient subsequent desensitization. So a few words about a drug, imlifidase. Imlifidase, it's an IgG degrading enzyme. And that enzyme has a property to cleave the IgGs, and within 1 or 2 hours after the infusion of the drug, the IgGs are disappearing for 1 or 2 weeks. And it's very interesting in single-hit diseases such as good posture disease, and which made a European study that was published in JASN 1 year back, 2 years back, demonstrating that in good posture syndrome, a single shot of imlifidase was able to improve these patients, and they almost all recovered. It's currently in phase 2 trial for Guillain-Barré syndrome, which is a single-hit disease. And it has been tested in acute ABMR, and the results are still pending. And in 2020, the imlifidase has been approved by EMEA for deceased, to desensitize deceased donor kidney transplant patients. So this is the first evidence in humans that imlifidase was efficient at reducing IgG levels in patients who had CDC positive cross-matches pre-transplant. As you can see, within 2 hours, there are no IgGs, and therefore the CDC cross-match becomes negative, and the patients were subsequently transplanted. However, there is a rebound after 2 weeks, and some patients will have at this point ABMR. So these are the Luminex results, anti-HLA class 1 in red before imlifidase, in blue after imlifidase. The threshold is 1,000, and all the antibodies became negative. For class 2, the same pattern in red before, and in blue, you cannot see it, it's after. It has gone for a while. And post-transplant, as you can see, these are the DSA levels in those patients who were submitted to imlifidase. For a week, there are no DSA around, but in some patients, you see there is a rebound of DSA post-transplant, and we have to deal with that. Okay, so just to finish with, our experience in desensitization in my center. And so far, we have been desensitizing more than 45 patients, but when we made this publication 2 years back, there were only 36 patients. So this is the patient survival in blue, those who were HLA desensitized. In green, those who were HLA sensitized, but who have had an HLA-compatible transplant. And in red, those who were on the deceased kidney waiting list. As you can see, there is no harm with desensitization. That is, patient survival is absolutely similar. And with regards to the DSAs in those patients who were desensitized, 36 in those days. So you see the mean DSA values, class 1 and class 2, before transplant. The day of transplant, it's nil. And post-transplant, 1 year later, some patients have a rebound, but most of them have no rebound. So it works. So to conclude, HLA incompatible transplant is worth a risk. To give an answer to my editorial 7 years back. Desensitization is based on rituximab, and you have to have rituximab on board, otherwise it's not efficient. Apheresis is very helpful. IVIG, forget them, it's pointless, it's expensive, and it's useless. Tocilizumab is a primer to desensitization, it helps a lot. And the place of imlifidase, which is a very costly drug, remains to be determined. Thank you for your attention. This is a view of my city and the Alps in the back. Thank you.
Thank you, Dr. Rostaing. So I reckon we are already running a bit late, so we'll go through this session very quickly. We'll move in the order in which the presentation was made. So we'll ask you to, first of all, identify yourself, your workplace, and So the first speaker was Dr. Naranjan Lal. Any questions for Dr. Naranjan Lal? So, yep.
Well, it was with the renal vein thrombosis, and there was a urine leak as well. So patient went into the sepsis, and we were not able to recover it.
How soon after the transplant did he die?
Actually, it happened on the around after 1 week.
And how soon after the transplant the person had renal artery stenosis? One of your patients had renal artery stenosis.
One of
your patients had renal artery stenosis.
Yes, the renal artery stenosis was on third day of the transplant.
Third day.
Third day of the transplant.
Any questions? Any more questions? So we'll move on to the next speaker, Dr. Sunil Kumar. Any questions for Dr. Sunil Kumar? I think he made a very relevant presentation. Any questions? Dr. Sunil, my question would be, in your experience or your studies you have done, would you suggest or could you find any correlation between the etiology of infection and time relation, duration after transplantation? You mentioned about infective and non-infective causes. So for a clinician, would you suggest or could you find any correlation between the etiology of infection and the duration of transplant?
No.
One would expect infective complication early on and the...
So amongst diarrhea, actually infectious causes usually depends when they leave their, because at SIUT when we transplant them, they usually stay in Karachi for say around 6 months, 3 to 6 months. So their drinking habits are good actually. Their eating habits are also good. But once they leave this place and goes to their native towns and which belongs to very rural areas, they may not get they say when we ask them to boil a water, they say okay, we don't have gas yet. We usually use wood for making foods. So probably from a diarrhea point of view, it depends upon from far away from transplant. That's why our median duration in our study was 78 months from transplant, when the patient usually came with diarrhea. Other complications, because the other complications are those complications which depends upon immunosuppression. Diarrhea is one of those complications which don't depends upon immunosuppression. It usually depends upon their eating habits and their drinking habits. That's why. So we don't find any correlation.
So any other question? So we move on to the third speaker.
So any conclusion remarks from the chair of the panel of experts, please, Dr. Osmani Saab.
Okay, since there's no questions, we would like to conclude this session. Before concluding, I will have the...
Thank you very much for this first session. Now I would like to invite our chief guest, Professor Saeed Ahmed Qureshi, to please, sir, come on front. And we'll start our prize shield distribution.
Now I would like to call Professor Aisha Hassan. Sorry, apologies. I would like to call upon Professor Saeed Qureshi, our Vice Chancellor, DUHS, to please come on stage.
Now we are beginning our shield distribution ceremony.
First, I request Professor M.H. Usmani from the panel to please come on stage and receive your shield. Next, I would like to call upon Dr. Bilal Jamil to please come on stage and receive your shield. Next, I would like to call upon Dr. Muhammad Khan Babar to please come on stage and receive your shield.
Now I would like to call Dr. Naranjan Lal to come on stage and receive his shield, please. Dr. Hamid Mehmood, please come on stage and receive your shield, sir. Professor Dr. Asim Ahmed, please come on stage and receive your shield, sir. Dr. Sunil Kumar, please come on stage and receive your shield, sir. Our guest of honor, Professor Lionel Rostaing, please come on stage and receive your shield. Dr. Ahmed Usmani, please give your concluding remarks and then we will take a tea break. Thank you so much, Professor Dr. Said Qureshi sir.
To conclude this session, I would have the following remarks. Since I am a Dow graduate of 1974 batch, very old one, so I'm proud to see this young team headed by Rashid and Tasadduk, who have done a wonderful job in a short period of time and limited resources in doing this tremendous amount of work in doing this transplant and arranging this symposium, for which I congratulate to every one of them. Thank you very much.
Thank you so much, sir. And we are extremely fortunate that the Vice Chancellor of the Dow University of Health Sciences, Professor Mohammad Said Qureshi, has joined us today as our chief guest. I would like to call upon His Eminence to the stage for his inaugural speech.
Professor Mohammad Said Qureshi, ladies and gentlemen, please put your hands together to welcome our esteemed guest of honor, Professor Mohammad Said Qureshi, Vice Chancellor, DUHS and Emeritorious Surgeon.
Bismillahirrahmanirrahim. Professor Rostaing is here, transplant faculty and other transplant surgeons, and ladies and gentlemen. I'm deeply honored to have been invited to speak at this session of the second International Kidney Transplant Symposium. This event is a testament to the incredible strides we have made in the field of healthcare, and more specifically in the realm of renal transplantation. The university is also involved in other aspects of transplantation, which include corneal transplantation, liver transplantation, and bone marrow transplantation. But of all of these, the renal transplant team, I think, is doing the best job. I extend a heartfelt thanks to you for being here today and being able to participate in this scientific meeting, which is dedicated to advancing knowledge and improving the lives of countless individuals. The Dow University has a long-standing tradition of providing healthcare delivery, and that started off with our facility here in the city, where the civil hospital, one of the largest hospitals of Pakistan, is located, and which has been providing healthcare to the indigent population of the city and province. I congratulate the Dow Renal Transplant team on having achieved nearly 600 transplants now. So I hope they keep on progressing and they keep on transplanting well. Ladies and gentlemen, the main problem in Pakistan is that cadaveric transplant has not taken off. A lot of effort has been put up, but to no avail. And people, due to religious reasons and other reasons as well, do not wish to donate their organs, which may be the kidney, the heart, or the liver. And with the current shortage of organs available in the market, we now need to move on and persuade people to will their organs so that transplantation becomes more available and becomes available and it benefits the people, rather than confining ourselves to taking out kidneys from one living person and putting it into another. So I hope you will have a good session discussing what are the advances and what needs to be done further to improve on. This is dedicated to renal transplantation, but I would say that to improve on transplantation as a whole. Thank you very much.
I request Professor Ahmed Usmani Saab to please come on stage and present the memento of the occasion to His Excellency Professor Saeed Qureshi Saab. Now, thank you so much, sir, for coming. Now we are commencing our second session. I would like to call upon our second panel of experts for today, Professor Abdul Manan Junejo, Dr. Farzana Adnan, and Dr. Sonia Yaqub.
Professor Abdul Manan Junejo is serving as Head of Nephrology, Jinnah Postgraduate Medical Center, Karachi, and we are proud that he has supervised our dear Dr. Tasadduq Khan. Dr. Farzana Adnan is serving as Consultant Nephrologist at Liaquat National Hospital, and I have the privilege of benefiting from her guidance during my residency training. Dr. Sonia Yaqub is serving as Section Head of Nephrology at Aga Khan University Hospital.
Now we are beginning our second scientific session of lectures, for which I would like to invite our first speaker, Dr. Khawar Abbas from SIUT, for his lecture on B-cell targeted therapy in renal transplants.
Ladies and gentlemen, please welcome Dr. Khawar Abbas, who is serving as a Chief Immunologist at Sindh Institute of Urology and Transplant, Karachi.
Thank you. So the topic of my presentation is targeting B cells and antibody-producing cells in transplantations. So in next 15 to 20 minutes, I would like to talk on these three things. So why and what should we target in transplantations, and what could be the specific mechanisms for targeting B cells and the antibody-producing plasma cells. So why and what should we target? So B cell, when become activated, differentiate into plasma cells, and the plasma cells produce antibodies. And just to remind you, the antibodies had two heavy chain and the two light chain, and the nature of the heavy chain can determine the antibody isotypes. And in case of IgG antibodies, is gamma heavy chain. And antibodies bind to the antigens by FAB regions, and in transplantation, most of the time it bind to the HLA, and sometimes non-HL like MIG-A and MIG-B. So what's important? Why these antibodies can cause pathology and have negative impact on graft survival? Because the antibodies can recruit a number of different immune responses. Via this FC region, they can activate the complement systems, and this FC gamma receptor, and this also engages the FC gamma receptors, and FC gamma receptors is expressed on neutrophils, monocytes, and then NK cells, and they take part in the antibody-dependent cell-mediated cytotoxicity. So B cell can also perform a lot of other important functions. B cells are the potent antigen presenting cells. They present antigens to the CD4 positive T cells, and the CD4 positive T cells are activated and produce a number of cytokines, the pro-inflammatory cytokines, IL-6 and TNF-alpha, and they also organizing the lymphoid follicles by producing things like lymphotoxin and VEGF. And on the flip side of the things, B cell also regulate the immune response. And we know that they do so by producing cytokines IL-10 and IL-35, and there is a contact-dependent mechanisms, PD-1 and PD-L1. The maturation and activation of the B lymphocyte occur in the secondary lymphoid organs, lymph nodes and spleen, and the T follicular cells are important for the maturation and activation of the T cells. And this is very nicely illustrated by Lakers. If you transplant a mice with allogenic heart, the wild type mice will develop the donor-specific antibodies. If you remove the spleen, mice will develop the donor-specific antibodies. If you remove the lymph nodes, mice will develop the antibodies. But if you remove the both lymph node and spleen, so there is no antibody. So these secondary lymphoid organs, lymph node or spleen, are critically important for the maturation and activation of the B cell. So B cell activation is a two-step process. In the first stage, B cell can recognize antigens with their BCR, B cell receptors. And then they activate and differentiate into plasma cells. And second signal we call co-stimulation. And there are two types of humoral response. On the right-hand side, the humoral immune response is against the non-protein antigens. And the second signal is provided by the macrophage or dendritic cells. And this is we call thymo-independent immune response. On this side, thymo-dependent immune response, we can talk about most of the time in transplantation. this type of immune response. In thymodependent immune response, this response is against the protein antigens, and the second signal is provided by the CD4 positive helper T cells. But that decision, it depends on other things. B cell can express and activating receptors, CD19, which form the B cell co-receptors, and CD21 actually tells the B cells that the complement systems are activated. So there are a lot of other signals that are activating and survival signal. And on the flip side of the thing, B cell also express the inhibitory receptors. Fc gamma, R2b, and CD22, both are inhibitory motifs. And when they encounter the antigens, they recruit the phosphatases, which slow down the downstream signaling pathway. So even then, the B cells can encounter the antigens. It's harder for the B cells to become activate. So there are two fate of the B cells. They become short-lived plasmablast and secrete low affinity of the antibodies, or they go form to the germinal center reactions with the help of the T follicular cells. And there are two things are important: co-stimulation and contact-dependent interactions. And the cytokines, which is secreted by the T follicular helper cell, IL-21, is important for the efficacy of the germinal center response. And the output is two things: memory B cells and the long-lived plasmablast. And we know that the long-lived plasmablast need to survive, and they need survival factors like IL-6, BAF, and EPRIN. And these survival factors are produced by a number of different cells like eosinophils, monocytes, and macrophages, and some of the stromal cells in the bone marrow. So summary, why and what should we target in transplantations, and what could be the specific mechanisms, therapeutic measures to eliminate these antibodies. So these are the potential therapeutic targets. For example, if the patient in front of us have no antibodies, are not sensitized, so our main target, our aim is to prevent the naive B cell activation. If the patient presents us with an acute ABMR or with de novo DSA, so our aim is to block this co-stimulation between T cells and B cells. If the patient is sensitized, have a donor-specific antibodies or the plasma cells, so we want to remove these plasma cells. So what is specific therapy we want to use? The most basic strategy to deplete B cell. And we can achieve in transplantations by using these monoclonal antibodies. They are used in B cell leukemia and lymphoma, the very well-known, famous rituximab, which can bind to the CD20. Then the ofatumumab, it's also bind to different epitope of the CD20, and the obinutuzumab is a type 2 CD20 monoclonal antibodies. It can remove B cells from peripheral circulation as well as from the lymph nodes. Then anti-CD19 antibodies bind to CD19, and on these sides, alemtuzumab, which is used in induction protocols, and aprotuzumab, which bind to CD22 on the B cells, and is less effective than rituximab in removing the B cells, peripheral B cells from the circulation. So rituximab used in ABO incompatible and HLA incompatible transplantation in treatment of the ABMR, and used as an induction agent in transplantation. So I just want to draw your attention on these three studies. They use rituximab as an induction agent. Two of them, Tiden and Bent and Hugen, used single dose of rituximab at day 0 of transplantations, and they found no significant difference in T-cell mediated rejection at 6 months post-transplant. And this group, Flower, they used 2 doses of rituximab at day 0 and day 7. And they found significantly very high number of T-cell acute rejection episodes, and they withdraw their study after this. Initially, they recruit 120 patients, but because of this high rate of acute T-cell mediated rejections, they discontinue these protocols. So this is the French prospective study on the effect of rituximab on acute antibody-mediated rejections. And this randomized study investigating 38 patients with active AMR in the first year after transplantations. And all patients received treatment with steroids, IVIG, and plasma exchange, and were randomized to either rituximab or placebo. And there was no significant difference in any outcome parameter except side effect in the rituximab group. There is another Spanish trial in chronic antibody-mediated rejections, and this patients were randomized to receive IVIG plus rituximab or IVIG plus saline infusions. And at 12 months, there were no difference between treatment and control group in terms of EGFR rate decline, level of proteinuria, and BANF score of biopsy or MFI of the immunodominant DSA. But this is the Cedar-Sinai group used rituximab in desensitization protocol with IVIG. And they candidates were randomized to IVIG plus placebo versus IVIG plus rituximab. And all acute antibody-mediation episodes occur in the IVIG groups, IVIG plus placebo group. And renal function at 12 months showed is significant benefits in IVIG plus rituximab group. So IVIG plus rituximab appear more effective in preventing DSA rebound and preventing acute antibody-mediated rejection and development of transplant glomerulopathy. So come to the other strategy, target BAF, which neutralize the BAF and inhibit the B cells activations. So increased BAF level are found in acute rejection episodes compared to the stable renal graft or in healthy control population. And BAF acts by its 3 receptors, and we have 3 antibodies. Belimumab and tebulumab are the anti-BAF antibodies, and etacicept, which bind to the one of the receptor, TACI1s. And their clinical trials in autoimmune disease and rheumatoid arthritis is going on. And the etacicept can decrease serum IgE level, and patients had because of this depression, because of this low level of the IgG, patient had more prone to infections. Belimumab second phase clinical trial is going on in human transplantation, so the hope for the best. So come to the middle sections, the co-stimulatory blocker between T cells and the T follicular cells. So the only co-stimulatory blocker that is approved in renal transplantation is the belatacept. Belatacept is the CTLA fusion proteins that can compete with CD28 binding to the B7 molecules CD80 and 86 on the antigen-presenting cells. So there are 2 large studies, benefit and benefit exit, and they compare the 2 doses of belatacept one-on-one with cyclosporin. And they found at 7 years of follow-up in belatacept group, the DSA was 6% compared to 21% in cyclosporin group. And EGFR in belatacept group was 62, and in cyclosporin group at 7 years of follow-up was 36.6. So very encouraging results of this. So now come to the final, plasma cell targetings. So we can directly target the plasma cells or some of the survival factors like IL-6 or some of the cells that produce these survival factors. So come to the direct targeting. The antibodies are basically the protein factories. They produce large amount of proteins, and this proteasome can deal this misfolded proteins. They recycle these proteins, and if you inhibit this proteasome with bortezomib, this misfolded proteins accumulate and cause apoptosis of the cell, apoptotic death of the cells. And this is bortezomib approved for multiple myeloma, for the treatment of multiple myeloma in 2003. And these are some studies. that use bortezomib in desensitization protocols and ABMR and found mixed results. And this is the only prospective trial of bortezomib in antibody-mediated kidney transplant rejections, and they found no significant difference between bortezomib and placebo-treated groups. And there is a lot of side effects reported with the bortezomib, especially bortezomib-induced peripheral neuropathy. So the second generation bortezomib are in proteasome inhibitors are in clinical trials. Carfilzomib, it's had release with better safety profile and reduction in the incidence of peripheral neuropathy compared with bortezomib. And this one, and exazomib, it's also used as it's in phase 2 clinical trials in desensitized patients and with a better safety profile. Now come to the survival factors, and I'm only discuss the IL-6. So the IL-6 and APRIL influence the growth and differentiation and survival of normal and neoplastic antibody-forming cells. So IL-6, interleukin-6 is a pro-inflammatory cytokine, important role in DSA generation. IL-6 stimulates B cell differentiation into plasma cells and increase the antibody production. And this suggests that anti-IL-6, IL-6 receptor blockade could be effective in modifying T and B cell responses to allograft. So tocilizumab, IL-6 blocker used in desensitization protocols. It's used in acute antibody-mediated rejections with a significant reduction in level of DSA, reduced inflammations and microvascular lesions, and stabilization of the renal function. And it can also use in chronic antibody-mediated rejections with the good results. Graft survival in tocilizumab-treated patient at 6 years compared to 30% is historic control. Now come to this IDES, imlifidase. Previously we known that IDES, it can cleave all 4 classes of the IgG into FAB and FC regions. FAB region retain its functions, bind to the antigens, but FC regions lost its functions, the complement-dependent cytotoxicity and antibody-dependent cytotoxicity. And it's used in desensitization protocol. And this is the French guideline for the use of this in sensitive CDC cross-match positive. They use this in positive cross-match become negative, and this is their follow-up protocol. And IVIG, it's very profound effects on the immune system, especially on the B cells. They inhibit the B cells. They cause apoptosis of the B cells. And IVIG also used in acute antibody-mediated rejections, in desensitization protocols, and ABA incompatible transplants. So in conclusions, B cell play an important role in immune response. An increasing number of therapeutic options that are available right now with target B cells, plasma cells, and related cytokines like IL-6. So understanding how to selectively control B cells that contribute to humoral response against donor HLA antigens. And this understanding can lead the improved long-term transplant outcome. Thank you very much.
Thank you so much, Dr. Khawar Abbas. Now we are moving towards the second lecture. I'm inviting Dr. Wakharuddin Kashif from South City Hospital to enlighten us on the topic of long-term effects of immunosuppression on transplant recipients.
Dr. Wakar is currently serving as consultant nephrologist at South City Hospital, Karachi, and an expert in critical care and transplant. He has also served at Khan University Hospital over a decade as section head of nephrology.
Assalamu alaikum. Thank you very much for having me today. For the next 20 minutes, I'm going to try and cover this topic of long-term immunosuppression, complications of long-term immunosuppression. So this is a very vast topic. I don't think 20 minutes can justify talking about it, but I'll try to summarize as much as I can. All right, so as multiple speakers previously have said this line that kidney transplantation is a treatment of choice for end-stage kidney disease. And that is because there is better survival, there's better quality of life, and in the long run, even in the private setting, it is more cost-effective when it is compared to long-term dialysis. And in the last 50 years, we have achieved this incredible success with acute graft function, preventing acute rejections. And there's over 90% graft survival at 1 year in most centers. And even the 5-year graft survival is now edging towards 90%, with an increase of about 10% every decade that we are seeing. If you want to, for those who like to look at graphs, this is the survival graphs of patients. This is European literature. The bottom line, the red one, is the transplants that were done in 80s and 90s, going to the green one, which is a decade later, and the most recent ones in the blue line. And as you can see, with successive decades, the outcome of long-term graft survivals have been improving regularly. And this is possible because we have robust immunosuppression. If you look at the timelines of immunosuppression back in the 50s and the 60s, we only had steroids and azathioprine, but then came along cyclosporin and tacrolimus, MMF, and then sirolimus and everolimus, and of course all the biological agents that my previous speaker, Dr. Khawar, was talking about. All of these have really helped us in maintaining short and long-term graft function. But this immunosuppression is not free of problems. It is a double-edged sword, which, yes, increases graft survival, but also has a lot of long-term side effects. So if you talk about major complications or major adverse effects of long-term immunosuppression, there's a long list. And I'll go from the bottom of the list to the top one. The last topic actually was the one that I spoke about on this very same forum last year, is chronic allograft nephropathy, which is chronic loss of graft because of fibrosis, and cyclosporin has been implicated in that, and tacrolimus as well. Cosmetic effects, mostly with steroids and antimetabolites, specifically azathioprine, skin changes, gingival hyperplasia, all of these issues we encounter in the long term. Mental health issues, steroids are notorious to cause psychosis, but in the long run, they have been implicated to cause anxiety disorders, depression, and even suicidal ideation in patients. So those are issues, again, that we encounter long-term. Bone disease is a very underappreciated aspect of long-term complication in transplant. This is something that we don't talk about very often, and I'm happy to see the program that Dr. Salman later on is going to be doing a full talk on bone disease in long-term transplant patients. Infections was partly touched upon in the previous talk, and I think Faisal Mehmood is here. He is going to be talking about some of the infections in long-term transplant complications, so I'm not going to spend too much time on that. So the two major things that I'm going to talk about in the next 15 to 20 minutes is cardiovascular disease and malignancies in transplantation, because these are the two major complications that these transplant patients beyond a decade of transplant face. So starting with cardiovascular disease in transplant patient, death with a functioning graft is the leading cause of graft loss in kidney transplant patients, and cardiovascular disease accounts for about 1/3 of known causes of these deaths. Even though transplantation reduces the cardiovascular disease risk compared to staying on dialysis, but when you compare to general population, the risk is still higher in all age groups, especially the younger ones. Cardiovascular disease not only only causes death, but also cause morbidity. So hospitalizations, almost 30% of the hospitalizations long-term for transplant patients is because of cardiovascular events, with a 4% associated mortality. So that's huge. If you look at, again, graphically, if you like to look at it, the top one, the green one, is hemodialysis patients, and the lower one is the general population. This is cardiovascular mortality rate over different age groups. And you can see here that in the youngest population, the 25 to say 45 years of age, this is where general population cardiovascular death risk is, and this is where almost a 10-fold, 100-fold increase in hemodialysis patients. Transplant patients are much better than the dialysis patients, but in the younger population, still a big gap between general population and transplant patients. So what are the cardiovascular risk factors? We have the traditional risk factors, which is hypertension, dyslipidemia, obesity, diabetes, smoking, family history of cardiovascular disease. And then we have transplant-specific risk factors in terms of immunosuppression and the treatments of acute allograft rejection in transplant patients. So if you look at individual immunosuppressants, they all have some effect, metabolic or otherwise, that increase risk of cardiovascular disease. For example, steroids have pretty much contribute in terms of developing hypertension, obesity, hypertriglyceridemia, hyperglycemia, dyslipidemia, all of this. Cyclosporin, notorious to cause hypertension, some dyslipidemia. Tacrolimus, again, hyperglycemia is the major issue with that. mTOR inhibitors, hyperglycemia, metabolic effects, dyslipidemia, hypertriglyceridemia, these are major effects. Belatacept and the antimetabolites are much better in this regard when it comes to increasing cardiovascular risk in patients who have long-term transplants. So the spectrum of disease that we see in patients, the cardiovascular disease, the spectrum of cardiovascular disease, these patients develop coronary artery disease, they develop CHF, they develop arrhythmias, especially atrial arrhythmias, which is implicated. Cyclosporin is implicated in that. And then pulmonary hypertension is also an under-recognized issue with patients who have long-term transplants. As I said, the recipients, when they are entering the transplant period, they already have high risk of cardiovascular disease, pre-existing risk because of having CKD and being on dialysis, but immunosuppressants again add somewhat more to this burden. Aggressive screening at the time of transplant for existing cardiovascular disease is very essential, and especially those who are already on dialysis and it's not a preemptive transplant, doing invasive investigations to look for subtle coronary artery disease is something that is warranted and recommended. So what do we do about these patients? We monitor them closely. If the goal for blood pressure is less than 130/90 in these patients, most of them should be on statins. There's already a lot of pill burden, so we shy away from treating hypercholesterolemia in patients a lot of times. But we have to understand that most of these patients die because of coronary artery disease, and this is something that needs to be aggressively treated. ACE inhibitors and ARBs, especially in diabetics who have a transplant, but even non-diabetics who have hypertension and no contraindication to ACE inhibitors and ARBs. I think we fear a lot about renal artery stenosis in renal transplant, and a lot of people shy away from putting them on ACE and ARBs. But this is something that should be, each and every patient should be assessed if they will tolerate ACE inhibitors and ARBs, because they have been shown to slow progression of kidney disease even in transplant patients. Smoking is like adding fuel to fire. So extensive counseling, pre-transplant, post-transplant for smoking cessation is essentially important. If you look at individual immunosuppressants and what to do with them, the first thing is to know what their side effects are, which immunosuppressants cause what, which cause proteinuria, which cause hypertriglyceridemia, which cause hypertension, and then avoiding those or minimizing those as much as possible. We have steroid-free protocols or early steroid withdrawal protocols for those who have difficult to control diabetes. Similarly, patients who have difficult to control cholesterols, avoiding mTOR inhibitors in them. So the knowledge of what the side effects are in the long run and tailoring the the immunosuppressive agents accordingly is essential. Switching gears, I'm going to talk now about post-transplant malignancies, the other big thing. Cancer is the most feared complication. Although cardiovascular disease may be the leading cause of death in patients, but cancers, because of immunosuppressants, is something which a lot of physicians and patients fear about. It is the second leading cause of death. After CVD, excess risk of cancer after transplantation is approximately 2 to 3-fold, which is huge compared to age and sex matched general population. The increased risk of de novo transplant or recurrent cancers, de novo cancers and recurrent cancers in transplant recipients is multifactorial and attributed to the oncogenic viruses and altered T cell immunity. Again, it's great to have potent immunosuppressants to avoid rejections and increasing early transplant survivals. But in the long run, the effect of these on immunity really translates into not just infections, but malignancies as well. Once cancer develops, outcomes are generally poor in patients with transplants, especially those with melanomas, renal cell carcinoma, and PTLD. Effective screening and treatment strategies are limited. Not a lot of studies are available. If you look at the epidemiology of these malignancies, cumulative incidence of solid organ cancers beyond 15 years of transplants is about 10 to 15%. That's a huge number. And when it goes to those few patients who have transplants for more than 20 years, this cumulative incidence can go up to as high as 25%. The magnitude of the risk of higher risk is also dependent on the cancer types. The greatest risks are with viral-associated cancers such as PTLD, anogenital cancers, and Kaposi's sarcoma. Data from the non-Western, Middle Eastern, and Asian cohorts show that there is higher incidence of urothelial transitional cell carcinomas, renal cell carcinomas, as well as GI malignancies. There was a study from Taiwan which showed actually a liver cancer incidence of more than 4 to 5-fold compared to the general population. Hepatitis B and C are endemic in these areas, and that is the reason for this high. So depending on the area, the risk factors in that area, the malignancy patterns can be different. So this is, I find this a very interesting slide. So this is talking about standardized incidence ratios of different types of cancer. So compared to the general population, which would be 1, there is like 60-fold increase of Kaposi's sarcoma. And this is age and sex matched. Interestingly, the most common cancers, solid organ cancers, which are breast cancers and prostate cancers, are actually not higher incidence in patients with transplants. It is, and you can imagine, these are all the cancers which are immune-mediated cancers, oncogenic viruses causing cancers, and they are the ones which occupy the top of this list. And if you look at death, standardized mortality ratios, and the size of the circle represents the absolute risk of dying from cancer compared to the general population. You can see here the breast and prostate cancers, even colorectal and lung cancers are not as fatal in these patients compared to lymphomas and renal cell carcinomas and melanomas. So again, the patterns of these cancers need to be recognized because screening needs to be accordingly, treatment aggressiveness needs to be accordingly. So this is what happens when you do immunosuppression. There are multiple pathways that are dampened by immunosuppressants, And this dampening of these pathways lead to a variety of ways why the tumors progress. Poor immune control of known oncogenic viruses is what the problem is. So several pathways lead to decreased tumor surveillance, decreased viral immunity and tumors, and anti-tumor responses are also diminished, which all lead to development and progression of cancers. And if you look at calcineurin inhibitors specifically, they increase VEGF, which increases angiogenesis. They increase TGF-beta, which increases tumor growth. They also cause, there's an increase in RAS and RAF signaling, which increases the growth of renal cell carcinomas. They increase tumor interleukin-6, which causes B-cell proliferation and leads to PTLD, and they inhibit DNA repair. So when we talk about DNA repair, cyclosporins is capable of inhibiting DNA repair, thereby accumulating mutations in the DNA, which induce apoptosis in activated T cells. And they also inhibit apoptosis in other cells, which opens mitochondrial permeability transition pores, which lead to tumor genesis. Other drugs that are implicated other than cyclosporin, the big one is azathioprine. It sensitizes the skin to UVA radiation and causes accumulation of 6-thioguanine in the DNA, leading to a high risk of non-melanoma skin cancers. Induction therapy with T-cell depleting agents is also known to lead to or associated with risk of cancer such as PTLD and melanoma. These are the oncogenic viruses that I've been talking about. Epstein-Barr virus causes PTLD. Human herpes virus 8 is associated with Kaposi sarcoma and lymphomas. HPV is associated with head and neck cancers, skin cancers, cervical, vulval, and penile cancers. Hepatitis B and C, of course, is associated with hepatocellular carcinoma, and Merkel cell polyoma virus is associated with Merkel cell lymphoma. Again, this is all, these are all associations, and suppression of immunity leading to proliferation of these viruses is what leads to these malignancies. Recurrence of prior cancers is also an issue, and it is observed higher risk is further augmented by poor surveillance and poor screening of these patients post-transplant. We need to screen patients pre-transplant for underlying malignancies. Both donors and recipients need to be screened, and there are available guidelines for what type of screening for what type of cancer should be done. If a potential transplant recipient is diagnosed with a cancer pre-transplant, there is a waiting time after remission, and it depends on the aggressiveness of the cancer. If the cancer is less aggressive, then 2 years waiting time is usually enough. But if the cancer is more aggressive, then up to 5 years. And there are certain cancer stages in which transplant is contraindicated for life, such as thyroid, advanced stage thyroid cancer and advanced stage melanomas. Transplants are prohibited for life. Post-transplant screening usually depends on risk factors and based on regional guidelines as to what cancers are more prevalent, and according to the risk factors. For example, patients who have underlying cirrhosis, they need an alpha-fetoprotein screening every 6 months. But most of the other guidelines are based on general population and extrapolated from there. How do we manage these patients? CNIs are the big ones to be aware of. They need to be taken off CNI or minimized on CNIs. mTOR inhibitors, sirolimus and everolimus, have shown to be anti-tumor activity or anti-angiogenic activity. So those should be used in patients who have been diagnosed with cancer. The decision to reduce or stop immunosuppression has to be, it has to be balanced with the risk of graft loss and life lost because of the transplant. It has to be a choice that has to be individualized to patients, and every patient needs to be assessed as to what. Okay, time? Okay. Okay, just one or two more slides actually. So For established cancers like PTLD and Kaposi sarcoma, reducing immunosuppression has been shown to be enough to cure these cancers. Several case series have shown Kaposi sarcoma response when you switch them over to sirolimus or everolimus. So these are drugs to be used. There's no data to support stopping immunosuppression in prostate, breast, ovarian cancers, and other solid organ tumors. So the complications of immunosuppression and the complications of chemotherapy also need to be taken into account. Whatever chemotherapy they are getting, there are complications for that, and you might want to reduce immunosuppression just for that sake. Just to summarize, in the end, there's a 2 to 4-fold increase in cancers in transplant patients. Oncogenic viruses and immunosuppressants are what the cause is, and waiting period for 2 to 5 years depending on what cancer, and cancer screening should be tailored according to the regional and patient risk factors, and reduction of immunosuppression and standard treatment of cancers is something that is recommended in these patients. I will stop here. Thank you very much.
Thank you so much, Dr. Khawar. That was a very wonderful lecture, and we all know that you are a wonderful teacher. Thank you so much for being here. For the third lecture of the session, I would like to invite on stage our respected Chief Transplant Nephrologist, Dr. Mohammad Tasadduq Khan, for the topic of complexities in renal transplant at DHS.
Let's give a big round of applause for our Chief Transplant Physician, who has made his valuable contribution in the journey of renal transplant here at Dow University of Health Sciences. He is also the Chief Organizer and the backbone of this symposium.
Thank you very much for the nice introduction. I would say organizing this kind of symposium and parallelly preparing your presentation is a very huge, difficult task. And you hardly get any time. But luckily, this presentation is not too much academic, little bit. It will be like more of sharing my experience, what we are going through with the statistics and issues related to the kidney transplant. Start. So it was when we started in 2016, it was nothing at Dow University Hospital. So we have started and we have run the show from the scratch, and it was a very difficult task to bring everything under one roof. And now, alhamdulillah, everything is happening in Dow, and none of the tests we are sending to any other labs. And that is the reason that we are doing it on a very quick mode. Kya hua? So today, there are two topics which I am taking part. One is like giving you statistics, what we have done and what problems we are facing. And the second one would be the BK virus nephropathy. So, Hassan? So my experience at Dow is very good, but at the same time, transplant is a difficult task. As Dr. Kashif just told you, that you have to keep balances because you always get infections. A start of a transplant program is a very good thing initially. You all get very successful rates, but as soon as you go further, so you come up with different sort of infections, different sort of experience. Every patient teaches you a lot, and you keep on learning things while you are, going with this journey. And every patient gives you a lesson that this should have been done previously, this should have not been done. So these are, because it's not all the bookish thing and the guidelines that you have to follow. As Dr. Wakar mentioned, you have to individualize the patient. in order to, make your transplant program successful. It can't be just you have to follow one guideline. क्या हुआ? I think I'm so sorry. The presentation is not downloading. So we would invite the next speaker. कौन है? नहीं, कौन सा next speaker कौन है? Dr. Faisal. Dr. Faisal is here. Yeah, Dr. Faisal is here. So I'm so sorry. This is a huge mess. So kindly come on the stage and give your talk, and I'll come after you. Okay? I'm so sorry.
Welcome everybody. So this was unexpected, but that's fine. So, so I guess my talk is going to be on another infection. You just heard about diarrhea before this. This is going to be about TB. And this is going to be a very whirlwind, very fast talk because there's a lot to cover in this. And I'll try to keep this as relevant to Pakistan as possible. I do want to say that a lot of this work actually is done by Dr. Sunil, who's sitting right there. So we will also enlist his help in answering some of the questions when the questions come. So the game plan is that we'll talk about the epidemiology of TB and TB in general, and also in the solid organ transplant population, and also then the clinical presentation, the management issues, especially in the era of SOT, and then finally prevention. Some things I'm going to go over a little fast, and we can maybe talk about it in Q&A later, or just stop me if you like. So if you talk about TB, we know that the worldwide incidence varies. The estimated there are about 10.6 million people in 2021. That's the last time there was a big survey. That's about 134 cases per 100,000 population. But most TB cases, about half of them are present in South Asia. And then there's about a quarter in Africa and 18% in West Pacific region. This is what the epidemiology looks like. And you can see that most of the green areas are, does this work or doesn't? Most of the green areas you can see are in Southeast Asia, and then Sub-Saharan Africa is where the green areas lie. But if I narrow this down further and we look at a graph looking to see where are most of the cases where there are at least 100,000 have been reported. And you can see that it's these countries where there are these blue gole. And if I zoom in, it's these 8 countries only. So China, Bangladesh, Philippines, Pakistan, India, Indonesia, Nigeria, and Congo, where 70% of the world's population of TB lives. Right, so we're in a very high endemic area in the world, where a lot of the TB population of the entire world is in just these 8 countries around the world. So we know a lot of TB here, but what about in the transplant population? So we know in the transplant population, TB is about 20 to 74 times more common than the general population. And it also depends, obviously, where you live. So if you live in an area where there's a lot of TB, so the rates are about 100 to 1,000 per 100,000 patient years. If you live in a place where there's no TB, then the rates in the transplant population will be lower, 2 to 80. And obviously, exactly where you see TB, you'll see more TB in the transplant. So in Asia, there is about 13.27% of transplant patients develop TB, while in Africa, it's about 7.32. So the risk also depends not just where you live, but also what organ was transplanted. So lung transplant has a slightly higher risk compared to renal and heart transplant, which is about 3%, while liver transplant has the lowest risk at about 1%. Now this may have to also do with the fact of where liver transplants occur, and liver transplant may occur more in the high income countries where you have less TB to begin with, really. So we talked a little bit about very rapidly TB, यहाँ बहुत है, TB and then organ transplant, who also have a lot of TB, and then hence anybody living over here who's at a transplant is at a double risk of getting TB over here. But once they do develop TB, what are the symptoms that they present with? So before we talk about symptoms, I think it's important to talk about how people will develop TB or develop active TB. So a lot of people will have latent TB. So TB, जो कि, I tell my patients, jail में बंद है. So, so your TB comes in, jail में बंद हो जाती है. It stays like this for a long time unless आपकी immunity कम हो जाती है for some reason. And in that case, that TB will multiply and the patient will start developing symptoms, or in other words, active TB. This happens in about 95% of the cases, is latent TB becoming active TB. However, anybody living in an area like this where there's a lot of TB, they may also acquire a new infection, so a brand new infection from another patient. Or very rarely you can also, and this could also be from the community or from nosocomial, from the hospital. But very rarely you can also have an organ which has TB inside it, which then gets transplanted, and my pointer stopped working, there we go, which gets transplanted to another person, and the TB bacilli are on the organ. Now, as a cause of TB, this is actually not a very common cause. So this is the least likely. So the most likely is latent TB reactivating. Second likely is getting a brand new infection, either community mein or hospital mein. And the last one is getting an infection from a transplanted organ. When does a TB infection present itself? So usually the median time is about 6 to 11 months after transplant. So this is one of those earlier infections, not one of those like mid infections, not one of those very late ones. And in 2/3 of cases, this will occur within the first year. So in 70% of cases, first year you'll have the manifestation. Renal transplants are a little lower, a little later, after about 11.5 months. But there's some cases they may be a little earlier. For example, in those who live in TB endemic areas, those who have had a lung transplant, or those who have had a donor-derived transplant, or maybe the infection occurs slightly earlier. And this is a table from a really good article by Nausheen Nasir. And authors of this include Dr. Sunil, Dr. Asma, Dr. Shobha, a lot of our ID physicians from different centers. And in this, they summarized the time to positivity. And over here, this is the East Asian area, where you can see it's about 5.2% prevalence to 19% prevalence. In the Southeast Asia for renal transplant, India, Pakistan, it's about the same, 14-15%, while in Bangladesh it tends to be a little lower at 6%, while in the African countries it's about 6 to 4% prevalence. But the time to having a positive from transplant is about the same within the first year or so. What are the risk factors apart from where you live and what transplant you've had? There are many. So diabetes, chronic liver disease, advanced age, and also if you had latent TB. But from a transplant standpoint, keep in mind that chronic graft dysfunction, any graft rejection, again, because you're increasing immunosuppression, any post-transplant OI will trigger latent TB to become active. And then finally, depending on how much immunosuppression you use. So really all dependent on the immunosuppression, what your risk of infection is. How do they present is the tough part, because they may present atypically. They won't be your typical cough, hemoptysis, and night sweats, and respiratory symptoms will be very non-specific. तो वो देर से miss होता है, diagnosis देर से होती है, सबको फैला रहे होते हैं at the same time. But these three symptoms are important: cough, weight loss, and malaise. And if I borrow from the HIV population, if an HIV patient does not have cough, weight loss, night sweats, and fever, then you can essentially rule out TB. So these are very sensitive markers. Agar इनमें से कुछ भी नहीं है, then TB becomes very unlikely. But extrapulmonary TB depends के TB कहाँ की है. GU-TB में very non-specific low interact symptoms or even low abdominal pain. Esophageal TB में dysphagia, laryngeal TB में hoarseness, again nodule. GI TB में just abdominal pain or ascites. So जहाँ की TB वहाँ के symptoms really. And you may have limited sort of systemic symptoms along with this. And extrapulmonary TB has been reported pretty much in all the places in transplant population. So anywhere from sacroiliitis all the way to febrile neutropenia to skin TB. So you have to have a really high index of suspicion thinking of any of the atypical manifestations of TB in these populations. So how do you diagnose active TB? So active TB is diagnosed essentially, and my mouse does not work. There we go. So by radiology. So radiology gives you a good hint कि हो सकता है TB हो, but I would be a little careful not to diagnose TB just based on X-ray, right? So many a times you've seen MRIs that say this is TB and it turns out to be a fungal infection or even lymphoma, or a chest X-ray which has a cavity which is a nocardia or aspergillus. So don't rely just on a chest X-ray or just on radiology to make your diagnosis. You can do histopathology, and this may be the only way to diagnose based on extrapulmonary TB. But again, granulomas are not pathognomonic. You can see granulomas in many things beyond TB as well. You can do cultures, and for the micro people over here, this is not an AFB culture, sorry, but the only picture I could find. So, but cultures are the gold standard. Smears are not very sensitive, but cultures are the gold standard, and they can also give us the susceptibility. And then finally, you can do PCR, also Gene Expert. Gene Expert is, remember, just a type of PCR. Jiska fayda ye hai ki it's rapid, and it'll also give you rifampin ki sensitivity. Gene Expert, mein the only thing you have to be really careful is what sample you're taking. So fluids, pleural fluid, ascitic, CSF, they have poor sensitivity. They will miss the disease. Tissue, sputum, they are much better at picking up TB. So a negative Gene Expert, depending what sample, may not rule out TB, active TB. So it is challenging because atypical presentation hai, clinical suspicion ho sakta kam ho, and extrapulmonary means you have to do invasive tests to make a diagnosis. You can do empiric therapy if you're stuck, if you can't do a diagnosis, if you can't do a brain biopsy, but keep in mind, empiric therapy means treatment for 2 months, see response, and then redecide. So don't give a whole year and somebody's not responding. After 2 months, you should start seeing a response in treatment. But keep in mind that a tuberculin skin test or TST or PPD and an IGRA should not be used to diagnose active TB, because in active TB, they can be negative, right? So, and also if somebody, for example, has a lung lesion and has an IGRA positive, it does not mean the lung lesion is because of TB, right? So don't use these to make your decision for active TB. What about latent TB? So latent TB, it's ideally you should do this in the pre-transplant period, not the post-transplant period. And you can either do IGRA or you can do a skin test. But both of these are just looking at the response to TB. These are not telling you under TB ki jarasim hai ki nahi. They're just telling you, okay, does the body have an immune, have they tried to kill TB in the past, right? So it's almost like, it's not, but it's almost like an antibody test for TB. It's not, it's a T-cell response to TB, but not an antibody test. Both are acceptable. IGRA is more sensitive, but it is also more expensive to do. And a negative test, again, does not also rule out latent TB. So it's a useful test if it's positive. Negative may still be a false negative. Moving to management really quickly. In management, remember the basic principles are the same. You give 4-drug regimen for 2 months, rifampin, INH, ethambutol, pyrazinamide, and then you give 2 drugs for the next 4 months minimum, so that's a 6 months therapy, but up to 10 months more, so that's a 1-year therapy. Most people with renal transplant, they recommend to treat for a little longer. So 6 months the minimum hota hai, but about 8 to 12 months is what we recommend. MDR TB is very challenging. I'm not going to talk about it, but we don't have a lot of data on this. And also we have very few drugs available, but generally we say use 4 drugs, look at the interactions and look at the disease, but the treatment tends to be at least 1.5 saal se leke 2 saal tak for MDR TB. Monitoring is important because you need to watch them very closely in the intensive, the first 2 months of therapy. And you monitor for side effects, you monitor for drug interactions, and also adherence, very important. There's already a lot of pill burden. Make sure they're taking the medicine at the same time every day. Monitor LFTs and CBC and maybe renal functions. Some guidelines do mention renal functions, but you would probably do this more to look for rejection as opposed to for an adverse effect. And then for hepatotoxicity, occurs in about 20% of cases, but the management, INH is the most cause, but the management is the same. So you manage it exactly the way you would do in a non-renal transplant. And again, I'm not going to go over the management of hepatotoxicity, but if somebody wants to talk to me later, we can talk about that. Okay, interactions is the main thing, main problem with transplant, right? So rifampin, as you know, is important for treating TB, but if rifampin is a very strong inductor of the cytochrome P450 system, which means that, and this induction, starts as soon as you start the medicine a few hours after that, and then keeps getting worse and worse and worse, or more and more, till about 1 to 2 weeks, and then it peaks over there. And then very important to keep in mind that once you stop rifampin, the induction ka jo effect lasts for about another 2 weeks. So it's not like aapne rifampin band ki and then you go back to your normal doses of your drug. So 2 weeks lagte hain for this effect to wear off. And this will reduce your key immunosuppressives ke levels and therefore increase your risk of rejection. So this is the major issue really that we deal with managing. And how would you deal with this? Well, for your calcineurin inhibitors and your mTORs inhibitors, what you'll do is you'll increase your doses by about 2 to 5 times, right? So whatever dose you're using, you double or up to 5 times you'll go up. And you monitor the levels very closely in the first 2 weeks. And then obviously when you stop the medicine, right? So that's when the levels will be really haywire. Once they're do hafte guzar jate hain, then the levels will usually stabilize after that. And if the level can't be maintained, you can use rifabutin. Unfortunately, rifabutin, though it works, is not available, right? So this is an issue over here. The other interaction to keep in mind beyond this is the azole antifungals. Fluconazole में सबसे कम होता है, मगर बाकियों में होता है. Voriconazole के levels, you should check if you're putting them on voriconazole. Voriconazole levels are available at Shaukat Khana, also at AKU. But avoid itra, pauza, isoconazole. Unke levels are completely haywire with rifampin. And then finally, keep in mind the rifampin itself is also acted on by the calcineurin inhibitors, the azoles and the mTOR inhibitors, and rifampin levels go up also, and we don't check it, but the side effect may be high. We may see more hepatotoxicity. But despite all of these issues, keep in mind that don't shy away from rifampin. If you have somebody with TB, go ahead and use first-line drugs because outcomes are much worse when you don't use rifampin. When you use a rifampin-free regimen, therapy lambi jati hai and outcomes also not as bad, not as good. There is one last thing in management, which is the immune reconstitution syndrome. This is something that ID sees frequently. In one study in transplant population occurred in about 14% of cases. And what happens is it happens usually earlier in the first month or so. And what is happening is that because TB also causes immunosuppression, once you kill TB, the immunity sort of comes back to some extent. And you see this paradoxic worsening of TB. So in the first month, if TB worsens a little bit, this is just the immune constitution, and management you don't have to do immunosuppression anything. Usually NSAIDs will take care of it after this. Okay, and then finally, prognosis is not bad. The all-cause mortality is 20 to 30% for TB, and that is not good. Yes, 5 minutes, we're done. So, but when you look at TB attributable mortality, it's about 9 to 10% in that case, and graft failure in about 68.3%, again because of the drug interactions. And this is sort of the same chart, but the last you can see the mortality. And for us in India, Pakistan, it's about 6.5% mortality, which is not bad at all. I'm going to finish up with prevention in the next 5 minutes, I promise, which is, and the prevention, the most important prevention is the latent TB infection management, because 95% of this TB is because of LTBI reactivation. Remember, in normal people, it's about 5 to 10% risk in the lifetime. If you've had a transplant, it's about 40 to 30% higher risk of reactivation. And this is even worse in high endemic countries, because you may get a new infection also after you get treated with LTBI. So remember, you should consider LTBI treatment, and this is according to the guidelines, in all of these other conditions also, even if your IGRA is negative. And I just want to point out, this is international guidelines, but I want to point out, if you're planning to travel to a high-burden country, if you may have gotten a donor from somebody who has TB, all of these things are with pretty much all of our recipients. So, we may want to consider using LTBI or treat latent TB in all of our folks in this part of the world. We use INH, 300 milligrams with Vita-6 with it for 9 months. You check LFTs frequently because there is increased risk of hepatotoxicity, but there are luckily no interactions with this. The bigger issue is that once you give latent TB infection treatment, there is still risk of TB which goes up after 2 years, and there's no consensus what to do. Some people have tried checking every 6 months and treating them. SIT did a study looking at putting them on INH just prolonged forever and ever for a long time, which is almost like pre-exposure prophylaxis in many ways, but or periodic testing, but there's really no clear answer what to do after you've given the treatment for LTBI. IPC, infection prevention control, extremely important. There are the 3 I's that we talk about. So that's prompt identification. there is I for isolation and I for IPT, which is ionish preventive therapy, right? But the bottom line in IPC is that you need to diagnose early and isolate and also treat latent TB. And then finally, vaccination. Just one line on vaccination, that there's really no point. It's a live, BCG is a live vaccine. The risk of getting acute BCGiosis is probably more than the benefit, and there's really limited studies in adults. So if just to wake everybody up really quickly, the risk of TB in transplant is high in this part because it's inherent risk है, and you're in an area which is high endemicity. The mouse stops working. Most of this LTBI is reactivation disease. So if you can treat the latent TB infection, you will prevent active TB. It occurs early in infection. So within the first 1 year is when you would see it. Management is the same as non-solid organ transplant. Just make sure to look at the interactions. And then prevention is, again, manage the LTBI before transplant, good IPC, and then no vaccination helps. Thank you.
Thank you, Dr. Faisal Mehmood, for this really enlightening talk. Your formal introduction was missed. Dr. Faisal Mehmood is serving as the section head of infectious disease at Aga Khan University Hospital. He is not only an ID expert, but has an experience in transplant infectious disease as well. I'm really sorry for the technical glitches that we are facing. I hope it is cleared by now. I would again like to call upon Dr. Tasadduq Khan for his talk.
Thank you very much. I'm sorry for. So here we are going to discuss the complexities at DUHS, what we are facing, what we have done. So the contents would be the exploring transplant statistics at DUHS, identify risk factors for the cardiovascular, which we already discussed and learned from Professor Waqar Kashif, pathogenesis, just a brief thing. And what we are going to discuss is the patients who have got cardiovascular disease, who have got low EF, and who comes up with, such comorbidities, how we have managed them, and how they have been successfully transplanted. And journey of hepatitis C and B, as we know that there are so many patients who are on dialysis, almost catch hepatitis C, or some have hepatitis B. So how we have to deal with those patients. And last year we have a good enlightened talk on how we have done DSA positive patient, which is a difficult one. So what is the vision of DUHS to become a regional center of excellence in the field of transplantation as well as transplant research, providing services to the people and professionals of Pakistan, SAARC, and Middle East region. In future, to make our institute, NISOT, a center of excellence in the field of renal transplant for patients and medical personnels, where it will be training people to fulfill the much needed requirement of trained medical personnel for the country. Our statistics. So we have started our program in 2017. We have done 28 cases in 2018, 78, 19, 106, 2020, 99, and 2021, 106, 2022, 81, and in 2023, 71 till now. So these are the numbers in 7 years. So these are the total numbers. These are the patients who have got, there are few patients who never been accepted by majority of the centers for their second transplantation. And this is a privilege for Dow University of Health Sciences that we are the only institute who have done the third transplant in a patient, because none of the centers in the Pakistan have done third transplant in a patient. So, which you can see easily in the Western countries, that they have gone through thrice and even 4 times the transplant. So this is facts and figures, how many recipients. This is very interesting from the last year, that I presented data in which females were the majority of the donors, but it has changed now, and donors majority are now males. So the total number is males are more, 468. As you all know, our tradition that everybody is for the male, the bread earner, not for the females. So recipients are less than as compared to the males. So, but this is interesting that donors now coming up, the male donors are coming up to donate their loved ones. So our transplant success rate, this is first year. As you all know that CKD patient are a complex patient. They have multiple comorbids. So it's not an easy job. It's not a piece of cake because they come up with hepatitis C. They come up with history of TB. They come up with the low EF. So they have so many comorbidities and you are transplanting in those high risk patients. And so success ratio, if you see, first year is very good as compared to any international center. And the third year success ratio is 88%. And even the fifth year is 80%. The mortality is, most of them are because of the infections. And, we are a country where we cannot control infections in especially a low socioeconomic status where they cannot take precautions despite they have been counseled several times. So this is the data that from where we are getting the patients as we are in Sindh. So majority is from the Sindh, that is 51%. But interestingly, this Balochistan, we have got 20% patient from the Balochistan, but most interesting is that 17% of the patients are coming from Punjab, where there are so many centers working for the transplant, but it is a privilege for the Dow University of Health Sciences that patients are coming all the way from Punjab to get their transplant done in our center. And few from KPK, Afghanistan, and other countries as well. So what are the difficulties in selecting the patients pre-existing cardiac issues? Because majority of the CKD patient have got history of ischemic heart disease and with history of CABG and with history of angiography, angioplasty has been done with 2 stents. So these are the patients you have to deal and you have to think beforehand while proceeding for the transplant. So patients with hepatitis B and C, so these are also complicated patients because majority of the centers have stopped doing it till the viral load has, become negative. But we have done it, and I'll show you the data that even once you start the therapy, you could have done it, the transplant, and continued the therapy for the rest 3 months, especially for the hepatitis C. And patient with history of TB, as we just learned from Dr. Faisal, that it's a very notorious thing. But if you take a proper history, you come across that patient have got a history or exposure history of tuberculosis. As we all know, we are an TB endemic area, although we have forgotten, especially the newer generation, because what we have learned from our professors, that they just used to see the X-ray and they say start ATT. But nowadays, things have become more advanced, and to diagnose tuberculosis is become very difficult on the laboratory test. And patients with DSA, this is also a challenging task. So diabetics, how many diabetics we have done? So it's a huge number. It's 165, 29%. How many with the low EF? Low EF, we can define those with 25% to 35%. And hepatitis C patients, 63 were hepatitis C positive. Hepatitis B were 14 patients. And this already Professor Rostaing has discussed about zero match and the HLA incompatible. So these are the patients who have got zero match with the, especially with the spousal transplant. So you always get the zero match. So this is also important to understand for the junior audience that immunology has become so advanced that beyond matching, there is other things as well to see rather than just to get a good match. Our challenges, of course, infections. Infections are there, and the numbers you can see, the E. coli on the top, and Pseudomonas and Klebsiella, staph, and fungal as well, and the other infections like CMV and BK, and rejections. These are the things which we are facing and which are the challenges which we have to come over. CMV is like 10% and BK is 4.3. Rejections are 5%, because rejections, because we do biopsy very promptly as soon as the rise in creatinine, so we catch rejections very early and treat them properly. So despite of those infections, what our protocol of giving the universal prophylaxis and vaccination, despite of all these, we are getting this kind of infections. For the CMV, and especially in a high risk group who have received ATG, we gave CMV prophylaxis, valganciclovir for 6 months, and the Bactrim, which will cover your 4 infections for the 6 months, and antifungal, especially in those who have history of recurrent infections and suspicion to get and catch fungal infection. We always give antifungal as well. Tuberculosis prophylaxis, what we are following a protocol in which if we do IGRA test, if IGRA is positive, then we go for the prophylaxis. If it is negative, we don't do prophylaxis. Hepatitis B vaccination, pre-transplant, influenza, and vaccination annually, and pneumococcal, Prevnar 13 and 23 vaccination. Cardiovascular and renal transplant. So there are 2 major categories. One are those who are with the uremic cardiomyopathy, and other are with ischemic heart disease. The number 1 patient, the uremic cardiomyopathy, especially those patients who are on long-term dialysis, usually you must have seen with the low EF, because of the exchange of blood they're going through for several number of years. So they come to us with the leaky valve, severe mitral regurgitation, tricuspid regurgitation, and with the low EF of 25 and 30%. And history of ischemic disease, it is very common because the number 1 cause for CKD is diabetics. So diabetics are very much prone to get the ischemic heart disease. And these are the risk factors, which I am not going into the details because everybody must be knowing that they are modifiable and non-modifiable risk factors. But unconventional, we have to look for that are proteinuria, left ventricular hypertrophy, anemia for our CKD patient, and prothrombotic states. If we get a chance, to take a detailed history, if we have a history of fistula failure, so we have to go with the hematological profile as well. We always go with the APLA and antithrombin 3, protein C, protein S, and factor 5 laden in those patients. And we come across 2-3 cases who are positive, and we have to anticoagulate post-transplant. So you have to be very cautious, especially I always tell to my junior colleagues that always take good history, because you come to know several things which you will realize later and it will not benefit your patient. So pathogenesis, we all know, I'm not going into the details, but there are certain things which we always look for, like volume overload, because patient sometimes comes to you for the transplantation who are in volume overload. So you have to go for the intensive sort of hemodialysis prior to transplant so that they are not in any volume overload. And the vascular calcification, this is a very important thing which we need to know, and we are now avoiding calcium-based phosphate binders and trying to get rid and decrease the rate of vascular calcification. So this is a picture which is showing all the pathogenesis and things. So what we do when we come up with a patient who has got coronary artery disease, what is our protocol is who has history of diabetes, who is 40 years plus, we always go for MPI scan, that is thallium scan, in order to proceed for the transplant. It's not the cardiologist recommend, it's our protocol that whoever has got diabetes and 40 plus, we'll go for the thallium scan other than the echocardiography. Echocardiography is a basic test. If it has got some reversible ischemia, then we go for the coronary angiography, or patient has got symptoms. If he has got any cardiac symptoms, then directly our cardiologists go for the coronary angiography before the transplant. So it is important to assess clinically the symptoms of the patient, that Does he have the symptoms or not? Even he doesn't have any history of cardiac disease, but those who are diabetics, we should always look for the cardiovascular protection. So with the low EF, I already mentioned in the previous slide that 76 patients we have taken, and few of them were because of the uremic cardiomyopathy, and PCI has been done as well. So you have to be very careful in continuing their antiplatelet and statins and everything. So we adopt a protocol that we do not stop antiplatelet agent till the time of surgery. We continue ASCARD. We just hold low plat if they are on dual antiplatelet. So we continue the ASCARD therapy, and our surgeons are very brave that they have now started accepting this, and they are doing the transplant with patients who are at high risk and continuing the ASCARD. So this is a real scenario. What we have a 20-year-old girl presented to us for transplant workup. She is known case of hypertension and on maintenance hemodialysis via permacath for 8 months. Her pre-transplant workup was done, baseline blood investigation were within normal limits, and bone profile shows secondary hyperparathyroidism. Echo, you can see EF was 25%, symmetrical hypertrophy, LV, moderate global hypokinesia, moderate systolic dysfunction, mild TR, MR, and TR. So this kind of patient who have got moderate global hypokinesia, I'm not expecting that it will get reversed. It will not get reversed because she has got the global hypokinesia. The problem, so what should we be doing? This is the main issue. Should she be continued on hemodialysis considering her age of 20 years or proceed with a high risk surgery? Because you have to counsel the patient, her family, her parents. It's very difficult because you start the counseling. Transplant physician has a role of counseling first, but after that, when you get a call from the cardiologist, so he also comes with a very threatening way that it will be a very high risk surgery. When you call the anesthetist, they'll say you'll get a on table death fitness. So it's a very difficult task to counsel those families, but what options we are left with? Because if she continues on dialysis, she won't be surviving. So fluid management and diuresis, starting antiplatelet therapy management is and restarting disease-modifying drugs, which include ACE, ARBs, statins, ASCARD. The second scenario was scheduled to undergo kidney transplant from his brother. He had been treated for chronic kidney disease due to polycystic kidney disease, and he had begun hemodialysis 12 years ago. He had also been taking medication for atrial fibrillation, MR, for 5 years, and he underwent percutaneous PCI, and he had an EF of 30%. He has got severe mitral regurgitation with left ventricular ejection fraction of 30%. So this surgery was also conducted with all the counseling and things, and with the very restrictive fluid management, close monitoring of cardiac function. The patient renal function improved promptly after the kidney transplant, and hemodialysis was stable throughout the perioperative period. The case indicates that these patients have the potential to improve cardiac function in patients who have been on hemodialysis for more than 10 years, especially those who have got uremic cardiomyopathy. I have seen the patient that their echo has improved from 25% or 35% to 55%. So outcome post-transplant, both of my patients are doing well, discharged as scheduled, no perioperative complication, 1 year follow-up with no complication. Follow-up echo, this is very important and interesting. From the second patient, not the first patient, has improved from 30% to 55%. First patient have also improved from 25 to 35% of EF. So this is the data that 76 who have been transplanted, post-transplant, low EF, only 24%. So this shows that majority of the patients have been reverted and their cardiac function has improved and they are living a pretty normal life. So points to remember in this that we should not discard these patients because majority of the center discard because of the high risk, suspicion for mortality and morbidity. So it's better to continue with the transplant, especially in the younger population. I'll skip those research. Hepatitis, so we will do hepatitis workup, PCR load is positive, then we start antiviral therapy, continued for 2 weeks, and then we go for the transplant and follow the PCR and continue for the 3 months. Hepatitis B is the same, PCR has been done, then start antiretroviral therapy, and it should be continued throughout the life, and we'll just follow the PCR. Challenges, the same. Tuberculosis, I don't think I need to go into the detail. The only problem which Dr. Faisal already mentioned, you have to be very careful when starting ATT that your drug level will go down and you have to increase your steroid. That is very important. You have to increase your steroids and you have to increase your immunosuppression in order to protect your patient from rejection. And these are the risk factors. I have not, and going into the details because TB has already been discussed. And difficult immunological patients, especially we are doing patients who have got CDC positive cross-match, patients who have got DSAs, patients who have high PRAs along with DSA. So we have been desensitizing, and a desensitization protocol would be doing plasmapheresis, immunoglobulin, IVIG, and rituximab. And we have successfully done many transplants of 87% non-desensitized and 12% you can say we have done desensitized patients. Thank you very much for listening. If you have any questions, I would be happy to answer in the end. Thank you.
Thank you so much, Dr. Tasadduq, for your words. Now, I'm moving towards the last talk of the session. I'm inviting Dr. Amjad Sattar to deliver his speech on the topic of unveiling the role of radiology in transplant care.
Dr. Amjad Sattar has served for more than a decade in SIUT and is currently working as our senior interventional radiologist here at Dow University of Health Sciences. He has a vast knowledge and experience in dealing with transplant emergencies. Dr. Amjad Sattar.
Assalamu alaikum all, and thank you very much for inviting me. And I congratulate the whole team. This is the second symposium, especially Professor Rostaing, who has come from France all the way, and Dr. Tasadduq and Dr. Rashid. So we are all previously shooting stars from SIUT and dropping in Dow University, especially Dr. Faisal and Dr. Khawar also were there. So my talk is about the role of radiologist in transplantation. And as you know that kidney transplant is the most common transplant being done in the whole world, and look at the number of transplants being done in the whole world these days. So there is a network which is known as Organ Procurement and Transplantation Network, and it says that these transplants of the kidney patients, mostly people are waiting for the donors, and these are, the number is like this in 2023, and every day in the world, 20 transplant recipient die because of non-availability of the donor. So the donor are the most important part of the chain of the transplantation, as everybody know, and we should give proper respect and honor to them. So just telling you about the role of radiologist, it's not just the X-ray or ultrasound, and it's more than that. So we actually work with our transplant team before transplant, at the time of transplant, in the theater, and after the transplant. So considering what we do before transplant, for the donor, it's X-ray, chest, and ultrasound initially, as most of the speakers already told us. And for the recipient, rest of the things. So for the donor, initially the X-ray chest, and this is very important, although Dr. Faisal already told that it's not just to see the X-ray and say that it's TB or it's not an infection. I agree with him, but when we are suspicious and we have more parameters to actually measure, so we do HRCT of these patients, and very, you can say, minor type of infection are being diagnosed by HRCT. So ultrasound for the donors actually to see the size of the kidneys, and in our Pakistani population a few years back we actually did some study about the sizes of normal kidneys in Pakistan. So it's almost between, considering the average height and weight, 5 to 10 percentile one way, and the other side is approximately between 8.5 to 10.5 centimeters. So the initial workup for the ultrasound kidney by measuring the size and appearance, and also CT triphasic for the vascular anatomy and anything else going on in the donor. So that's how we get our fine images, and we don't need renal angiography for this. This is CT angio, and usually if from our SIUT times, we used to do conventional angio, and out of those angios, sometimes surgeon used to tell us that the endothelium was damaged while we were doing the catheter workup. So for this, the new technique and the new softwares in the CT scan, we do these CT angios, and these are very accurate most of the time. And I must say that these are almost touching 90 to 95% of the accuracy. If more than 2 arteries on the left side, usually the left kidney is being taken. So if they are more than 2, then we sometimes go for the conventional angiography with the approval of the renal surgeons and our transplant surgeons. So that's how we do all the 3-dimension workup. We do plain CT scan, and then we do contrast enhance, and then out of that we sometimes get these things, sometimes collapse of the vertebrae only, sometimes some abscess or something in the donor. So at that time it's very important that the donor should be 110% fit. So that's how we do the angiography. This is maximum intensity projection images, MIP images, and out of this we can make it in the color form and also in the form where only we can see the kidney. So you can see beautifully the veins and arteries of the kidney and other things. We are also working with the liver transplant team, and we are part of that team as well and do interventions for them. So the other thing is for the recipient now, we do the venous mapping, and peripheral arteries, peripheral veins, and central veins are being seen by the Doppler examination. And these are few of the measurements which we actually see to make the fistula for them. Dr. Mohammad Khan Babar used to make AV fistulas with Dr. Naranjan in SIUT. And we actually used to give him these measurements to do the thing. And this is how we actually assess the veins. And definitely these are the points where we look for the cephalic veins and basilic veins to let them be sure about the fistula and its outcome later on. So for the recipient, the important thing is the usual algorithm goes with the chest and abdominal X-ray and ultrasound of the abdomen. And at transplant, while the operation is going on, and if there is any loss of turgor during surgery or the change of color or something wrong with the appearance of the kidney, the surgeon usually make us call to visit, and we actually reach with our Doppler machine and see at the time of the surgery when the patient is open, and that's an amazing experience what we do while they are doing their surgery, and we are with our hand inside the body of the patient. So we see the patency of the artery, patency of the vein, and before transfer to the ward, when they just close the patient, sometimes they again ask us to do the Doppler ultrasound. So the post-transplant, we have some early, intermediate, and delayed actions. And post-transplant, some complications, what we get actually in the earlier phase is usually within 4 to 6 hours, intermediate between a week or when the patient is discharged, and delayed when there are many months or years after the transplant and patient is on immunosuppressive therapy. So post-operative complications, most of the complications are being discussed in these talks before. So most important is correctable vascular abnormalities. And these correctable vascular abnormalities are nicely being picked up by the Doppler examination. And these are really graft saving, patient saving, and as initially the talk was going on about the ethical values, the donor is quite depressed when these kidneys fail. So this is also important that if we get it within 4 hours, we can do it nicely. So the surveillance ultrasound usually are done for hydronephrosis, perinephric fluid, vascular patency, and arterial resistive indexes. So the only thing is, this actually for trained people, this is a 5 to 7 minutes job, but this actually gives life to the transplant. And most of the time, just because these parameters are changing or earlier picked up, so these transplant can be saved very nicely and easily and work for the longer period of time. So the contrast enhanced ultrasound, we are not doing it, and the contrast is also quite costly, and most of the time it's not available in our country. So in Western world, they use for detecting the cyst and solid renal masses just to differentiate them. CT and MRI usually comes later when there is some doubt in the ultrasound examination or Doppler examination, or sometimes when there is a trauma to these patients for any reason. So we can do the CT and MRI for those. Biopsies are routinely performed during the first 1 to 2 years. And mind you, before anything goes wrong, the parameters which we see on ultrasound are usually indicative. So the trained person can pick them up earlier and can help the nephrologist to treat the patient. So what I suggest, and the literature also suggests, that duplex ultrasound is the principal modality used for evaluation of the renal allograft. Nuclear medicine has a limited role in the sense that its availability in most of the center is sometimes difficult, and sometimes it's time consuming. And time is actually the key and the most expensive thing when we are dealing with the transplant patients. So keeping them just like some sore in your hand, and you cannot work with your hand. So we should also keep these patients in our mind that they should get their treatment or their diagnosis very soon, rather than waiting for something going bad and something going wrong with the biopsy material. So it is important to identify and document the Doppler profile of each donor, renal artery and vein at baseline postoperative ultrasound. Sometimes the person who is following the patient and there is some anatomical variation, or sometimes while doing the surgery, sometimes they make some bypass or some changes in the anatomy of the transplant. So actually that should be noted and that should be on the file, and if anybody new coming to the department to do the ultrasound, they should be knowing it, or somebody can help them out. So in our setup, usually the nephrologist or the urologist, the chief surgeon, Dr. Rashid, usually tell us that please keep in mind that we have done this. Sometimes they don't put DJ stent and sometimes they put DJ stent inside. So we can see them and let them know. This is the type of attachment what they do with the ureter. So this is ureteroneocystostomy. Usually this is done. Sometimes there is ureterostomy and sometimes pyloureterostomy. So in these almost 18, 19 years, the first two are usually seen by me, and the last one, I think, very few. I think less than 10 patients. So the complications, Dr. Waqar, Dr. Faisal already have discussed too much about it, so I won't be discussing tuberculosis here, which is very important as well. So this is the timeline which actually being followed by the ID people, and these basically are mostly being seen by the ID persons and the nephrologist. So what what we actually are doing, this is the compartment syndrome when the kidney is placed deeply and sometimes the artery or vein kinks. So there is a loss of color filling or flow in the kidney, and then they call us to do the ultrasound because one person is most of the time sitting near the table and just seeing how much urine is coming. The moment he sees that it's less than 15 ml per minute, they just call us and we see it. So the perinephric collections, as already discussed, are hematoma, urinoma, abscess, and lymphocyte. And in that order, with respect to time of surgery. So usually the first thing is hematoma, later on urinoma, and in between is abscess sometimes, or after this abscess, and lymphocyte mostly quite late. So the urinoma can be detected on nuclear medicine as well, DTPA and MAG3 scans as isotope which can be seen outside the kidney. Here is the ultrasound, the first picture on the left side. Outside the kidney, there is some collection which is anechoic, and we can see it that the flow and renogram is showing most of the isotope outside the kidney. So fluid collections, these can be hemorrhage, which on the left side upper picture showing hemorrhage around the kidney, and the leakage of the contrast sometimes due to infection or sometimes poor attachment later on with the infection or something, it's coming out of the collecting system. The ureter, the asterisk is showing the ureter. The lower on the left side is showing abscess, and the last one is showing the lymphocyte. So trauma grading on the CT scan, and this is a three-dimensional CT scan, and we just do it on the spiral CT. We have our 16 slicer, 64 slicer, and 128 slicer in one unit here, and others in the peripheries. So we can pick up early the trauma of the kidney, and just grading this seems to be grade 3 injury with more than 1 centimeter of the parenchyma is involved, and the collecting system is spared. So it's not the damage to the collecting system. So perioperative renal vein thrombosis can be easily picked up when we see diastolic flow, which is usually not that low in normal kidney, and peak systolic velocity is a bit lower on that side and just showing the swollen kidney. So this has to be basically looked for very quickly. So the interventions, what we do, we can place the antegrade DJ stent. This looks like this in the X-ray. Sometimes they are encrusted, and we help them to take them out when they are encrusted and they want to take it out. Post-biopsy, AV fistula sometimes form, and the treatment is we do the angiography and do coil embolization to stop this bleeding. Renal artery stenosis, the artery caliber can be plastied, and we just make it some ballooning is done, and then the flow is patent for this. So Uretropelvic ejection obstruction, percutaneous intervention can also have sometimes replace PCN in these kidneys, and the kidney work nicely then. And these are the abdominal complications in renal transplant. Sometimes small bowel loops are involved on the left side upper one, and the string of balloons like appearance of the small intestine, which we can see sometimes on CT, and patient is complaining of pain, and sometimes most commonly the herniations when they are placed superficially. This actually is complete infarction and rejection due to vascular thrombosis. It's late and it's giving the rim of enhancement outside the just below the capsule of the kidney, and this cortex is just thin out. Hydronephrosis with restive index increase again. So this can be seen earlier, and just due to the increase in creatinine level, we should be looking for it and just do either drainage of the collecting system by DJ or some dilatation. Survivors, as Dr. Khawar has already talked about, so they can develop RCC later on due to these medications which we give for immunosuppression. So we can diagnose on CT, and the thrombosis can be diagnosed on contrast enhanced ultrasound. So the reminder, there are 4 main types of perinephric collection: hepatoma, urinoma, abscess, and lymphocele. Usually these are the things for which patients are coming. And reverse diastolic flow in the transplant renal artery at spectral Doppler is highly suggestive of renal vein thrombosis. And absence of allograft dysfunction and secondary features of obstruction, it may be within acceptable limits. Sometimes as there is a new bladder formation, so when there is fullness in the kidney, there is no obstruction. So the conventional thing is that we ask the patient to void, and then this fullness goes away. After immunosuppression, I think most of the things have been covered. So I stop here because these are basically having, these patients have neurotoxic effect and donor-related malignancy. Even the malignancy which the genetics of the donor has, sometimes this gets working in the recipient and they get malignancy. So usually seizures, press, and infections are in the CNS, and we can see sometimes the hemorrhage. This is the MRI image for the hemorrhage, and this is the subdural hemorrhage in the recipient. Fungal sinusitis is too much, is common in the sense that immunosuppressed patients having prolonged immunosuppression have this fungal infection, and sometimes the brain is involved, and this is actually the time when within few days this goes like from 30% to 80%. Lymphoma is also the notorious thing which comes, as Dr. Khawar has already discussed, and sometimes gliomas and different CNS tumors just because of immunosuppression. Thank you very much.
Thank you so much, Dr. Amjad. Now we are open to question and answer sessions. First from the panel of experts, then we'll move towards the audience.
Thank you very much. My question is to Dr. Faisal Mehmood. Yes. So regarding TB in kidney transplant recipients, how has your experience been in terms of clinical presentations, drug accessibility, and treatment responses?
So our experience has actually been pretty good. We haven't seen any MDR TB, which is a good thing. The biggest issue we face usually is with drug interactions. Currently, I have one person who's actively has transplant and is on ATT, and the only thing atypical about him was he had severe chest pain along with his his fever, etc. Enough that he had to go to the ER, but he's doing very well now on therapy. So not a bad outcome actually.
I have a question to Dr. Amjad Sattar. If most of the patients we see that when we are going to transplant, so we see the history of femoral catheterization. So that was very difficult for us to do the surgery on that side, place the graft on that side. So we request you for the either you do the venogram or CDI to rule out the some thrombus or something. So what is the superior for that is either we do the venogram is the superior or the only CDI, because venogram is some kind is painful or very difficult procedure.
With all due respect, I must say that it depends on the facilities available at that time and the expertise of the radiologist who is there. So I would prefer, as you said, that it's a painful procedure, and sometimes these patients are on dialysis and they have to have dialysis later on while we do this venogram. So it's better to have Doppler ultrasound first and be sure and have good pictures out of this, so that anybody, if you want to have another opinion, you can confirm. Thank you.
Outcome of the second transplants are good because they are following, and the third one is also following. The reason for his rejection previously, because your question is very good, that why he has got 3 transplant. One time he had a very bad infection and he lost his graft just after the transplant, 6 months, which has been done in the other center. Second time he had transplant in our center, and he has stopped taking medication during the flood time. And he said we could not come to all the way to anywhere, and unfortunately he stopped his immunosuppressive medication, and he went into rejection. The third transplant has been done 1.5 years back, and he's following pretty well, and his follow-up, his creatinine are pretty normal. In the second transplant, those we have done 12, we have to get the DSA levels because these are highly immunogenic patients who have got high titers of antibodies. So majority of them have been desensitized, and then we proceeded for the transplant. And their follow-up are good.
That we need to redesign our screening protocols post-transplant for cardiovascular disease, since we have seen emphasis on cardiovascular disease post-transplant. So do we need to redesign and be more vigilant in screening these patients post-transplant?
Yes, we are actually following them very religiously from the cardiovascular aspect, despite I'm not a cardiologist, but keeping that thing in mind that they have pre-transplant low EF or they have ischemic heart disease. So we have made a protocol of getting their echoes and their stress ECG as well. So to pick any ischemic heart disease factors earlier than it happens. And for the protocols, yes, I would suggest and I would recommend for all the transplant centers that do not reject those patients because they don't have any other option. Because for that, going for a transplant, you need a courageous anesthesiologist and a courageous physician in order to make a decision that you are going for a transplant. Because if you keep those patients on hemodialysis, I don't think they are going to survive much, because they already have EF of 25 to 30%, and they are on continuing hemodialysis sessions with the blood exchanges. So they are prone to get any major infarction during the course of hemodialysis. So transplant is a better option, and we should opt for it, and we should go for it after a detailed counseling of the patient.
Thank you.
Thank you.
EV. because indeed it's dilated uremic cardiomyopathy. And we came across with such patients coming from Africa to my center to be transplanted. They're on dialysis once a week. They are very young as yours, and EV fraction is very low, but in fact, we just place them on a daily EMO for 10 days or 15 days just to raise up their ejection fraction and transplant them. So just to make the point that the way you deal with these patients is very fine and fantastic. So thank you.
Thank you. Actually, we are also a third world country where the dialysis facilities are not up to the mark. So there are majority of them are inadequately dialyzed, and that is the reason they are coming up with low EF and other problems. Thank you.
So the conclusion remarks from the chair of the panel of experts, please, Dr. Abdul Manan Junejo.
Bismillahirrahmanirrahim. First of all, I am thankful to Dr. Tasadduq and Dr. Rashid for inviting us here in the symposium, and congratulate both of them and his dynamic team for arranging this second International Kidney Transplant Symposium. And I am also thankful to all the speakers, senior speakers, for their nice talk. They share the knowledge. I hope our postgraduate, junior consultant, even we senior consultant, take benefit from their lectures. And I am also thankful to all the audience for coming here and attend this ceremony. Thank you very much.
Now we are beginning our shield distribution ceremony for this session.
I would like to call on stage the Honorable Medical Superintendent, Professor Jahara of DUHS. She's a well-known gynecologist, and she is helping our transplant program in every possible way. First, I request Professor Abdul Manan Junejo to please come on stage and receive your shield. Next, I would like to call Dr. Next, I would like to call upon Dr. Sonia Akub to please come on stage and receive your shield. Next, I would like to call Dr. Farzana Adnan to please come on stage and receive your shield.
Now I would like to call upon the speakers from the second session to receive their shields. First, Dr. Khawar Abbas from SIUT. Dr. Waqaruddin Kashif, please come on stage and receive your shield, sir. Oh, Dr. Sonia will receive the shield on his behalf. He had to leave, so. Next is Dr. Faisal Mehmood, sir, please. Dr. Faisal Mehmood. Dr. Amjad Sattar, please come on stage and receive your shield, sir. Now I would like to call Professor Lionel Rostaing to present the memento of appreciation to the MS of Dow University Hospital, Professor Jahara. Thank you so much, everyone. Dr. Tasadduq, please come on stage and receive your shield, sir. Thank you so much, everyone. Now we are calling our first speaker for the session, Professor Dr. Ijaz Ahmed, to enlighten us on the topic of renal transplantation in patients with FSGS and autoimmune diseases.
Professor Ijaz Ahmed is currently working as Head of Nephrology at SIUT and as President of Pakistan Society of Nephrology. Professor Ijaz.
Assalamualaikum. I must thank the transplant unit of Dow University of Health Sciences to persevere with renal transplantation and making an effort to educate young nephrologists as well by holding its second symposium on renal transplantation. Now, Dr. Tasadduq was generous enough to give me this talk on recurrence of FSGS and autoimmune diseases in renal transplantation. It's a big topic, so what I have done is I will try and focus on focal segmental glomerulosclerosis and SLE and talk about its recurrence after renal transplantation. So the outline of my talk would be, very briefly, I would be talking about just overall recurrence of chronic glomerular disease and graft loss, the recurrence of FSGS and its risk factors in particular, the preventive measures which we can theoretically take before transplanting a patient with FSGS, the conventional treatment for treating recurrent FSGS and whether or not we have got newer agents on the horizon, and the risk factors and impact of lupus nephritis recurrence, what is the histology of lupus nephritis recurrence, and what approach we have got to prevent recurrent lupus nephritis and graft. This is the Australia-New Zealand data of about 4,500 patients who had biopsy-proven chronic glomerular disease before transplant. And the graph shows the recurrence rate of 4 common chronic glomerular disease. And what you can see from this chart is, this is the overall recurrence in this study is about 10%. So that's not very high. And the most common disease which recurred was membranoproliferative GN, followed by membranous nephropathy, the yellow one. The recurrent of FSGS in ANZ registry was not very high. But the important thing to note is the line FSGS, which is beginning here. So most of the FSGS, when it recurs within first year of renal transplantation. The median time to recurrence of focal segmental glomerulosclerosis in different studies has been between 6 and 9 months. So the 50% would recover a recurrent FSGS before 9 months of transplantation. Now, when the disease does recur in the graft, do they fail because of recurrence? MPGN, so the orange section in the 4 common glomerular diseases, so about 50% of the graft in recurrent FSGS does fail because of glomerular disease. And besides the recurrence, there are other causes of graft loss in these 4 common glomerular disease when they do recur. Now, I came across this latest meta-analysis of incidence and risk factor of recurrent focal segmental glomerulosclerosis, that is in 2023. So they analyzed about 1,000 patients of FSGS. The 358 had recurrence and 608 did not recur, which comes to about 35-36% recurrence rate of focal segmental glomerulosclerosis, which is a significant number. This is slightly earlier data of recurrence or FSGS from the post-transplant glomerular disease project called TANGO. Now, in this particular study, the recurrence rate was about 32%. And out of these 57, 22 lost their graft. So the 39% of them who experience recurrent lose their graft. And the main risk factor which they identified was white race and native kidney nephrectomy before transplantation. And of course, the recurrence did affect long-term graft survival. On the left-hand side picture, this is the survival of patients who did not have recurrence. This is the survival curve of patients who did experience recurrence. On the right-hand side are patients of FSGS who did experience recurrence and were treated. So after treatment, some patient did respond. So the patient who did respond either completely or partially had much better graft survival compared to who did not respond at all after recurrence FSGS. So it's similar to what we experience in general nephrology, that FSGS, if it does respond completely or partially to whatever treatment we are giving, the long-term survival of the native kidney is much better. At our own center between 1993 and 2015, and we analyzed it in November 2017, there were 85 transplants where the diagnosis was FSGS, and the recurrence rate in our own experiment is not very high. It's about 14%. So what are the clinical risk factors to guide a practicing nephrologist whether recurrence will occur or will not occur? So the patients who are at increased risk are diagnosis of primary FSGS, young age at the diagnosis of FSGS, short time to end stage renal failure from onset of FSGS, heavy proteinuria pre-transplant, pre-transplant nephrectomy, related donor and older donor. Patients who have genetic FSGS, most of them are children or adolescent, or patient who had secondary FSGS had a low risk of recurrence. whether there are biomarkers available to a clinician to predict whether a patient would recur or not. These are some of the biomarkers which are being investigated to predict recurrence after transplantation. Serum soluble urokinase like plasminogen activator receptor in blood or urine, anti-CD40 antibody and anti-angiotensin II receptor antibody. These four biomarkers have some clinical data to support that the patient may recur, but these biomarkers are still not in use at time because their data is insufficient. So you have to rely heavily on your clinical judgment to stratify patient whether or not recurrence will occur. Now, two of the most common strategies to prevent recurrence is plasmapheresis pre and post transplant. That means you do some plasmapheresis session before transplant and some session immediately after transplant to remove the putative permeability factor if one does exist, and rituximab pre-transplant. Now, is there sufficient data to support that the use of pre-transplant plasmapheresis or pre-transplant rituximab is indeed beneficial? We are fortunate that the author of this article is sitting in front of me. Kidney transplantation for focal sclerosis, can we prevent it? Personal experience and literature review. So in fact, the conclusion is at present time there is insufficient data to propose that we should do routinely plasmapheresis or routinely give rituximab as prophylaxis. But one trial of prophylaxis using rituximab is currently underway in Europe. It's called PREVENT trial, but they are recruiting patients. But this strategy of pre-transplant plasmapheresis is still practiced, and I must confess that we are still doing it in some patients. Now, treatment of recurrence, there is data that plasmapheresis started immediately after recurrence does help. In early course, there's the number of sessions, how much it should be done. Usually at least 10 sessions are recommended. Insufficient data about immunoabsorption, and rituximab is usually an add-on treatment to plasmapheresis, and there's more partial response compared to complete response when you use rituximab as part of treatment. Now, any newer agents on the horizon to treat recurrent FSGS? Another humanized anti-CD20, ofatumumab, and the co-stimulation blockade, abatacept and belatacept. There are no randomized trial to support till date whether they are indeed effective. Very recently, this is one of the latest articles in pediatric nephrology about use of abatacept in pediatric renal transplant recipient. And what they did was they stained the biopsy specimen to see whether B7-1, which is a co-stimulatory pathway receptor, is expressed. And in patients who had the expression of B7-1, they administered belatacept. And again, the number were only 12, and out of 12, 8 benefited from belatacept. So what does the young nephrologist do when faced with a person who has got FSGS and is going for transplantation? because most of the things are clinical. The first and foremost thing is identify patients with primary FSGS. Now, it is important to remember that due to late presentation in our country, many biopsies are labeled as probable FSGS because there is extensive sclerosis, segmental sclerosis, and global sclerosis without a clear history of nephrotic syndrome. So please remember that only those patients are at risk of recurrence who had full-blown nephrotic syndrome before they had this biopsy. Without a history of nephrotic syndrome, one biopsy showing FSGS like lesion does not mean that the patient had FSGS, because the recurrence rate in those entities which are probably secondary FSGS or end stage because of some other glomal disease is not very high. Look for clinical risk factors, although there is no consensus which risk factors are indeed very important, but one can tell the family that these additional risk factors are present because we are doing living related transplant and it may recur. Avoid pre-transplant nephrectomy. It is not a practice, something which is practiced here, but in very bad nephrotic syndrome with FSGS, this was practiced in some centers to do pre-transplant nephrectomy so that the proteinuria ceases and the patient is in a better condition to be transplanted. But two different studies reach the same conclusion. If you remove the kidney, the chances of recurrence are higher. Now, avoid intrafamiliar donors in patients with family history of renal disease. This is very pertinent to our scenario because of live-related renal transplant. One young male has developed end-stage failure due to FSGS, maybe genetic, may not be genetic, and then another younger brother or older brother comes forward to donate, and we don't know what disease is he actually suffering from. But if in any family member, even in parents, there is history of some renal disease which has ended the patient on dialysis, avoid taking the kidney from that family because we do not have sufficient facility to go for genetic testing, which is still evolving. So there may be a role in future. And the other important point is start screening for proteinuria from day one post-transplant, especially for first 3 months, because that's the peak time of FSGS recurrence. And when it does occur, unfortunately, then the plasmapheresis should be started immediately. And if the response to plasmapheresis is poor, then there's a place of using rituximab or the newer anti-CD20 treatment. So that was FSGS. The second part is what happens to lupus patients. They are ideal transplant candidates because they are young. They had better pre-transplant management of CKD and other factors because seen by nephrologists, seen by rheumatologists, maybe cardiologists as well. They have lower likelihood of different contraindications which you often encounter in age population, and you are sure that the patient has got some experience of complex immunosuppressive treatment before transplant. So they are good candidate. But there are potential problems in lupus patients. They may be cross-match positivity, they may have antiphospholipid antibodies, and there is a higher risk of thrombosis, there is a risk of avascular necrosis, and the last thing is recurrence, which I am going to talk about in next few slides. So this is a slightly older study of 2009 where from a center from Birmingham, Alabama, and they analyzed 177 patients over 30 years, all suffering from SLE. The recurrence rate of SLE was 10%, higher in African Americans, But the important thing to note that it does not adversely affect either graft survival or patient survival. This is another important thing to note, that the patient who recurred, they biopsied them, and this is the biopsy from the native kidney, this is from the transplanted kidney. So most of the recurrence were mesangial class 2, not very bad, and some with membranous disease. There are higher chances of recurrence in protocol biopsies among lupus patients, as high as 50%. But again, most of them are class 1 and class 2 lesions. The serological activity of lupus is unreliable in predicting relapse. So what do we do when faced with a lupus patient going for transplant? Shall we delay it? There is a common belief that let the disease burn out and then transplant them because the outcome would somehow be better. What to take, whether familial donor or wait for a cadaveric donor, which there is no hope of getting one in Pakistan, and whether or not immunosuppression in lupus should be different, considering that the trials of treatment of lupus nephritis in native kidneys has changed a lot in last decade. Now this is the data of transplanted lupus patient 4,743, and if you look at this graph, the transplant lupus patients time to graft failure. So regardless of the time you wait for transplant, the outcome is no different. So in fact, those who were transplanted within 3 months of starting dialysis, shown in the blue line, is much better compared to who waited a slightly longer waiting time on dialysis. So graft loss due to recurrent lupus nephritis and living kidney donation, because that's the only way to transplant patients in our country, because lupus may be familial, and if you are taking intrafamilial donor again, then there may be some risk of added risk of getting the same disease in the transplanted kidney. But that does not happen. So this graph does show the percentage of recurrent lupus nephritis recurred and led to graft loss among differently HLA matched in living related donor transplant. So in this graph, these white bars are those who had 2 haplotype match. These are the one with 1 haplotype match, and these have less match. So the one who had 2 haplotype match had the best percentage, at the lowest percentage allograft loss due to recurrence. So in fact, it's the same thing, that if a better match, whether it is lupus or whether it is any other scenario, the outcome is better. Lastly, these are different immunosuppressive regime from different studies in lupus patients after transplant. And there is wide variation in recurrence rate, and it's very difficult to draw conclusion which immunosuppression is better to prevent lupus recurrence after transplantation. There is very little to choose from in modern era of immunosuppression. So the SLE patient going for transplant, the take-home message would be there is no need to delay transplant to get the disease burnt out. You should not rely on serology to predict recurrence. The important thing to leave for lupus patient, that is screen for antiphospholipid antibody. If it is positive, start formal anticoagulation in the perioperative period. And better HLA match is protective against recurrence. So one should not worry about taking donor from well-matched kidney within the family. And the choice of immunosuppression has little effect on the recurrence rate. And the other important thing is which is reassuring, that the surveillance biopsy has also shown that even if recurrence does occur, these are mild lesion, class 1, class 2. So you don't need to have a surveillance biopsy in lupus patient. You just go and rely on your clinical indication to biopsy a patient with lupus after renal transplantation. So that was my last talk, and thank you very much.
Thank you so much, sir, for taking out time from your busy schedule and joining us today. Now, the next lecture consists of 2 parts. And for the first part, I would like to call our chief organizer, Dr. Mohammad Tasadduq Khan. Please, sir, come on stage.
Thank you very much. So I'm again for the BK virus nephropathy. Why I'm here? Because this topic, this infection is not dealt by the ID consultants, because nothing has to be done. It has to be done by the transplant physician. So we need to know, everybody actually knows what is BK virus in the transplant, and it is such a notorious virus that it doesn't say anything, doesn't have any symptom, but it burn out your kidneys. So as soon as you get the rise in the creatinine, so you always have things in your mind that you have to go for the BK virus. So need to know, everybody knows PK polyomavirus is a small DNA virus that established lifelong infection in the renal tubule and uroepithelial. Transmission is fecal-oral and respiratory tract, and it's on the name of the first patient who was a Sudanese, which was diagnosed as a ureteric stenosis after transplantation. And infection is quiescent and benign. However, in immunocompromised, it can occur in other patients as well, HIV, SLE, and it usually get reactivated in the transplant patients. So PK prevalence is 80 to 90%. You can see this is a high prevalence, and BK urea is 30%. BK viremia is 12%, BK nephropathy is 1 to 10%. So we always go for surveillance with the BK with the actual guidelines, doing every month for the 6 months, then every 3 months for the 2 years, and then yearly for 6 years. But doing BK virus testing is not an easy task in a third world country, because it's an expensive test and you cannot always go for the BK virus. So as soon as you see a rise in the creatinine, you always go for the BK, CMV, and other infections as well to rule out other things. So it has got, the pathogenesis of this BK virus is different, and it has got numerous things that the immunology is involved, and there is a humoral immunity that is the part of this BK virus. Other pathogenesis include the tropism of the virus in the renal tubule cells and replication in these cells. Viral virulence acquired by the BK can contribute. HLA mismatch, and age more than 50 years and male genders all are found to have a relationship. Manifestation, usually subclinical acute kidney injury, BK nephropathy, premature allograft loss. So usually you see subclinical whenever you are going for surveillance. But usually what we do, or in Pakistan, usually when the patient comes with acute rise in the creatinine, when you check the BK viral load, then you come to know that he or she has got the BK virus in his urine. So risk factors, what are the risk factors? Heavy immunosuppressants, especially those who are desensitized, or those who have been given ATG for the induction, who have poor matches, and ABO incompatible and HCV positive donors. So this is the stages of the BK virus, viuria, viremia, and BK nephropathy. Diagnosing is always difficult. I already discussed that you have to actually, for the junior audience, you have to go with the surveillance protocol with every month of BK virus in urine, and as soon as you got positive, then you need to decrease the immunosuppressant. but it is very difficult to go every month. And but you can always consider BK virus whenever you got any clinical symptoms, and along with the rise in the creatinine. Whenever you are suspecting rejection, you always think of BK and CMV in your mind. So these are the tests which we can do. Urine and blood, you can see the high sensitivity. The specificity is much more high, a little bit higher in the blood. And but BK virus, as we all know, starts from the urine. So urine testing is much more in the initial stage. And if you think that there is a huge amount of BK viral load, then you can check the PCR in the blood as well. Our experience at DUHS, we have transplanted 570, and among those, 28 patients have been BK positive, and that is 4.7%, and total transplant. So the problem arises actually not diagnosing the BK virus. Problem actually arises when you send your patient for histopathology, and it comes with the BK virus along with acute T-cell mediated rejection and along with acute antibody mediated rejection, or he has or she has got acute pyelonephritis. Here the big challenge arises when you have got BK virus along with rejections, and then the physician's job starts, that how you are going to manage and how you are going to balance, because if you stop immunosuppression, you will get further rejection, and it's already rejection and BK virus. So you have to be very cautious, and you have to keep balance among the management. So these are the issues which we are facing. And what we do is reduction in the immunosuppressive, mixed rejection. We reduce antiproliferative, plasma exchange, and IVIG. Our protocol is as soon as we get the BK virus in the urine, we decrease antiproliferative agent to half. And we repeat the BK viral load after 2 weeks. If it continues to rise, then we stop antiproliferative agents. And the problem arises when there is a rejection. So we have an option of starting IVIG. There are several studies has been done that it has got some improvement in the BK virus nephropathy and the rejection with a concomitant rejection. And if patient doesn't get settled, despite of that, you have to stop immunosuppressive in order to save your patient. Because usually what we see, BK virus usually coexists with other infections as well. Because we have 3 patients who have got BK virus along with CMV infection as well. So there is a chance of getting different infection at the same time when the patient is immunocompromised. So the newer thing is CFTR gene inhibitor. And thank you very much. And I will give over to Dr. Aisha. She is a histopathologist at Aga Khan University Hospital, because all the histopathology of DUHS has been done by her. Give her a big round of applause, because she is giving us reports in within 8 hours. If I send report in the morning, I'll get reports in the evening. So thank you very much, Dr. Aisha. Over to you.
Thank you, Dr. Tasadduk, for your kind words. I would like to congratulate you for this successful international second Renal Transplant Symposium. So I would like to start my presentation. So polyomavirus nephropathy with concurrent T-cell mediated rejection. So this is a diagnostic and therapeutic challenge. So I have no conflict of interest to declare for this talk. All the pictures that have been that are present in this presentation are our own cases. So polyomavirus nephropathy is a common viral infection in renal allografts with a biopsy-proven incidence of 1 to 10%. This has already been discussed by Dr. Tasadduq that it is a non-enveloped double-stranded DNA, which after primary infection of urothelial cells is integrated into the host genome and stays dormant. So following transplant and after immunosuppression, the virus activates, replicates, and damages the urothelial cells as well as the renal parenchymal tubules. So the presence of virus in the urine, viruria, is the first step of viral activation that progresses to viremia and then to the polyomavirus nephropathy. So these are our own cases. On the left side, you can appreciate you can appreciate all the nuclei. There's a lot of nuclear enlargement and ground glass chromatin with margination of the chromatin, so giving these beautiful polyomavirus inclusions. On the right side, you can see a lot of acute tubular damage with sloughing of cells within the lumen. So these are all viral infected cells which are sloughed off within the tubules. So again, more cases from our archives showing a lot of viral infected cells with intranuclear inclusions. And this is a very robust marker, SV40 immunostain, which is a T antigen, Simon virus 40, so which shows nuclear positivity in all the viral infected cells. So it's a very robust marker which highlights all the viral infected cells. Here also you can see a lot of inclusions, and all those inclusions are highlighted by SV40 immunostain. So polyomavirus nephropathy and acute rejection, they are two closely associated diseases on opposite ends of the immune scale in kidney transplant recipients. The renal allograft biopsies from polyomavirus nephropathy can show dense tubulointerstitial infiltrates and can also show tubulitis. So these two dense tubulointerstitial infiltrates with a lot of tubulitis are hallmarks of cellular rejection. So it is very difficult and challenging to differentiate between the two entities on histology alone. So this leads to a particularly challenging problem following development of T-cell mediated rejection, which complicates the course of approximately 5 to 30% of cases already having BK viral infection. So the principle of balancing the immune system remains the mainstay of therapeutic strategy. So again, another case, sometimes these viral inclusions are very subtle and not, like you can confuse them with regenerative changes. When there is active inflammation, there is a lot of regenerative changes in the nuclear tubular epithelium. So sometimes you can confuse them with regenerative changes. So SV40 immunostain is a very robust marker, and it highlights those inclusions very well. So you can appreciate over here that this is the case of polyomavirus nephropathy with a lot of dense tubulointerstitial inflammation and a lot of tubular damage and tubulitis. So this can mimic T-cell mediated rejection. So it's very difficult to differentiate between these two at the time of biopsy. So this is our Dr. Tasadduq. I can see what he goes through when we report the cases of BK virus nephropathy, and at the same time, we also say that we cannot rule out rejection entirely on this biopsy because of dense interstitial T-cell infiltrate and presence of tubulitis. So, so a balance between these two and immunosuppression, delicate use of immunosuppression can help him solve these cases. So early diagnosis and treatment of polyomavirus nephropathy is a challenging issue in the management of patients with kidney transplantation. Currently, pathological diagnosis is the gold standard. And sometimes the typical viral inclusions, as I show you one of the cases, may not be found in early cases of BK viral nephropathy. So it should always be assessed with the use of SV40 immunohistochemical stain. So all transplant biopsies that come to our center are usually accompanied with SV40 immunostain the same day, along with C40 immunostain. So sometimes skip lesions can cause false negative results. So ideally, it is recommended that 2 renal biopsy cores should be taken, and it should include portion of medulla, because these infections, most of these infections, they arise in the medullary region first. So it is always important to biopsy part of the medulla with the renal allograft biopsies. So this is just to show the importance of SV40 immunostain recommendation to be done on all renal allograft biopsies. This was a study which was conducted in United Kingdom in 2008, and 2 of their centers performed SV40 on all of their samples, and you can see that the BK virus detection rate was 4.9% as compared to 1.6% in the other centers which performed SV40 on all biopsies. This is again one of the studies. They found that 19% of the biopsies did not show typical viral inclusions on histology. So they had to be confirmed with the SV40 immunostain. So there is prospects of, because on histology and on the basis of immunohistochemical stains, it is not honestly, it is not possible to differentiate between BK virus nephropathy and T-cell mediated rejection. So a lot of molecular diagnostics are under process to help us. So we have a long way to go, but many of these studies are finding that there is a high similarity between the BK virus and the TCMR gene expression. So this study also shows that immune gene sets demonstrated suboptimal diagnostic performance. So these studies are going on, and we have a long way to go to establish the molecular diagnosis that can help us in differentiating between pure BK virus nephropathy and a BK virus nephropathy which has concomitant T-cell mediated rejection. So polyoma virus nephropathy, there's a BAMF working group of polyoma virus nephropathy, which has developed a morphological classification that groups together histological changes, clinical parameters, and facilitates the comparative outcome analysis. There are 2 independent histological variables that are found to be significant to predict the graft function and graft survival. So intrarenal polyoma virus load levels, PVL levels, and interstitial fibrosis. So these 2 parameters are important, and they should be done on the biopsy. And this group recommends that these PVN classes 1, 2, 3, which are on the basis of these 2 parameters, they should be done on all routine renal allograft biopsies for diagnostic communication to the clinicians. That will bring a uniformity to the diagnosis and to improve the comparative data analysis. So this is some of our cases. This study is ongoing. We have a total of 10 cases, and on initial 6 cases, we did this study. And we looked at our renal biopsies, and on the basis of H&E trichrome stain, which determines the fibrosis present in the core, and the SV40 stain, which quantifies the presence of viral load. So on the basis of that, we divided our 6 cases into different classes, PVN 1, 2, 3 classes. And it was shown that like in PVN 1 class, one patient was in PVN 1 class, and on follow-up, there was significant drop in the creatinine level, and the graft was also functional on follow-up. And as compared to that, if you see one patient in PVN class 3, there was significant increase in creatinine level on follow-ups, and there was a loss of graft. So this study is kind of promising, and we are doing it are all cases of polyomavirus. So follow-up for these 6 patients showed that PVN class 1 have a better clinical presentation, graft function, and outcome than class 2 and 3. And the current data is suggesting that BAMF 19 PVN classification may play an important role in predicting outcome in these grafts. So take-home message, polyomavirus nephropathy is an important cause of allograft dysfunction in patients with kidney transplantation. And due to focal pattern of involvement, sampling error can occur in 10 to 30% of the cases. So ideally, 2 biopsy cores, which includes part of medulla, is recommended for assessing these grafts. And the routine use of SV40 immunostain on all transplant kidney biopsies should be practiced to enhance the diagnostic sensitivity of early stage disease detection. Thank you.
Thank you so much, ma'am, for such an informative lecture. Now we are inviting our third speaker of this session, for which I would like to request a very senior nephrologist, Dr. Mansoor Shah, to deliver his lecture on taming erythrocytosis and hypertension in post-transplant patients.
Let's welcome Dr. Mansoor Shah, who is working currently as consultant nephrologist at Khan University Hospital and has experience of more than 2 decades in the field. He's not only a good clinician, but also a passionate teacher.
Assalamualaikum. I would like to thank Dr. Tasadduk and the organizers for inviting me here. Started the lecture, we know that hypertension is very common among the general population. It is also very common among the transplant population as well. And usually hypertension is seen along with the other metabolic diseases such as diabetes, hyperlipidemia, and obesity, and so in the transplant population as well. And the pathogenesis is quite complex, and it includes the interplay between both the immunological and the non-immunological factors, and we'll have just look at it briefly. The prevalence is thought to be has been noted to be about 70 to 90%, but recently it has been found that it is exceeding 95%. That means almost all of the transplant population will require antihypertensive therapy or diagnosis of hypertension at some point in time. How do we define hypertension in the kidney transplant recipients? In 2017, the American College of Cardiology or American Heart Association put the levels at office BP of 130/80 and ambulatory blood pressure monitoring at 125/75, whereas the Europeans put it at a little bit higher level of 140/90 and 130/80. But KDIGO tended to agree with the American College of Cardiology and put the levels of diagnosis of post-transplant hypertension at 130/80 or ABP of 125/75. That's the level above which we should consider treatments. What is the impact of hypertension on the graft or patient outcomes? We know that it causes decline in the kidney function with poor graft survival and worse patient outcomes. And in the collaborative study, which was a retrospective cohort that looked at about almost just under 30,000 patients, they found a strong relationship between the post-transplant blood pressure and the subsequent graft failure, even when the patient death was censored and it was reported for the first time. In a subgroup analysis of about 24,000 patients, they found that keeping the systolic blood pressure, even by third year of transplant, under 140 resulted in better graft survival and patient survival at 10 years. So that's how important it is to detect and treat the hypertension in this group. Looking at the pathogenesis, we have donor factors, we have recipient factors, and we have other factors. We look at it. So the recipient transplants from expanded criteria, if they received from patients with 60 plus years of age or with a history of hypertension, they've got a higher incidence of developing hypertension, and particularly with the marginal donors where the creatinine is 1.5 or above. And especially in the Europe and USA, where the kidneys are coming from the cadavers, if the patient died of cerebrovascular accident, they are in a higher incidence of developing hypertension later. And then there is a problem of underdosing due to reduced donor mass compared to the recipient mass, that is transplantation of female to male. We know that males have got a higher body surface area than females, and then pediatric to adult population, and then thinner patients donating to obese patients. These differences result in hyperfiltration, glomerular hypertrophy, and increase in intraglomerular pressure, resulting in higher blood pressures. So we can divide the incidence of hypertension or pathogenesis into 3 periods after transplant, that is immediate post-transplant period, early post-transplant period, and late post-transplantation, because that also gives us an opportunity to find out what is the possible underlying reasons for developing the high blood pressure or what to look for in those particular periods. In the immediate post-transplant period, we give a lot of IV fluids to the patients at time of transplant, which can result in hypervolemia, and that can generate hypertension. And we know hypervolemia is also one of the causes of hypertension in the dialysis population as well. And we use high-dose steroids as immunosuppressive medications. So high-dose steroids are known to cause high blood pressures. The mechanism of action is not clear, but they tend to cause an intrinsic pressure response, which leads to arterial vascular resistance. And the dose determined has been that it is more than 20 milligram of prednisolone per day is the threshold for having hypertension, and high-dose steroids contribute to hypertension during the immediate post-transplant period and later as well. Rebound hypertension can also occur because at the time of surgery, we tend to stop the antihypertensive medications which the patient was taking in the pre-transplant time. And this is particularly true of beta blockers and the clonidine, which can cause rebound hypertension and cause increase in blood pressures. So as if they were on beta blockers or clonidine, one should reinstitute them if the blood pressure starts rising. And another thing which is the pain, inappropriate pain management. That is, if the patients do have pain, pain is associated with increased blood pressure. It acts via the sympathetic nervous system, which results in increased heart rate, increased peripheral vascular resistance, and increased stroke volume. And it also causes stimulation of the neuroendocrine system via the hypothalamic pituitary adrenal axis, which leads to pain-induced hypertension. So we should give the patients good pain control so that it does not become a factor in causing increase in blood pressures. We know that even generally, pain can cause increased blood pressures among normal persons. Next is let's see what happens in the early post-transplant period. First, let's define what is the early post-transplant period. Under optimal conditions, even the blood pressures tend to rise at about 6 months to a year's time after kidney transplantation. And we know that baseline renal allograft function becomes stable around about 3 to 6 months time after the post-transplantation. So it can be defined as a period of about 6 to 1 year's time, that is the early post-transplant period time, during which several factors may contribute to hypertension. Weight gain, as last night I heard that they tend to tell the patients that not to gain weight, and the lady was saying that that's the reason I also don't like to gain weight, because you can't tell the patient to lose weight if you are also obese. So the average weight gain in the first year of transplant, because of the increased eating habits, the high dose of steroids, and multiple other factors, about 6 to 10 kilograms. That results in increased BMI, and we know that and obesity is related, causes hypertension. What about the use of calcineurin inhibitors? The prevalence of hypertension, as we said, is at present about 70-90%. In the pre-calcineurin era, it was about 40 to 50%. So it contributes to hypertension, and there are multiple mechanisms for that. If you look at this slide, they enhance the mitochondrial oxygen stress, which results in increased endothelin-1 production, which is a systemic vasoconstriction, which results in hypertension. It causes reduced prostaglandin synthesis, which causes renal vasoconstriction, because prostaglandin is a vasodilator, and that also contributes to nephrotoxicity and hypertension. It causes reduced nitrous oxide activity, which results in hypertension, increased sympathetic nervous system activation, which leads to hypertension by causing increased heart rate, increased peripheral vascular resistance, and calcineurin inhibitors also cause enhanced sodium reabsorption, which again leads to volume expansion and hypertension. So there are multiple factors how cyclosporin or calcineurin inhibitors, although the incidence of hypertension with tacrolimus is less than cyclosporin. What about in the early post-transplant period? As we said, the early post-transplant period is to be taken about 6 months to a year's time. Steroids are also contributing to hypertension, and steroid avoidance or steroid avoidance withdrawal maintenance immunosuppression medication can be considered, but this can result, it although does help in cardiovascular outcomes including hypertension, but it also increases the risk of acute rejection, and it will not cause decrease in blood pressure much, so it should be avoided. A study in kidney transplant patients who had undergone native nephrectomy prior to transplantation received donors from normotensive donors found that all recipients were normotensive post-transplant without the need of antihypertensive therapy, whereas another study found that transplant recipients from normotensive families who found a net increase in antihypertensive requirements after kidney transplantation when the kidneys came from donors of hypertensive patients or hypertensive families. In recipients with familial hypertension or those who were prior hypertensive receiving kidney transplantation with patients with hypertension, they did not have any significant difference in the incidence of hypertension. So we can have in the pre-transplant period, hypertension can result in persistent hypertension, or they can become normotensive or recovered hypertension. If they were normotensive pre-transplant, they can become post-transplant hypertensive, or they may remain persistent normotensive depending where the kidneys or what kind of families the kidney transplantation came from. The next is renal artery stenosis also can occur in the early transplant period, and incidence is reported to be about 1 to 23%, rising with the kind of modalities we had. As the non-invasive modalities have become more common, so the diagnosis of transplant renal artery stenosis has become much more common. Refractory hypertension and worsening kidney function are the main clinical manifestations of renal artery stenosis, which usually tends to develop after about 3 months to about 2 years' time after the transplant. The stenosis can be anastomotic, that is at the site of artery anastomosis, or it can be proximal, which is related to recipient's atherosclerosis, or distal with a non-fully elucidated pathogenesis related to mechanical and immunological factors. The immunological factors that can contribute to renal artery stenosis include endothelial injury and development of de novo class 2 specific antibodies, or the association. There has also been association of stenosis with cytomegalovirus as well as ischemia reperfusion injury. How to diagnose renal artery stenosis? We have various modalities available. Color Doppler ultrasonography is the most common one, and it is widely available, but it is one also you should think, but it is also operator dependent. Then we have renal artery computed tomography or CT angio. Now we have CT angio, but the downside with CT angio and MRA is that if the renal function is poor, then we have to think of contrast-induced nephropathy as well. But the gold standard remains the renal artery angiogram. Therapeutic options for treating renal artery stenosis: pharmacological, if it is thought that the stenosis is not very significant and we can be treated without intervention, then we continue with the antihypertensive therapy. Renal artery angioplasty with stenting or surgical revascularization, especially if it is a proximal stenosis or there is kinking of the renal artery. So this is just a summary slide. Now we look at what are the possibilities of later post-transplantation, that is after years of therapy. Renal allograft dysfunction is associated with high blood pressure, both acute and chronic, both acute antibody and acute cellular rejection, and later chronic allograft nephropathy. They are all associated with the development of high blood pressures. Fibroblast growth factor declines after transplantation, but sometimes there is failure to decline, and this may cause is a risk factor for renal allograft loss and cardiovascular and all-cause mortality, and can contribute to high blood pressures. Obstructive sleep apnea can also develop in post-transplant population, and this also is associated with high blood pressures. This is a summary slide of post-transplant hypertension. On the left, we have immunological factors, which includes the renal allograft dysfunction and immunosuppression. On the right, we have donor factors, we have surgical-related factors, and we have recipient factors. What are the targets of therapy? According to the Europeans, we should keep the blood pressures less than 140/90, or according to the American Heart Association and the KDIGO, it should be kept around 130/80 or less. Non-pharmacological therapies, as for every hypertensive patient, should also be instituted in the transplant population. Smoking cessation is very necessary, and what about the pharmacological measures? Loop diuretics are essential to control the volume rather than the blood pressure control is the indication. So in the early immediate post-transplant period, loop diuretics can be used to control blood pressure if it is thought that the volume is contributing to the high blood pressures. Thiazides are uncommonly used because of their metabolic side effects and because of the fact that they may cause slow volume depletion and may cause a little bit rise in creatinines as well. Drugs like spironolactone are not very commonly used because of the hyperkalemia, and hyperkalemia also being caused by the CNI calcineurin inhibitors. Calcium channel blockers are one of the commonest drugs. They counteract the vasoconstrictive effects of the calcineurin inhibitors and which leads to post-transplant hypertension. And the calcium channel blockers have also been shown to decrease the incidence of post-transplant acute tubular injury or delayed graft function. And a Cochrane review of 724 patients also concluded that perioperative calcium channel blockers significantly decrease incidence of post-transplant acute tubular injury and DGF. Beta blockers are also very commonly used in the treatment of hypertension, and Aftab and his associates did a retrospective study on 321 patients over a 10 to 44-year period, which showed that the beta blockers had a significant survival advantage compared to those who did not. The possible protective mechanism of beta blockers is via mitigation of the sympathetic nervous system, which is stimulated in failed native kidneys. And also beta blockers have got a pro-inflammatory cytokines, which are known to increase the risk of atherosclerosis. ACE inhibitors and ARBs, they are not a no-no, but they can be used, but they can cause, we know they can cause increase in the decreased GFR, increased creatinine, which can cause confusion and lead to unnecessary work of the patient to find out the rise of the creatinine. So they should not be the first line of therapy, but they can be used as added, but preferably they used in the later part of the transplant when the kidney function has stabilized. Alpha-1 antagonists are not the first line therapy, but they can be adjunctive, can be considered as third agent or as a fourth agent, and so did alpha agonists as well. There's no drug of choice for blood pressure control after kidney transplantation, but the commonly used antihypertensives the calcium channel blockers and the beta blockers are the most commonly used. ACE inhibitors are less commonly used and should be avoided, as I said. The next part of my talk is just a brief mention of the post-transplant erythrocytosis. You know, it is reported to about almost in 1 in 5 patients with renal transplant develops erythrocytosis, which has a definition that hematocrit goes more than 51% or hemoglobin of more than 17 grams, provided it persists for longer than 6 months and without any other underlying reason. Typical onset is usually after 8 months up to 2 years of successful transplantation. 25% of the patients will remit spontaneously within 2 years, whereas some 75% of patients will persist with erythrocytosis. This is the mechanism of post-transplant erythrocytosis. That is, we say reticular renin-angiotensin system, which has got a positive association. But it causes stimulation of the erythropoietin, so does androgens, and RAS also causes stimulation of androgens, and androgens also stimulate erythropoietin, cause bone marrow and PTE. And the androgens have got a dose-dependent direct stimulation of differentiated erythroid progenitors, and sometimes androgens are used in males with anemia. And we know that EPO is the major hormone regulator for erythropoiesis, IGF factor 1 and ACSKDP are also stimulate the bone marrow. They are also involved in PTE. The risk factors include male gender, smoking. We know smoking causes secondary polycythemia, diabetes, retention of the native kidneys by causing stimulation of the sympathetic nervous system, transplant renal artery stenosis, rejection-free post-transplant course, adequate erythropoiesis prior to transplantation, and shorter duration of hemodialysis prior to transplantation. Most of the time it is asymptomatic, but because of this high hematocrit, sluggish flow can cause malaise, lethargy, headache, dizziness, hypertension, flushing, which are almost the similar symptoms which are also found in polycythemia. As I said, diagnosis is based on hematocrit and hemoglobin. What are the consequences? 10 to 30% may develop embolic thrombotic phenomena like arterial thrombosis, stroke, pulmonary embolism, and the mortality ranges from 1 to 2%. Treatment is mainly angiotensin converting enzyme inhibitors or angiotensin receptor blockers, sometimes theophylline also used, and antiproliferative agents like hydroxyurea can also be used. Phlebotomy helps a lot, but frequent phlebotomies can cause iron deficiency anemias. Different societies have also given the recommendations that erythrocytosis should be treated whether it is more than 17 grams or 51 HCT or 51%, and the first line therapies in all of them is ACE inhibitors or ARBs. If one ACE inhibitor doesn't work, then you can try another ACE inhibitor which may be helpful. Now this is how, as you alluded to, what are the pathogenesis of PTE and how ARBs, at what levels ACE inhibitors and ARBs block. They inhibit the RAS. The RAS inhibition leads to decrease in EPO, decreased bone marrow stimulation. ACE inhibitors and ARBs also inhibit the androgen stimulation of the RAS, and it also blocks the IGF factor stimulation of the bone marrow. So at multiple levels, ACE inhibitors and ARBs act. Sorry. What are the goals of therapy? The treatment goal is to keep the hematocrit less or hemoglobin less than 17.5. The treatment duration is indefinite. And if you stop the treatment, then erythrocytosis can recur. Other treatment modalities may be considered in patients who cannot tolerate the ACE inhibitors or the ARBs like theophylline and anti-proliferative agents. Thank you.
Thank you so much, Dr. Mansoor Shah. We are moving towards the fourth and key speaker of this symposium, Professor Lionel Rostaing, to proceed for his lecture on managing chronic antibody-mediated rejection after transplantation.
So good afternoon, everybody. We're going to talk about acute ABMR and then move to chronic ABMR. Okay. So first of all, a few words about acute ABMR, because it's a condition that you can come across with, because if you're not using Luminex platform, as we said this morning, you may miss some low levels of DSA that might result in acute ABMR. And then we'll move to chronic ABMR. So this is a real story, a case story. A woman, she was aged 44 years of age. She had a history of renal dysplasia. She was on dialysis. She was a mother of 3 kids. She had never been transfused, but she was sensitized through the pregnancies. She was on a kidney disease waiting list, and she was sensitized against class 1 and class 20 genes. And she underwent a disease kidney donor transplant in August 29. She had no preformed DSA. And so she had 3 mismatches, A32, DR8, and DR11. Negative cross-match was, the cross-match was negative by CDC. And the post-transplant course was very simple. There was a huge drop in serum creatinine. By day 4, serum creatinine was normal. And by day 5, she was anuric. Okay, so the Doppler ultrasound was normal. There was no vascular, no ureter issues. And so we performed by day 5 first kidney biopsy, and secondly we repeated the CDC cross-match. And the CDC cross-match became positive, so she only had acute antibody-mediated rejection, okay? And the same day we've got the report for the DSA. She had an anti-32 anti-HLA antibody, which was a mismatch. And we HLA typed the husband, but we had the report 1 week later, and the husband was A32. So she was only sensitized with regards to B cells, memory B cells, plasma cells against A32. She has lost her anti-HLA, anti-A32 antibodies, and she just had a recall immune response that resulted in thrombotic microangiopathy-like pattern because of this acute antibody-mediated rejection. So she was placed on a daily plasmapheresis 4 sessions, and then rituximab, waited for 3 days, and then 4 subsequent plasmapheresis sessions, and the last rituximab injection, and thereafter she recovered and nowadays she's fine. Okay, this was the lesions we observed, TMA, okay. Okay, so just to remind you that, well, a woman that has had pregnancies is always HLA sensitized, always. Okay, so what about chronic active antibody-mediated rejection? You may have chronic inactive antibody-mediated rejection, and you may have chronic active. We're going to focus on chronic active. It means that the activity is there with regards to having an ongoing immune response within the graft. So this is a story, a typical case of a young man. He was transplanted for IgA nephropathy. He had so on a yearly basis, we assess anti-HLA antibodies in France, it's within the guidelines, in order to detect early on de novo DSS post-transplant. And so on a yearly basis, he had no anti-HLA antibodies at transplantation, neither post-transplant. He was on TAC, MMF, no steroids, because in my center we stop steroids in every non-sensitized patient at month 3 post-transplant if the kidney protocol biopsy is normal. But the only thing is that he had very unstable tacrolimus trough levels that needed multiple adjustments, and very often he was underdosed. And so his baseline serum creatinine was perfect, and when he showed up for the 6-year post-transplant workup, within the previous month, there was a creeping serum creatinine, so it was 120 the year before, so he had de novo microalbuminuria, renal ecography was normal, BK viremia and variant were negative, but he had developed de novo DSS. And so no anti-class 1 antibodies, but however, he was positive against class 2 antibodies, and he had 2 de novo DSS, once against DR11 and once against DQ67. And the MFIs of these de novo DSS were not that high, they were at 2,000. But in spite of that, when we made the kidney biopsy, he was PTC2, I2, and he had IFTA, okay? And there were some double contours on the glomeruli. Okay, so based on these findings, he was given rituximab 1 gram once, and he was placed on tocilizumab monthly therapy IV. So 1 year later, serum creatinine was unchanged, was stable, albuminuria was reduced, DSA level was low, and we reperformed a surveillance kidney biopsy 1 year later, it was stable. And we decided to keep him on tocilizumab therapy, and he has been on this therapy for 4 years now, and his serum creatinine is stable. Okay, so just a typical case of chronic active antibody-mediated rejection. So these antibody-mediated rejections are mediated by preformed or de novo DSAs, okay? And so according to the Banff classification, there need to be some evidence for acute tissue injury in the case of acute active ABMR, and there need to be, but it's not mandatory, to have linear deposits or C4D, to have at least moderate microvascular inflammation, that is at least G lesions and PTC lesions, and the gene transcripts are never looked after. And finally, to have the presence of donor-specific alloantibodies. So DSS, well, there are many ways to detect DSS. So you can perform a cross-match. If a CDC cross-match becomes positive, sometimes post-transplant, it means that the patient has developed a de novo DSA that binds complement and that at the end of the day injure the transplant. You may perform a flow cytometry cross-match because you have a living donor still there around, and so if your flow cross-match has become positive, it means that there is a de novo DSA for sure that was not present pre-transplant. And finally, the gold standard is to use the Luminex platform SAB test just to demonstrate that there is an anti-HLA antibody that is directed against the donor. Okay, so just to summarize there. And oh yeah, one thing is that there are very few drugs that are able to decrease the DSAs. Once they are there, it's almost impossible to remove them. So regarding the band's classification for chronic active ABMR, it needs to have CG lesions greater than 0, okay? There need to be some, if electron microscopy is attempted, there are severe peritubular capillary basement membrane multilayering, but we never use this tool. And finally, there might be arterial intimal fibrosis. In addition to that, there might be some linear C40 deposits, and there might be at least moderate microvascular inflammation lesions, G plus PTC greater than or equal to 2. And finally, there might be evidence for circulating DSAs, anti-HLA or non-anti-HLA antibodies. Okay, so a long time ago, there was a study that has shown that for patients who are developing de novo DSA, that is to say, they've got some antibody-mediated rejection, if a DSA does appear at the time of allograft of acute rejection, it resulted in a decrease in allograft survival. Conversely, if there was a rapid decrease in the DSA following specific therapy, this was associated with improvement of allograft survival. This is a scenario that we see in the typical cases of acute humoral rejection, but we never see that in chronic active antibody-mediated rejection. So this was a study showing that if DSA were absent at the time of acute rejection, graft survival was excellent. Conversely, there was a DSA at the time of acute rejection, the outcome was very poor. Okay, so this is a very interesting study from the Paris transplant group. They perform yearly routine kidney biopsies, okay? And so they included a cohort of more than 1,000 kidney transplant recipients who were consecutively transplanted and all had a CDC negative cross-match at transplant. And so according to the findings of the one-year kidney protocol biopsies, plus the presence or absence of DSA, plus the presence or absence of DSAs, the patients were classified into three groups. Three-fourths of the patients had normal kidney biopsy without rejection. 13% had subclinical T-cell mediated rejection. All these patients were stable. And 14% had subclinical ABMRs. So what were their outcomes? So first of all, when they examined the kidney biopsies at 1 year post-transplant of these patients who were stable, with regards to MVI lesions, microcirculation inflammation lesions, it was absent in the setting of subclinical TCMR and absent in the cases of no rejection. Conversely, when there were evidence for subclinical ABMR, there was inflammation within the microcirculation as well as deposition of C4D. With regards to transplant glomerulopathy, by definition, it was only observed in those patients who had subclinical ABMR. With regards to interstitial inflammation / tubulitis, it was mostly present in the setting of subclinical TCMR, but you see it was also present to some extent in some patients who had subclinical ABMR. So you may have ABMR, as we all know, plus some features of interstitial inflammation tubulitis. And finally, when they look at arteriosclerosis lesion, it was present all across the three groups, but we know that it's driven by the precondition of the donor situation plus the CNI exposure, but it was significantly increased in those having subclinical ABMR. And finally, IFTA lesions were present all across the straits, the three groups, but it was significantly more frequent in those having subclinical TCMR or subclinical ABMR. And at the end of the day, what were the graft survivals in the long term? As you can see, indeed, if the patients were diagnosed with subclinical TCMR, they were treated as such with methylprednisolone pulses. If they were diagnosed with subclinical ABMR, they were treated with rituximab with or without plasmapheresis. And so what they found was that if you have no rejection at 1 year post-transplant, the graft survival is excellent, as well as those patients having subclinical TCMR that was treated accordingly. Conversely, if you were to have subclinical ABMR lesions, even though you treat them accordingly, the graft survival is poorer in the long run, but not in all the patients. And finally, the incidence of graft loss was significantly higher in those patients in whom the eGFR at 1 year post-transplant was lower than 30 or between 30 to 60. Conversely, you may have some lesions of subclinical ABMR, but if your eGFR is perfect at 1 year post-transplantation, the impact, the negative impact of the subclinical ABMR and subsequently treatment of it is nil. Conversely, when the eGFR is poor, the outcome is poorer. Okay, and with regards to the, in that series of patients, the independent risk factors for allograft loss comprised the eGFR at 1 year, subclinical ABMR, and proteinuria, which is a surrogate marker for subclinical ABMR. So what can we do when we have a de novo DSA? And how can we treat chronic active antibody-mediated rejection? So the tools we have are either apheresis, but it's mostly used in the setting of acute ABMR to remove the circulating DSA. And with regards to modulation of DSAs, we've got IVIG, rituximab, ATG, bortezomib, eculizumab, imlifidase, tocilizumab, and maybe in the future, clazakizumab, which is a monoclonal that blocks IL-6. Okay, so in fact, we have treatment effective against acute ABMR, but for chronic ABMR, it's not really the case. So with regards to acute ABMR, this study has shown that plasmapheresis, these patients who received plasmapheresis plus IVIG had a better outcome as compared to those who have had only IVIG. So I will skip that, I will just focus on, it was shown this earlier. So for chronic ABMR, what can we do? Well, these are the list of tools that we have on board. So the first trial was that it was a randomized control trial with regards to comparing placebo to bortezomib in the setting of chronic ABMR. It was a very nice design study that has shown that at the end of the day, the creatinine slope was very similar in those who were treated with placebo as compared to those who were treated with bortezomib. And so, okay, so bortezomib is not efficient, and bortezomib has no effect upon the DSA values, NFIs. Okay, clazakizumab, it's a monoclonal antibody that targets IL-6, not the receptor, but IL-6. So there was a phase 2 trial that was published recently. So 20 patients had chronic active ABMR, and they were randomized first to receive either placebo or clazakizumab, and thereafter all the patients were placed on clazakizumab. So, and what they found was that those patients who were placed on clazakizumab, the red one, had a stabilization of their eGFR. Those who were placed on placebo had a decrease in their eGFR, and subsequently, at that point, 1 year post, 12 weeks post-randomization, they were placed on clazakizumab, and thereafter they were stabilized. So it means that blocking IL-6 might stabilize patients having chronic ABMR. So these were the 2 randomized control trials. What about non-randomized control trials? So this is a trial from Spain that used plasma exchange, rituximab, IVIG for patients who have chronic ABMR plus transplant granulopathy, and they found that as compared to an historical control that was not treated as such, there was no effect upon eGFR for those who lost their graft and for those who kept their graft. So at the end of the day, this aggressive therapy for patients who had chronic active ABMR was not efficient. So as we said, blocking the IL-6 pathway is of interest because we block the T cells, memory T cells, memory B cells, plasma cells, and so forth. Okay, so this is a study from Italy. It's a non-randomized control trial in which patients who had transplant glomerulopathy, that is chronic active antibody rejection, were treated with tocilizumab for a mean time of 20 months. And they found that, in fact, despite that 60% of patients had TG lesions, there was a stabilization of glomerular filtration, and some patients had an improvement or stabilization in their protocol biopsies 6 months down the road. And also they found that some gene expressions were significantly improved. Those genes involve podocytes, mesangial, and tubular restoration cells or pathways. So this is the MFIs that did not really decrease, slightly decreased, and this is the serum creatinine that significantly decreased. This is a study that we conducted in my center in which we treated 40 patients who had chronic active ABMR. We treated them with tocilizumab, and we found that at 1 year after starting the therapy, because it's a long-run therapy, the eGFR was very stabilized. However, 6 out of these 40 patients lost their graft, so it means that in some patients it's not efficient for sure. We performed histological follow-up kidney biopsies, and the biopsies were unchanged. And finally, the chronic glomerulopathy score increased in some patients over time. And so we concluded that tocilizumab might be efficient in some patients to stabilize chronic ABMR. We skip that. So this is the eGFR of the patients before at initiation, 6 months later, and 1 year later. So it's better to prevent because we really have almost no tools to control the presence of chronic active ABMR. I thank you for your attention.
Thank you so much, sir, for your lecture and taking out time, your valuable time, and being here with us today. Moving towards the fifth lecture of this session, I request Dr. Ahad Qayyum on the topic of addressing fertility issues in post-transplant candidates.
Dr. Ahad Qayyum is a consultant nephrologist and transplant director at Behra University Hospital, Lahore.
Right. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum, everyone. So before I start, while my slides are being uploaded, I'd just like to thank and congratulate the organizers, Dr. Tasadduq, Dr. Rashid, for organizing this wonderful, wonderful symposium, and of course, for inviting me to be a part of this wonderful symposium, and of course, sort of delegating me of the task of talking about a very, very important aspect, which is most often than not very much ignored in the transplant scenario, that is to look at fertility issues in the post-transplant milieu. I've already been graciously introduced. My name is Ahad, and okay, here we go. All right, so the talk is just going to be about, briefly, I'm just going to talk about a little bit of physiology, first couple of slides, then we'll talk about why contraception counseling is important, how we can counsel, what are the maternal and fetal outcomes, is there a consensus now on when to get pregnant, and what drugs should we take off, what drugs should we bring in, is breastfeeding safe, and then we'll have a couple of slides in the end whether it's safe for the donors to become pregnant later on once they've donated the kidney. Okay, so just a bit of physiology. We know that fertility is through the hypothalamus that secretes GnRH, which is gonadotropin releasing hormone that acts on the pituitary, largely the anterior pituitary, which secretes LH, FSH, and that acts on the gonads. If it's a male, testosterone will be made. If it's a female, estrogen and progesterone will be made. Prolactin does play a part. One thing very, very important that I would bring in is that it's not the GnRH level which is important, but it's the way, the manner that it is secreted. So it has to be secreted in a proper pulsatile manner, which was demonstrated with this. This is a normal menstrual cycle for a female. Initially, GnRH coming from the hypothalamus It's a pulsatile fashion, and it's, it's a little more rapid than what it is in the luteal phase. And when the LH surge occurs, this actually increases in frequency. And as they demonstrated within this experiment was that, even if the GnRH concentration was normal, but the LH and FSH would decrease if it is not secreted in a pulsatile fashion. Then that is exactly what happens in CKD and in our dialysis population. So what is happening is, yes, there is LH FSH, but because GnRH is not in a pulsatile fashion, the uremic milieu actually inhibits that. And this is exactly what prolactin does as well. Prolactin is a hormone which is cleared by the kidney. Because the patient is under kidney failure, prolactin increases and has an inhibitory effect on the pulsatility of the GnRH. So that was that. Now coming to the transplant setting, what I've just said is this, that the LH levels and the pulsatile, I've already been through this. But all of this manifests in males in the transplant setting as erectile dysfunction, decrease in fertility, decreased libido, and gynecomastia as well. If it's a female, there will be menstrual irregularities and ovulation, decreased libido again, and infertility, of course. But the important aspect is that most, if not all of this, can get reversed within 1 year. And the average time for this to reverse is 5 months. So it is important to start counseling for contraception early. These will be high-risk pregnancies who will have to be taken care by a high-risk obstetrician. So we need to counsel regarding that. And Edith Helm is the classical example of this. She is the first female, first transplant mother who later on became pregnant in 1958. She was one of the transplants from Joseph Murray's group. So she received her kidney from her identical twin and went on to have 2 live births while the donor had 4 children. So hence proven these are pretty fertile patients. So we need to do a lot of contraception and start planning early. These things might not be applicable in the sense to our transplant population because it was an identical twin, so there was no immunosuppression used. But there and then what we've proven up till now that fertility does return. Fine. So contraception counseling is important because this is a high-risk pregnancy. We need to time this pregnancy. We need to modify the drugs before conception. So this is all very important. What does the CDC tell us? You need to discuss it with the, with the female or the male, whoever has the transplant. If they don't want children and it's been decided that that's fine. If it's a male, you go down the road of the vasectomy. If it's a female, you start counseling regarding tubal ligation. But as per CDC, the most effective one is the intrauterine device, whether it's copper T or the levonorgestrel one. And, and if you want to go down the road of barrier methods and hormonal methods, then you have to use both. But in these 3 cases, you can choose one of these. Right, so effectiveness of IUD, yes, it's in class 1. It's very, very effective. There was some talk initially that it increases the risk of infection and pelvic inflammatory disease. That has sort of been dethroned now. So it is very effective. If you're not very comfortable about talking about these aspects, it's always good to refer them to a gynecologist or obstetrician to start discussing these aspects. But it's something that we as doctors need to discuss, and we need to discuss it before start counseling it before transplant, and then discuss this on every transplant visit as well. If the intrauterine device is something that the female doesn't want to go down, then we start talk about hormonal contraception. If it's a combination of estrogen, progesterone, the oral contraceptive pill is available in Pakistan, transdermal patch, vaginal ring, I'm not sure if it's available or not, but progesterone only, the injection, the Provera depot is definitely available in Pakistan. So this is something that we need to give the information to the patients so they can go decide on that. Just a sort of disclaimer that if the female has decided that, yeah, I want to use the oral contraceptive pill, estrogen is prothrombotic, so you don't want to use that in the first 6 weeks after a transplant. So you might want to think about maybe a Depo-Provera at that time. What can we counsel as far as males are concerned? If he has decided he doesn't want a family, okay, you do go down the road of the vasectomy, or else you start counseling regarding barrier methods. So that was that as far as contraception is concerned. Outcome data, let's see if pregnancy is safe in the transplant setting, what happens with the mother, what happens with the fetus. The data that I'm going to discuss is largely from registries, retrospective data, and case reports, along with observational data as well. So there's lots of registries out there. The biggest one that I could find was the National Transplant Registry, that it's been renamed now, the UK Transplant, and the data coming out of New Zealand and Australia as well. So this is the one that I was talking about, which has been renamed. It's called the Transplant Pregnancy Registry International. Data is coming all over the globe now, from Australia, Africa, Europe, and a center coming out of Pakistan as well. India contributes, with the major burden coming from the North American countries, which is Canada and the USA. So what does this registry show? So I'll just sort of give you the highlights. So one thing was that, yes, there are lots and lots of pregnancies there. One thing to highlight is that 30% of these pregnancies were unplanned. So clearly we're not doing a good job of counseling regarding contraception and counseling these patients that how to proceed for pregnancy. And during the pregnancy, the major issue which we see is hypertension, a sequelae of which will be preeclampsia. So this is something that we need to keep an eye on very, very clearly. Diabetes, lo and behold, we're using steroids, but that's not a major issue, and rejection isn't an issue most of the time as well. Let's look at the babies now. So as far as the babies go, the live births, the rate is pretty good. It's about 80 to 81%, so there's no statistical significance there. The gestational age, so these babies most of the time will be premature, and they will be of low birth weight. So it's more statistically significant as per matched cohorts there. As I said before, it has to be a high-risk obstetrician, and you need to liaise with him or her very, very closely. So these are the significant that comes out from that registry. This was pretty much what was said by the UK registry and the ANZ data as well. The stillbirths weren't that much, birth weights again low, preeclampsia still high. So this is just a slide to sort of highlight that we sort of start thinking that these patients will end up only having 1 or 2 kids. That is not true. Quite a few patients, 31 patients, had 6 or more babies post-transplant from that international registry. Fine, so this is pretty much what, again, an observational study which actually said what I've already repeated upon. So what have we discussed up till now? What we've achieved is that, yes, the consensus is that blood pressure will probably be an issue in these patients if they're pregnant. Prematurity and low birth weight in the fetus is something that we are going to have to look out for. So is there a consensus that what are other variables? What is, what would be a high-risk pregnancy and what would be a low-risk pregnancy? So 3 things we know. If the patient has uncontrolled hypertension, that will be a problem. If the patient has a creatinine of greater than 1.5, there is a chance there will be a poorer outcome. And the protein urea, if greater than 500 milligrams per deciliter, will be a problem as well. In terms of graft dysfunction, graft loss, over time, long-term graft dysfunction hasn't sort of stood the test of time. So patients who have gotten pregnant, even after 9 to 10 years follow-up, the evidence is pretty clear as long as those 3 variables which I just denoted were under control. Okay, other factors which observational studies have sort of alluded to is pretty obvious from most pregnancies, even if they're not transplant. If they're diabetics, the mortality, I'm not saying but the morbidity rate and the outcome data is bad. Advanced maternal age is a problem. If you're poor and you've got African American race, that the outcome was poor from the data as well. So timing a pregnancy, when is it safe? It was controversial for quite a while because Kim et al. In a study, landmark study in 2011 sort of said that, less than 1 year post-transplant to greater than 1 year till 10 years, the data says the same. All the rest of the studies have negated that. So the consensus is to wait at least 1 year post-transplant and then allow them and sort of counsel that, yes, now it is safe for them to proceed if they want to father or mother a child. Surprisingly, the statement which came out from the American Society of Transplantation in 2005 has stood the test of time. It is still very, very applicable, almost 20 years now. What they've said is that you need to wait 1 year. The patient needs to be on minimal immunosuppression. when there is low risk of infections. They've added that if the patient had an episode of CMV infection, it's better to wait 6 months until CMV has been treated. A patient should have a stable graft function, no rejection in the last year, blood pressure needs to be controlled, and proteinuria needs to be under control as well. So if these things, this is sort of a consensus statement how we need to sort of carry out these pregnancies. So let's talk about drugs then. From a drugs perspective, what are drugs that we are considered safe? Well, the CNI, cyclosporin, tacrolimus, either of them you can switch to. Prednisolone is relatively safe, and azathioprine is the antimetabolite that we need to be shifting these patients to. As a rule of thumb, the main crux of the matter is going to rotate or revolve around MMF. So MMF is absolutely no. We need to stop this drug early. And when I say early, it needs to be stopped 6 weeks before the patient becomes pregnant. That will only happen if we discuss contraception and conception at every visit. There isn't a lot of information with belatacept. There are quite a few case series that belatacept is safe now, but most guidelines, including KDOQI, will sort of say that stay away from mTORs. What about corticosteroids? Corticosteroids are relatively safe because the placenta actually inactivates them. The maternal to cord blood concentration is 10:1. So, by the time, if we're going to be waiting for 1 year post-transplant anyway, so the dose would be less than 10 milligrams or 10 milligrams at max. So, the doses greater than 20 milligrams are sort of unheard of at that level. So that patient we wouldn't be allowing to go for pregnancy anyway. Azathioprine in pregnancy is safe largely because the fetal liver lacks the enzyme for converging to the active metabolite. So yes, so azathioprine, we use that, and that's not a problem at all. MMF is a major problem. It increases the rate of spontaneous abortion. It is a human teratogen, and you see a lot of problems with external layer deformities, with microtia, and then again with distal limb abnormalities, esophagus, and nervous system. So it needs to come off really, really early if the pregnancy is going to be an option. Calcineurin inhibitors are relatively safe as well. Whatever the mother is taking, 50% of that actually goes through to the placenta, to the fetus, and there hasn't been a lot of data out there which has shown that it leads to any teratogenic effect. Levels might be a problem because as the pregnancy pursues, the blood volume increases, the P450 enzyme system gets upregulated as well. So initially there is a lot of thought that we might have to increase the levels of the tacrolimus, increase the dose to make up for this level. The sort of the rule of thumb is that you do the levels every month for the first 1 or 2 trimester. In the last month, you do it every 2 weeks, and you try to maintain the level of whatever it was pre-pregnancy or you had decided upon. Again, this study coming from Herbert in 2019 actually said that it doesn't really matter whether you change the levels or not, because as tacrolimus is largely albumin bound, and it resides within the RBCs. So as the patients become anemic, and the patient starts to lose a little bit of protein, the unbound or the active form which is available actually does not go down, it actually goes up. But then again, the rule of thumb has to be that you keep on checking the levels and try to maintain it. I don't go down that road. Sirolimus, as I've already said, the European guidelines and the KDOQI is saying that don't use it. Right, so a word about breastfeeding now. Recent studies have shown that transplant patients taking the drugs that I've just mentioned are safe, and they need not be discontinued, and we should be encouraging our patients to breastfeed, and that is what this data has shown. Since 2000, the rate of breastfeeding in the US has increased remarkably as the data has come out. Tacrolimus, or less than 0.3% of whatever the patient is having, the mother is having, will be appearing in the breast milk. So it's very, very safe. What about the fathers? So we haven't talked about the fathers, also about mothers. So fathers who want to father a child and are on MMF, there is no problem, congratulations. So even if you're on MMF, the rate of pregnancies, the outcomes are very, very good. MP exposure, which is MMF, was 21%, live births 92%, birth defects were matched for cohorts. So no issue there, and this conclusion is right there. The outcomes of pregnancies fathered by transplant recipients treated with MMF appear similar to outcomes as the general population. So you don't have to switch the MMF in the fathers to azathioprine. Sirolimus, although not teratogenic if the father is taking, but does lead to a little bit of, there'll be difficulty getting pregnant with this because it decreases spermatic motility and spermatic count. So that is something just to sort of think about. Last few words about fertility in donors. So this study is something that I also used, and one should always use. What they've sort of shown is that outcomes are similar to the general population, but worse when compared to pre-donation. So what the study did was that when the donor became pregnant before donating the kidney, the outcomes were different, and once they donated the kidney, once they got pregnant after donation, the outcomes were worse. But then again, if you think about it, the maternal age would have increased by that time as well. So it should match cohorts, just something that you need to tell your patients, but otherwise donation is very, very safe. Just something, a moment of privilege more than anything else with this picture. We lost this wonderful, wonderful father of ours, Professor Tahir Shafi, 7 days ago. If anybody in Punjab is anything, in nephrology at least, it is due to the services of this legend. It's very, very unfortunate that I can't use the word living legend anymore. So request for prayers for him, and I thank you for your patient listening.
Thank you so much, Dr. Ahad Qayyum. I'm inviting now our last speaker of this session, Dr. Sabahat Sarfaraz, for her lecture on recent advances in renal transplant immunology.
Dr. Sabahat is working tirelessly with the transplant team since its inception as immunologist, and she has been providing quality results of cross matches and HLA identifications, which are the backbone of transplant. Dr. Sabahat, give a big round of applause for Dr. Sabahat.
Assalamu alaikum. Thank you for nice introduction. Dr. Sabahat Sarfaraz, I'm basically an immunologist serving Dow University of Health Sciences as assistant professor. My talk is all about recent advances in renal transplant immunology. Well, there are many diagnostic modalities have come up during last 2 decades, but my topic is all about the scope of proteomics in renal transplant, and then I'll discuss about donor-derived cell-free DNA. Okay. Donor and recipient's journey towards transplant begins by assessing blood group compatibility, matching HLA, and then antibody screening. And if the cross match is negative, then they proceed for renal transplantation. After transplantation, we assess for de novo antibody synthesis along with other laboratory parameters to assess the graft function. Rejection is still a major issue, despite of strong immunosuppression, which have been discussed by many of our eminent speakers. This is still a major challenge. It is a main factor which determines the function and long-term survival of allograft. Reliable and timely diagnosis is crucial to go for the adequate treatment. Like if we are dealing with graft rejection, we have to go for immunosuppression intensification, whereas reduction is required for BK virus nephritis, which has already been discussed. Allograft surveillance, conventional method like serum creatinine and proteinuria, basically they are insensitive and late predictors of rejection. renal biopsy is still a gold standard, but it has its own issues in terms of graft injury, sampling error, cost, and sampling error, and it's difficult to go in pediatric population. So there is an urgent and unmet need of highly sensitive and specific non-invasive biomarkers which can be used to monitor the allograft function, especially and they can predict rejection, especially the subclinical ones. Proteomics is a large-scale study of proteins, their structure and physiological role in terms of their function. Proteomics has emerged as a significant tool in recent, as a recent biomarker research. Basically, in humans, there are 20 to 25 genes. 20 to 25,000 genes, and if we talk about transcriptome, there are 2 lakhs transcriptome, and there are around 1 million proteome. A proteome is basically a cluster of expressed proteins, and these proteins, they keep on changing. They are different in fetus, then childhood, and then later on in adulthood. So these differences are utilized by researchers, and they use this information to discriminate between a physiology and the pathological states. So proteomic biomarker research is based on the hypothesis that at least one of the following condition is true. Proteins are differentially expressed from their genes during a disease process, or proteins are subjected to differential post-translational modifications due to enzyme-specific change in different enzyme activity, or proteins are detectable in different amounts because of their altered production, degradation, or release from the cells because of the underlying disease process. Basically, these proteins are assessed by mass spectrometry, which profile these proteins, and there is a wide variety of proteomics in the field of agriculture, drug discovery, food and nutrition, biotechnology, a number of diseases, both infectious, non-infectious, immunology, stem cell, and many other. So this proteome can be used as a useful biomarker because it is chemically stable, especially during the storage and analysis phase, highly specific, they express differentially in different diseases. It is easily, economically, and quickly measurable. So it can be useful, used as a useful biomarker. Proteomics analysis predicts diagnosis of recent transplant earlier compared to the conventionally used modalities, which impacts graft function and the long-term survival of allograft. This urinary proteome has played an important role in differentiating stable graft from a number of pathologies, which include transplant glomerulopathy, infections, weak nephritis, and drug toxicity. So these various biomarkers has been evaluated in the urine of kidney transplant recipients with acute rejection. They include cytokines, different renal tubular cell constituent, kidney injury molecule, interleukins 1, interleukin 18, 20, and CXC motif chemokines 9 and 10. So this is an extensively growing list of proteomics which have been evaluated so far in renal transplant recipient, and it is still growing. Multiple studies have analyzed the urinary chemokine CXC and chemokine ligands, most notably CXCL9 and 10, which is basically a marker of inflammation and acute rejection, and it is associated with decreased renal allograft function, and its level rise before serum creatinine and decrease after the immunotherapy for rejection. Wang et al. Basically identified or evaluated the plasma protein repertoire in BK virus nephritis, and he basically found that 12 proteins were differentially expressed in BK virus nephropathy. And the most prominent was calprotectin. It is a calcium zinc binding S100 protein family or member, and out of this family, 2 of them, S108 and 9, they were this study mentioned that they were significantly elevated in BK virus nephritis than in patients who were positive for urinary BK virus. Shahbaz et al. Found that among a panel of biomarker, kidney injury molecule was significantly upregulated in patients with acute rejection compared to the normal graft. Hedry et al. Performed a study in around 1,000 urinary proteins, and he found that 20 of them were significantly upregulated, and out of those 20, 3 proteins significantly predicted antibody-mediated rejection. Segdal et al. Performed a study in around 400 kidney transplant recipients. He evaluated around 35 proteins. Out of them, 11 peptides were significantly predicted acute rejection. 12 different peptides were associated with chronic allograft nephropathy, and 12 another proteins were found associated with BK virus nephritis. So, and Martens et al. Did a multi-center case control study, and he found urinary biomarker for antibody-mediated rejection in a cohort of 249 patients, and he found a set of 10 urinary proteins which accurately discriminated with patient with and without antibody-mediated rejection. Urine is basically a modified ultrafiltrate of plasma, and the majority studies have evaluated urinary proteome. Few studies have evaluated plasma because around 70% of urinary proteome originates from the kidney and the urinary tract. Only 30% are filtered from the glomerulus. So urinary proteome consists of extensive information about the kidney, and this assessment of urinary proteomics could be considered as a liquid biopsy. So we are back to basics. Proteomic studies suggest that approach of whole proteome discovery resulted in biologically relevant information on graft injury. Because rejection is a heterogeneous process, therefore single biomarker is not able to significantly differentiate between disease and a healthy state. A combined panel of biomarkers form a signature pattern which results in significant diagnostic performance. This is a large clinical trials are ongoing which are assessing urinary proteomes. Next important biomarker is donor-derived cell-free DNA. Basically, it's not associated with the cell. It's a free DNA which is present in the plasma, and it originates from the dead or injured cell, and it stays in the plasma for around 30 minutes to 2 hours. And these are short fragments of around 166 bases. Basically, they are they have been assessed as a marker of injury. Only few centers have using this modality for assessing renal injury, and basically, here you can see that in the normal state graph, it remains normal. As soon as the injury starts, its level increase and it's become maximum during active injury, and post treatment their levels comes down. So this marker can be used for monitoring of the allograft function. It's a single blood test which is non-invasive and more accurate compared to the renal biopsy and the routinely used clinical parameters like creatinine, proteinuria, and many others. This test basically uses next generation sequencing in which it detects single nucleotide polymorphism, which helps to discriminate between the DNA from the graft and the recipient. Basically, it's a simple test in terms of sample preparation. Multiple tests can be performed simultaneously within a short span of time. So this test is interpreted in terms of calculated as a percentage of total circulating DNA, combine both donor and recipient cell-free DNA. And basically, normally, it is in normal stable graph, its value ranges from 0.5, 0.2 to 0.4, and some researchers have mentioned a cutoff of 0.5 when the injury actually starts, and the majority researchers have mentioned the cutoff of 1%. That if the cell-free DNA reaches 1%, then it can predict the graft injury. So this continuous monitoring of this assay gives relevant information to tailor and is used as a useful biomarker for kidney transplant recipient. Thank you for your patience listening.
Thank you so much, ma'am, for your efforts for our transplant unit and being here for your lecture. Now we are introducing to you our few transplant recipients, the real heroes. I would like to call upon Jawad and Hashir, please proceed to towards the stage.
Assalamu alaikum. My name is Jawad Ali. I'm 26 years old. I've been a transplant recipient patient at Dow Hospital, Loja campus, and I've been operated on 20th of October, and mashallah, my journey has been really successful up till now, even though my journey is long life, but yeah, it's been amazing. And my beautiful mom is sitting right there. She in yellow. She gave me her kidney, and and yeah, everything's been amazing. And I was just operated 16 days ago, and I'm like, look at me, I'm feeling better, and it's like I'm living my second life. So I'm gonna make the most out of it. Thank you. Thank you so much.
अस्सलाम वालेकुम, मेरा नाम हाशिर है और मेरे ट्रांसप्लांट को 1 साल हो गया है। मैं बिल्कुल फिट हूँ इनकी बदौलत से। एक्सपीरियंस बहुत अच्छा रहा, मेरे को पता ही नहीं चला कब ट्रांसप्लांट हुआ और 1 साल भी गुजर गया। बिल्कुल फिट।
Thank you. Now we'll commence our question and answer session. So first from the panel of experts, then towards the audience.
Thank you very much. I want to ask some questions from Professor Ejaz. Sir, as we have small size kidneys and we get transplant, so does they have FSGS? How your biopsy record shows this? Second is, when FSGS patients are transplanted, they have some residual urine, so they have proteinuria. So how we can screen for a recurrence of the disease post-transplant in early post-transplant period?
Yes, I mean, this is a big problem that more than half of the patients who are referred to us or any other center in Pakistan, they have got small kidneys and we don't know what is the diagnosis. Because no one does biopsies on these kidney, and even if you do, it just shows very, very advanced sclerosis. So it's very difficult to say that whether what was the original disease in their cases. If there is no history suggestive of a typical picture of nephrotic syndrome, then it's difficult to say that this patient had FSGS. This problem is not unique to Pakistan. It is this presentation of small kidneys without any prior history is also present in other parts of the world. And there are different explanations of why their kidneys have failed. But my personal opinion is that there is something else other than primary FSGS at their explanation. Now, regarding the presence of proteinuria at the time of biopsy, many patients at the time of transplantation have some degree of proteinuria. So it is that any advanced chronic glomerular disease or any other disease can have some degree of proteinuria. So it does not give you much information. The only thing is that if there is sufficient amount of urine, you can perhaps quantify it and see what happens after transplantation in these patients. If the amount increases, then there is a concern that there is something new which was present in the old kidney has coming back in the new one. Apart from that, it's very difficult to say anything more about the residual proteinuria which is present at the time of transplantation.
Sir, is there any role of IV cyclophosphamide along with plasmapheresis in the management of post-transplant FSGS?
People have tried IV cyclophosphamide as in primary FSGS in native kidneys, but I mean, the very sketchy data about the use of cyclophosphamide after transplantation, very sketchy.
Any questions from the audience? No. So any concluding remarks from the chair of the panel of experts, Professor Syed Fazal Akhtar Saab?
Thank you very much. I think, first of all, I want to congratulate the transplant team of DUHS, Dr. Tasadduq, Rashid, for holding the second symposium of renal transplantation. That means it is a continuing saga, continuing CME or education for us. I mean, not only the junior doctor, they were educated, but myself, I have been educated as well. I think there were 6 very good speakers, and I learned quite a few things from them. I mean, I think for the Dr. Ejaz, I mean, he talked about transplantation with a patient with chronic glomerulonephritis, especially FSGS and lupus nephritis. And I mean, what he says, what one of the message says, that there is no time bar for transplantation with the lupus post-transplantation, and there is probably no role of plasmapheresis or rituximab before transplantation in patient with the FSGS. Then there was Dr. Tasadduq. He spoke about the BK virus nephropathy, and that was followed by the histological presentation with Dr. Aisha. I mean, things like Beaker virus nephropathy. Sometimes the Beaker virus, it causes interstitial nephritis. And sometimes it is very, very difficult to distinguish whether it is acute rejection or it is Beaker virus interstitial nephritis, because the treatment modality is 180-degree difference. And in this case, I think there was one question that was arising in my mind. Is there any role of proteasome or genomic analysis in the urine? And Dr. Sabahat explained that there is role of proteasome and genomic analysis. Perhaps in a few years' time, that we will be able to distinguish whether it is acute rejection or whether it is Beaker virus nephropathy. Then there was talk by Dr. Mansoor Shah. He talked about the hypertension in renal transplantation, and then what are the drugs and how can we prevent it. And then it was Lionel Rostaing. It was excellent talk as usual. And the thing which I was learned, that in chronic antibody-mediated rejection, if DS is only high, there is no role of rituximab and plasma exchange. If there is a role, then there is our favorite drug during the COVID, that is the tocilizumab, the IL-6 inhibitor. It might have a role, but there is no role for the rituximab. Then Ahad Qayyum talked about the post-transplant pregnancy, conception, the guideline, the breastfeeding, and that was a very, very good talk. And then Sabahat, I mean, it was very enlightening lecture about the proteasome and genomic analysis. The world is, I think it is going on that perhaps in a few years' time, instead of doing the invasive procedure of the allograft biopsy, we will be able to distinguish what disease it is by just analyzing the urine. Thank you very much. And I can see there are so many people even after the lunch. Thank you.
Thank you so much, sir. Due to unavailability of any more time, maybe a short of time, so we are not taking any further questions, but the panel and the speakers are available in the tea break. So you can answer ask your questions there. So now we are moving towards the shield distribution ceremony.
I would like to call on stage our guest of honor and Principal Dow International Medical College, Professor Zeba Haq, to please come on stage for shield distribution. First, I request Professor Syed Fazal Akhtar from the panel to please come on stage and receive your shield. Next, I would like to call upon Dr. Puran Kumar to please come on stage and receive your shield. Dr. Khurram Daniel, please come on stage and receive your shield.
Moving towards the speakers of the session, I would like to ask Professor Ijaz Ahmed to please come up on stage and receive your shield, please. Dr. Mansoor Shah please come up on stage and receive your shield, please. Dr. Aisha Hassan Memon, to please come up on stage and receive your shield, please. Dr. Ahad Qayyum, please come up on stage and receive your shield, please. Dr. Sabahat Sarfaraz, please come up on stage and receive your shield, please. Now, I would like to call upon Professor Lionel Rostaing on stage to present the memento of appreciation to Ma'am Zeba Bahak. Thank you so much. I welcome aboard our fourth panel of experts for this session, for which I would like to call Professor Rubina Naqvi, Dr. Rashid bin Hamid, and Dr. Ashar Alam.
Professor Rubina Naqvi is a very senior and well-known transplant nephrologist from SIUT. Dr. Rashid bin Hamid is our chief transplant surgeon and director at the University of Health Sciences. Dr. Ashar Alam is the medical director and nephrologist at Indus Hospital.
Now we are calling our first speaker of this concluding session of today's symposium. I request Professor Salman Imtiaz from Indus Hospital to deliver his speech on the topic of overcoming AVN and osteoporosis in post-transplant patients.
Professor Salman Imtiaz is a very senior nephrologist who is not only a good clinician but very informative and enthusiastic teacher. He has trained several nephrologists who are present here in this auditorium.
Well, thank you very much, Dr. Rashid Hamid and Dr. Tasadduq Salman for arranging this nice transplant symposium. And I also congratulate the whole of the team of DUHS for maintaining this tradition of doing this, and I hope so it will be continued in the future. I am also very grateful to Professor Rostaing for coming here for a long distance and did his energy-driven tour and did 3 programs in Karachi, and he enlightened us. And thank you very much, sir, for your updating us in transplant. My topic of today transplant is the post-transplant renal osteoporosis. So we all know that renal transplant is now increasingly performed as a preferred modality of treatment in the end-stage kidney disease, because transplant has improved the longevity and as well as the quality of life. Post-transplant osteoporosis can potentially affect the morbidity and mortality. The reduction in the bone density after transplantation is substantial, especially in the first year post-transplant, and contribute to an increased risk of fracture. यार ये कहाँ से चलेगा? यहाँ से pledge. There is a significant reduction in the bone mineral density after the kidney transplant, particularly at the lumbar spine. And about 22.5% of the kidney transplant recipients experience fracture in the first 5 years after the transplant. In the last decades, there is a reduced use of the glucocorticoids by steroid-sparing protocols that reduces the risk of the post-transplant fracture tremendously. But however, fracture risk post-transplant is still higher than in the general population. Hence, a thorough knowledge of the pre-transplant risk factor, medication side effect, and the bone morphological changes post-transplant is essential to manage the transplant recipient effectively. Bone or the bone matrix is a combination of organic and the inorganic components, the collagen, proteoglycan, and glycoprotein, and an inorganic part is the calcium hydroxyapatite. And this is this bone matrix is surrounded by 3 types of cells. The osteoblast, which produces the bone generating cells, and the osteocytes, which mineralize and form the bone matrix, and the osteoclast, which resorb the old bone and replenish with the new one. The human skeleton is 80% of the human skeleton is composed of the cortical bone. The cortical bone is tough and stout and thick, and it surrounded the bone marrow, while the 20% of the skeleton is composed of the trabecular bone, which is penetrating into the bone marrow space. There is a variation in the ratio of cortical versus trabecular bone as the age passes. The bone keep its strength by continuous remodeling, and this process of remodeling started at the resting bone surface when it becomes old, and there is an appearance of the pre-osteoclast. That osteoclast activated and causes the resorption of the old bone. Then there is an appearance of the pre-osteoblast which get matured, and there is a reversal of the phenomena. And this empty spaces are replenished with the new bone, and this mineralization of the bone occurs with the osteocytes, and this process is continuously going on. The balance of osteoclast and the osteoblast are very important to maintain the integrity of the bones. When this balance is more towards the osteoclast, there will be increased resorption and decreased bone formation, which ultimately leads to increased trabecular numbers, reduced trabecular number, reduced trabecular thickness, increased trabecular spacing, increased cortical thinning, and expansion of the bone marrow cavity, which all leads to the increased risk of the fracture, as it happens in the senile osteoporosis. There is a unique pathogenesis of post-transplant osteoporosis in the patient who have kidney transplant, as the bone change evolved through the 4 different phases. The first is the presence of the bone mineral abnormalities in the end-stage kidney disease. The second is the phase of the post-transplant where high-dose immunosuppressive medication influence bone architect. The third is the re-establishing the bone microenvironment after the few year post-transplant. And fourth is the return of the bone mineral metabolic abnormalities secondary to reduced graft function. In this landmark study, the differential, which tells about the differential expression of the osteoprogesterone, OPG, and the receptor activator of the nuclear kappa B ligand rank L in the human osteoarthritic subchondral bone osteoblasts, give a good insight about the pathogenesis of the osteoporosis. What it tells that the osteoblast express the rank L on their surfaces. When this rank L binds with the rank L receptor on the osteoclast precursor, it activated, and this fusion causes the activation and formation of more and more osteoclast cells, which causes the bone resorption very rapidly. If these receptors are occupied by OPG rather than the rank L, there is inhibition of the osteoclast activity. The hormones which increases the bone turnover, like interleukin-1 and osteoblast stromal and PTH and the vitamin D, all increases the expression of this rank L on the surface of the osteoblast. Renal osteodystrophy on the basis of the bone turnover, mineralization, and the bone volume is classified as high turnover bone disease, which includes the osteoitis fibrosa cystica, and the mixed renal osteodystrophy, and the low turnover bone disease like adynamic bone disease and the osteomalacia. During the evaluation of the patient who have an increased risk of the fracture, we should consider both pre-transplant and the post-transplant factor. Among the pre-transplant risk factor, which increases the bone fracture after the transplant, which includes the adynamic bone disease, the hypocalcemia and hyperphosphatemia, secondary hyperparathyroidism, vitamin D deficiency, poorly controlled diabetes and hypoglycemic medication, hypogonadism, family history of fracture, frailty, and age. The factor which added after the transplantation is the use of the steroid, the persistence of the secondary hyperparathyroidism, uncontrolled diabetes, tertiary hyperparathyroidism, and vitamin D. Persistent secondary hyperparathyroidism and steroid are the important one which we will discuss in. It was thought that after getting the new kidney and recovery of the renal function improved the renal osteodystrophy, and there must be a replenish of the bone again. But the study tells a different story. Like if, for example, in this randomized trial, which include 126 stable renal transplant patient, the whole body, lumbar spine and femoral neck bone mineral density was measured by DEXA scan. And it was concluded that although there is a BMD, the lumbar spine have stabilized after the renal transplant, there is a continuous loss of the whole body and the femoral neck bone mineral density. And the major cause of the bone loss after the steroid therapy and continuing parathyroid hormone with no tendency toward spontaneous revision. In another trial, which included 62 patients in which the PTH was followed for about 36 months, 68 plus minus 26 months. And it was concluded that only 20% of the patient have achieved the normal parathyroid hormone over this period. And they concluded that the spontaneous resolution of hyperparathyroidism after renal transplantation is uncommon. And in addition, the magnitude of the pre-transplant hyperparathyroidism and the renal function determine the long-term post-transplant parathyroid function. Coming to the effect of steroid, we know that they harm the skeleton by reducing the bone formation and potentiate bone destruction, leading to decrease in the bone density. The glucocorticoid effect is seen especially at the trabecular level of the vertebral bones, and glucocorticoid induce accelerated bone change in the first 6 months after the transplant. Steroid affect all level of the cells. For example, in the osteoblast cells, they decrease the osteoblastogenesis. On the osteocytes, they reduce the number of the osteocytes and this decrease the bone formation. And on the other hand, they increase the rank L, increase the macrophage colony stimulating factor, decrease the impression of OPG, and therefore they increase the activity of the osteoclast, and this osteoclastogenesis increased activity causes increased resorption of the bone. What happens if there is a withdrawal of steroid after the transplantation? So this study observed the change in the bone mineral density at 1 year following glucocorticoids withdrawal in the kidney transplant recipient. They recruited 80 patients, 84 patients, and out of which 40 were out of the steroid after 1 year of the transplantation. And then their scan was done after 3 years, and there was a reduction in the in the there was an improvement in the lumbosacral spine, but there was no effect on the femoral neck and on the hip bone. There was no effect in of this withdrawal of the steroid. Calcineurin inhibitor causes the hypomagnesemia, and this causes an increased parathyroid hormone and secondary hyperparathyroidism post-transplant. And this was the cause of bone disease in osteoporosis was poorly studied in both of the cyclosporine and in the tacrolimus. Most of the studies are animal studies, and a very little data is available of the effect of the cyclosporine and the tacrolimus for osteoporosis. There is a liver transplant recipient study in which tacrolimus was associated with a higher femoral neck bone density as compared with the cyclosporine 2-year post-transplant. So while evaluating the patient, there is a need to screen the pre-transplant risk factor, and it would be beneficial in predicting the post-transplant course. The history of the bone pain, vitamin deficiencies, hypogonadism, previous fracture, steroid use, and the secondary hyperparathyroidism should be considered. A sedentary lifestyle, malnutrition, tobacco, and alcohol usage must be addressed at the pre-transplant level. The KDICO 2017 guidelines for the post-kidney transplant patient recommend checking serum calcium and the phosphate weekly until they are more stable. And PTH and the vitamin D should be checked based on the renal function every 3 to 6 months post-transplant. How to assess the fracture risk? The FRAX is a clinical tool for predicting a 10-year fracture risk in the general population. It implements a questionnaire which include the age, sex, weight, smoking, and the alcohol history, previous fracture, glucocorticoid usage, family history fracture, and the bone density. And it is available online, and we can put the data and then we can score. And the score is done at 3 levels, like for example, patient with a high fracture risk, the intermediate risk, and the low risk. And for the high risk, there is a need to do the DEXA scan to rectify this presence of the osteoporosis. If there is, then where we can consider the pharmacological treatment. Whether FRAX predict the same as risk fracture in the kidney transplant recipient, this study was done in 458 individuals which received kidney transplant in the Canada. And 1 year post-transplant evaluation was done, and they concluded that the FRAX scores categorize most kidney transplant recipient as a low-risk fracture group. And the low observed fracture rates were consistent with the 10-year fracture prediction. FRAX showed modest fracture prediction and discrimination similar to the general population. But there is a need of independent validation for clinician to continue this as a routine clinical practice. DEXA scan is also a non-invasive and relatively accurate test that assists in predicting the osteoporosis and the fracture risk. However, DEXA scan has flaws as a predictive marker for the fracture risk. The predictive value of DEXA scan for the lumbar fracture is uncertain, particularly for the kidney transplant recipient. Based on the available data, KDICO 2017 has recommended bone mineral density testing in the renal transplant patient at the substantial risk of the osteoporosis. DEXA provides the problem of the DEXA that it provides two-dimensional measurement of the bone density. So generating difficulties in understanding the bone disease quality and strength. And the complex bone histomorphology post-transplant necessitate advanced testing beyond the DEXA. HRCT was recommended, was been done in understanding the density and the microarchitect of the cortical and the trabecular regions separately, and is currently used for the research purpose. Given its high cost and non-generalizability of the result, it needs further validation and validation by more trials. Bone biopsy is a gold standard, although invasive, for evaluating the bone abnormalities post-transplant. KDICO recommend considering bone biopsies post-transplant for patients with persistent bone pain and who are at the risk of fracture to have the guide treatment. In post-transplant patient, there is a slight increase in the osteoclastic activity, a decrease in the osteoblast function, and the alteration in the bone dynamics. And in the post-transplant patient, uremia-related bone changes are resolved. However, hyperparathyroidism changes persist, making bone biopsies difficult to interpret. The other problem of the bone biopsy is that the most centers lack expertise in the interpretation of the result from the post-transplant patient. Follow-up biopsies looking at the dynamic changes might be challenging, as this is being an invasive procedure. Bone histomorphometric changes could be different at the different sites, so that including the radius, femur, and hip bone, which could make the result difficult to generalize. The bone biopsy was done in this trial in 20 patients, 22 to 160 days after the renal transplantation. And they concluded that there is a significant reduction in the osteoid surface post-transplant. There is a significant reduction in the osteoblast surface, and there is a decreased fibrosis after the transplantation. So management, there must be a general management like stratification of the high-risk individual, regular weight-bearing exercise, smoking cessation, early mobilization post-transplant, shorter steroid course post-operative, avoidance of the medication with negative calcium balance, use of calcium 100 milligram per day and vitamin D 500 milligram international unit per day, evaluation and correction of the underlying causes. The specific management, which should address the secondary hyperparathyroidism, management of the hyperphosphatemia, bisphosphonate, and denosumab. There is a stepwise management should be considered in treating the osteoporosis among the renal transplant recipient. Treating patient with osteoporosis before or at the time of transplantation is similar to the osteoporosis management at the chronic kidney disease. Management of the persistent hyperphosphatemia and secondary hyperparathyroidism should be considered initially. In patient with no evidence of low turnover bone disease and a GFR of more than 30 ml per minute, anti-disruptive therapy should be considered. Denosumab, a monoclonal antibody against the NF-kappa B ligand, has been shown to preserve the bone density and decrease the risk of fracture in the woman. And it can be used to consider as an alternative to the bisphosphonate in patient with a low GFR. However, the rebound risk of the spontaneous vertebral fracture after discontinuation of the denosumab and the hypocalcemic risk should be considered. So, in a randomized control trial, which consists of about 90 kidney transplant recipients who were randomized 1-to-1, about 2 weeks after the surgery, who received 2 doses of denosumab, 60 milligram at the baseline and 6 months. And then they followed, and there was a significant improvement in the total lumbar spine, but there was a moderate effect on the total hip and the femoral risk. And this study showed that there is an increased risk of the fracture after withdrawing of the denosumab. So the use of the denosumab is being advised to use the pamidronate after the use of this denosumab. So to conclude, post-transplant bone disease is complex, and the management should focus on correcting the metabolic abnormalities associated with the bone disease. The primary goal is to identify the high-risk individual and implement preventive strategies to help them minimize fracture risk. Fracture are associated with increased mortality and morbidity. Multiple medications have been shown to reduce bone loss post-transplant. However, no substantial data is available regarding the clinical outcome. Therefore, there is a significant need of high-quality evidence-based studies in order to develop the treatment modalities that could help mitigate the fracture risk following the transplantation. Even though DEXAs can help predict the bone density and fracture, significant limitation exist in predicting the fracture risk in the renal transplant recipient. Hence, more sophisticated imaging modalities to conveniently identify high-risk individuals are further warranted. Thank you.
Thank you so much, sir, for being here and educating us on such an important topic. Our next lecture consists of 2 parts, and for the first part, I request Professor Lionel Rostaing, our key speaker of today's symposium, to enlighten us on ABO incompatible transplants and its outcome.
Thank you. Good afternoon again. So I have no slides. So we're going to talk about ABO incompatible kidney transplantation. So ABO incompatible kidney transplantation has been mostly used in Japan because in Japan they only rely on living donors, and they came across very rapidly with ABO incompatible cases, and thereafter it was developed in Korea. And with ABOIs, the results are very good in the long term. They are as good as those from ABO-compatible transplant thanks to pre-transplant desensitization. And this is based on eliminating the isoagglutinins by means of apheresis, if needed, plus immunosuppression that includes, in those days, splenectomy, and now it's rituximab plus immunosuppressive drugs. So having a shortage of potential living donors, having on board ABOI donors will expand the pool of donors. And this is what we did in France, and I was a pioneer in France in 2011 to introduce ABO incompatible cases. And during my various visits to Pakistan, I came across with a young resident in nephrology in FIIU some years ago, Dr. Naveed Sarwar. And since 2019 is my mentee. And under my mentorship, he succeeded in realizing 3 cases of ABOI cases in Rawalpindi in Marriott Hospital. And so I will leave the floor to Naveed Sarwar, my mentee, because he has everything in hand to present you how is it practically realizable or feasible in Pakistan. So Naveed.
Thank you so much, sir. For the second part, I am requesting Dr. Naveed to come up on stage and enlighten us on your topic.
Dr. Naveed is working as a transplant nephrologist who has specially arrived from Rawalpindi to attend this symposium and deliver his lecture today. Dr. Naveed.
Assalamu alaikum. Thank you, Dr. Adam, for such a gracious introduction. I will be going through the practical implementation that the protocol that we have developed under the mentorship of Professor Rostaing Lionel to set up an ABO incompatible transplant program at Diarrhea Hospital. Okay, so the outline would be brief introduction, the desensitization protocol, our experience, and the future directions. So the only the rationale for ABO is expansion of the donor pool to overcome the organ shortages and to curb the market of an illegal transplants. So for the recipients, like for A, B, and blood group O recipients, they are natural anti-AB isoagglutinins, so that you need to avoid with an ABO incompatible transplant. So there are basically 2 types of isoagglutinins. IgM, they are notorious for on-table hyperacute rejection, TMA-like pictures, IgGs for delayed ABMRs. Okay, so pre-desensitization is required as mandatory. So what are the ways to do the titers estimation? So the simplest one is the tube titration, and the reliable one, which is reproducible, is the gel card, which gives you a separate report for IgM and IgGs. So here's a report where when we order so we get a separate result for IgMs and IgGs, and it's in the one log, so we can easily titrate it. So obviously, ABO incompatible transplant is a high-risk transplant, but if you have to further categorize it into a low and a high-risk category, so the low risk would be A2 donor, the recipient of blood group O, and the starting titers of less than 1:16. The high-risk any blood group other than A2 donor or recipients of blood group O, for some unknown reasons, they are more prone to have AMRs as compared to the recipients of blood group A or B, and the starting titers of 1:164. And if it's a combined HLA and ABO incompatible transplant, so it's a high-risk transplant. So what's the patient selection criteria? So the best effort should be put into avoid and to find a blood compatible donor. patient's motivation to start with A2 donor and no DSs in the recipient. So it's a general guideline for the patient selection. So I will go through how we have desensitized, and it's rituximab mainly and apheresis. And we have used conventional plasmapheresis and selective immunoabsorption both. So it's a single cohort from a staining study where basically it's highlighting the use of rituximab in a desensitization protocol, where they have lost about 6 kidneys and from 2010 to 2019, where they have performed about 66 transplants without using pre-transplant desensitization using rituximab. So these are the various modalities. First one is the plasmapheresis, the DFPP. We don't have the DFPP. DFPP is exclusively used in Japan. The plasmapheresis in the US, and specific immunoabsorption, which is practice of European countries. So our protocol is it's mandatory to give rituximab minus 30 days and apheresis in the form of selective immunoabsorption or conventional plasmapheresis. इसका ये highlighter. So this was our first patient here, day minus 30. So that it was A1 to B. The starting titers were 1/64, 1:64. So day minus 30, we gave rituximab, 500 milligrams standard prophylaxis, well-site, Septran twice a week with the Moxil and Vorif. At day minus 15, we start standard triple immunosuppression. And at day minus 10, we estimated the titers, but there was no reduction of any log. And we did 5 consecutive back-to-back plasmapheresis, 1.5 volume plasma sessions. And on day 0, we did the induction with the Similac and did the transplant. We did it about a year back, roughly 12 months back, and so far he's doing perfectly fine. And here's the second patient where we have used the same protocol for desensitization pre-transplant retux. Day minus 15, we started the triple immunosuppression. And here we have done a single session of a membrane plasma suppression plus selective immunoabsorption, where we have treated about 30 liters of a plasma in a single session and reduced the titers to 1:8. And this is the third one, where the starting titers were 1/28, and we gave the standard pre-transplant desensitization retux minus 30 days, 500 milligram. And on day minus 1, we did a single session of in-tandem procedure, which is a simultaneously use of hemodialysis, plasmapheresis, and selective immunoabsorption, and the transplant on the next day. So here, this is a pictorial description. Like the first machine is doing hemodialysis, the second one is membrane plasma separation, and the third one is doing selective immunoabsorption. So if we have to connect the machines in like all together, what are the options to connect them in circuit? So first one is the parallel connection, where you can run 2 machines with the different inputs. But we have used this in the series, where we first give supply to the hemodialysis, then we took the venous output from the dialysis and then use the next 2 machines. So we will show you in the video. This is a short video of 4 minutes showing how we have done in tandem procedure. 55. So to start with, he's our dialysis nurse, chief nurse, and he's going to demonstrate the various connections, the various bypass circuits that we are using. To start with, we will first take the blood from the artery of the patient. We have pricked his AV fistula, and this is the inflow, and that is the first pump. It's going into the first dialysis machine. It's a conventional hemodialysis being going on. The pump is running at 200 mils per minute. And from here, the blood is going into the dialysis. It's a conventional dialysis filter, FX10, and the blood is being dialyzed. And now the blood is coming back as routine from the outflow from the venous system into the patient, towards the patient. And now here we have attached a specialized Y connector. We are going to demonstrate the Y connector here. It's split into 2. Okay, so now the outflow is divided into 2 from the venous return that is coming towards the patient, and the one blood is going back to the fistula, to the patient via a venous needle. Okay, here you can see half of the blood is being returned to the patient. Okay, now The blood from the venous chamber that we have split into two is now, we will show you the feed of the second machine. Here you can see we have taken the inflow for the second machine, and here is the inflow for the membrane plasma separation. The machine is run at 100, the pump is at 100 mils per minute. You can see, and now from that, you can see that the blood is going through the plasma filter. It's in the reverse configuration. The blood is going from downwards. Okay, and this is the specialized Plasma Flex P2 filter imported, and it's being marketed and assembled by Fresenius. It's specialized use for membrane plasma separation. And from here, the plasma feed is generated. And now, after the plasma feed is generated, the venous return, we will show you the venous return. No, first this venous return. The blood that is being returned from the P2 plasma flex filter, here you can see we are using the conventional hemodialysis connections, the tubings, and now here it's being attached to the second Y connector, which we have attached to the venous limb. And here you can see that the two inflows coming from two machines, they are going back towards the patient, and the blood is returned simultaneously through a single needle. And now back to the second machine, we will show you how the plasma is generated. Here, if you can see that we have kept the lower end clamped. Here it fills the column, and from here we have the outflow of the plasma. It's a specialized connector that we have also imported for taking the outflow feed. Because it's a selective immunoabsorption, we need a continuous feed of plasmapheresis, and that's why we are generating a continuous plasma. From here, there's an outflow that is coming from the P2 in the form of the plasma. And here you can see the plasma is going through the third machine, and the pump is being run at 25 mils per minute. Basically, it's a ratio, extraction ratio of plasma filter is about 25%. So if you keep the pump of the second machine at 100 mils, you have to keep it at 25 mils for the third machine. And from here, from the third pump, you can see, and from here, you can see the feed is going through this vitrosorbed column. This is a specialized Secreman column imported from Switzerland, which is used for selective immunoabsorption, and it is NTB basically. It will absorb all of the NTB isoagglutinins, IgM and IgGs. And now, from here, this is the outflow, which is the plasma. The plasma which has been generated and treated will be returned to the patient. And now we will show you how we are returning the plasma to the patient. And here we have used the venous chamber as a routine of conventional hemodialysis machine. And here the plasma, treated plasma, is coming back towards the patient. And on the second machine, which is generating the plasma, we have attached it to the venous chamber. Here you can see whole of the treated plasma is being returned to the patient. And now for the second machine, we will show you how the blood is being returned. Here you can see this is the outflow from this, the second machine, and to the second Y connector, it's attached, and the whole blood is simultaneously returned to the patient. And that's how we are doing it, and we will stop. So this is a blood product selection guide. So if you have, you need a very good hematology supply. If you have a donor from the A and the recipient is B, so it's a bidirectional mismatch. So you need to have the platelets or FFPs of AB type. So we are lucky to have Rostaing. It was a proof of concept that treating a single session of high volume plasmapheresis, like 30 to 40 liters of plasma, you can easily get rid of all of the isoagglutinins without little or no rebound. So a short word regarding the columns, where there are various types of columns, selective, non-selective. This globefin column is used for HLA incompatible transplants. We have used this vitrosorb, which is non-reusable, but it doesn't saturate. This is the Russian one, which is reusable up to 20 times, and this is glycosorb, which saturates, and non-reusable one. So what's the protocol for monitoring? It's a standard is AVO incompatible, is for AVO compatible transplants. If the DSAs are persistently high, so don't need to monitor the isoagglutin titers unless they are indicated. In case of ABMR, Doppler, nothing special. So what's our experience? We have attempted 3 patients so far, and one is 12, 6, and I think so last one is 4th month old, yes. And there is a biopsy-proven accommodation in 2 patients. There was no episode of AMR in any of these 3. One patient, the second patient had a rebound of 1024, but there was no drop in the urine output. So it's a paradox. No one really knows basically what's the pathology, like how important or relevant the isoglytin titers really are. And the last one, there was acute shutdown of the output with the essentially 0 titers, and we did the plasmapheresis on the 0 post-op day, and he resumed the output, and so far he's fine. So this is one of our patients where you have PTC C4D positivity, and it was suggested for accommodation. That was plus 50 days the transplant. So we had only one complication that we have so far documented. It's lymphocyl in 2 patients out of 3 surgical. It's known to have like lymphocyls are common in ABOs. What are the future directions? So under the mentorship of Professor Rostaing, we are privileged to start this as a regular procedure in our setup for ABO incompatible transplants using selective immunoabsorption. ABO incompatible transplant is trivial, it's simple as compared to HLA incompatible transplants with a good hematology and immunology support. It took us 3 years to set up a reliable titer lab, but so if you are comfortable with the titers, so I think so 50% of the work is done, because you need to have a very reliable source of titers. Introduction of MPS is the standard method of choice where you can do a bedside plasmapheresis just using a filter like a hemodialysis. And we will be attempting an ABO plus HLA incompatible transplant, inshallah, in near future, like in 4 weeks. And that's it. Thank you.
Thank you so much, Dr. Naveed, for your talks. Now we are proceeding towards the third lecture of this session. I request Dr. Mohammed Mubarak from SIUT to please come and deliver his lecture on diagnosis and classification of rejection, a journey through Banff classification.
Dr. Mohammed Mubarak is serving as head of histopathology department at SIUT and who has special interest in post-transplant care and management. Dr. Mubarak.
First of all, I must thank Professor Rashid Hamid and Dr. Tasadduk Khan for inviting me to give a talk on diagnosis and classification of renal transplant rejection through the eyes of Banff classification. In your program, you have written that added the prefix of beyond the microscope. In fact, that is the holy grail for us. We are still grappling with the microscope, and this talk will be related to the microscopic diagnosis of renal transplant rejection. So I have no disclosures. This is the plan of my talk. First, we will define rejection, what is the theory of rejection, and then how we diagnose and classify rejection in practice. And we will briefly review the Banff classification and its updates, and we will conclude with some take-home messages. So theory is very simple. Rejection is nothing but damage of the graft parenchyma, and that is manifest by either inflammation, which is an acute process, or it can be scarring, which is a chronic irreversible process. Inflammation is reversible, it can be treated, but scarring cannot be treated. And this damage is caused by specific immune system. So there must be 2 types of rejection. And we know from our knowledge of immunology, pathology, that there are 2 arms of the specific immune system. One is antibodies, the other is T cells. So it can be divided into 2 types. In fact, there are 3 types. The third type is that of mixed. It can be acute, it can be antibody mediated, it can be T cell mediated, it can be mixed, combined T cell and antibody mediated. And all these 3 types can be either acute or active. They can be chronic or they can be acute and chronic. This is the ideal classification. This is an actionable classification and is clinically useful. But BANF has taken 30 years to arrive at this classification. We will see how the previous BANF classifications divided rejection. So classically, the rejection was divided on the time of its occurrence after transplantation into hyperacute, accelerated, acute, and chronic types. And as you can see, both arms of the immune system take part in it. In fact, the scope of antibodies is much broader. It can also cause hyperacute rejection. And hyperacute rejection is not caused by T cells. So the scope and power of antibodies is much more than T cells. However, in earlier BANF classification, the main focus was on the cellular part of rejection. In practice, majority of cases, in fact, the majority of cases are mixed T cell and antibody mediated. Pure rejections are less in frequency. So there are, as in native kidney, there are 4 components of the graft parenchyma. These consist of glomeruli, larger vessels, and tubules and interstitium. Interstitium is not normally visible under the light microscope. Now, each of these 4 components may be involved by either T cells or antibodies, may be affected. But the main targets of T cells are this component, tubulo-interstitial component, and larger vessels. Whereas the main component of antibodies is the microcirculation, the glomeruli and peritubular capillaries. And of course, antibodies can also involve major vessels. So major vessels, arteries are affected by both T cells as well as antibodies. So how we diagnose rejection in practice? Of course, rejection can be suspected on clinical grounds by laboratory tests such as serum creatinine and on imaging studies. And more recently, molecular markers have also been used to diagnose rejection. But the only definitive test is the renal allograft biopsy. And you can classify rejection only on graft biopsy. You cannot classify rejection with any of these other modalities. And renal allograft biopsy is considered the gold standard, but it is not a perfect gold standard. There are some limitations of biopsy diagnosis. So this is the beginning of rejection. It begins like this very patchy, subtle process, but if you do not treat it, it will evolve into this final picture. There is complete scarring of the graft parenchyma with involvement of all components. There is arteriosclerosis, global glomerulosclerosis, severe tubular atrophy, interstitial fibrosis. So obviously we do not want this fate of the graft. And in between these two extremes, we see as many patterns of rejection as there are graft biopsies. So this was the pure form of rejection, purest form of rejection. This was the first renal graft biopsy that was performed in 1952. The slides were recovered and they were stained. As you can see, there's a mixture of antibody and T cell mediated rejection. And there's diffuse infiltrate, and many of these lymphocytes appear activated. There's diffuse infiltrate. So there, obviously there will be no issues in the diagnosis of this type of rejection. But unfortunately, we don't see this type of rejection anymore because we are giving immunosuppression. In this patient, no immunosuppression was given. But we see this type of rejection where there's only patchy infiltrate. So how to diagnose it, how to classify it, that is the main challenge. So what are the challenges? Why biopsy is not perfect gold standard? Because the rejection process is a patchy process. So it can result in underdiagnosis and undergrading of rejection. And moreover, it is gradual process. It takes time to develop. So there's BANF has addressed this by creating a borderline category. And basically, rejection is nothing but an inflammatory response. So, and there are many other causes of inflammation. So we have to devise criteria for the diagnosis and classification of rejection. And finally, the histopathology is a subjective field. So there is obviously inter-observer variation. And not all components of immune system are visible or detectable on under microscope. For example, antibodies are not seen under the microscope. Hence, the role of T cells and antibodies in rejection was quite debated for quite some time, especially during the early period. So, what were the criteria for pathologic diagnosis and classification of rejection before BANF classification? There were, in fact, no uniform or internationally agreed upon system for diagnosis or classification. Different pathologists were using different definitions of rejection. Even the presence of a few lymphocytes within the graft biopsy was considered sufficient for the diagnosis of rejection, which is in fact true if provided these lymphocytes are allo-specific. Even one lymphocyte can constitute rejection, but the requirement is that it must be specific, allo-specific. So traditionally, as we have seen already, the rejection was classified on the basis of time duration, but this was not very helpful for the management point of view. For example, if there is acute rejection, how will you treat it? You have to know whether it is caused by T cells or antibodies, whether it is acute or chronic. So this designation, this classification is not useful for the classification. This is the place where BANF classification took place. It is a small town in Canada where the first meeting of BANF classification took place, and this is the person, Kim Soles, who is the driving force behind this classification. And this is the first paper from this full paper that was published in 1993 in Kidney International. And in fact, the first BANF classification took place in 1991, and the paper took 2 years to complete. And as you can see, it was labeled as BANF working classification because it was thought that it will evolve over time. So what were the objectives of BANF schema? They were threefold. The first was to standardize the nomenclature and classification of kidney allograft pathology. And the second aim was to achieve uniformity in the reporting of renal allograft pathology throughout the world. And finally, to guide therapy in transplant patients and to serve as objective rejection endpoints for clinical trials. So how did the BANF approach the challenges of biopsy diagnosis? So first of all, BANF defined adequacy criteria for an optimal biopsy. And for gradual process of rejection, BANF created the category of borderline rejection. And for subjective nature of the biopsy interpretation and to differentiate it from other causes of inflammation, BANF identified or in fact produced different scoring of different lesions. As you can see, there are 4 components in the graft parenchyma. These are glomeruli, interstitium, tubules, and vessels. So each of these can be involved in rejection process, and the process can be acute. G stands for glomerulitis. It is an acute lesion. I stands for interstitial inflammation, and CG stands for chronic glomerulopathy. This is chronic lesion. So these are different types of lesions which are used to make diagnosis of rejection and its classification. And BANF also described the minimum threshold for the diagnosis of tubulointerstitial rejection, and that was I2, interstitial inflammation of moderate degree, and T2, tubulitis of moderate degree. And BANF also developed specific criteria of rejection diagnosis, as we saw in previous slide, and its classification into grades and types. This was the first BANF classification, 1993 classification. As you can see, there were 6 categories. First is normal and 6 is other. The rest of the 4 categories were related to rejection diagnosis. So the BANF was focused on rejection diagnosis and classification. Category 2 as you can see, was named as hyperacute rejection. And at that time, it was thought that antibodies can only cause hyperacute type of rejection. And there's no role of antibodies beyond hyperacute rejection. The category 3 and 4 are related to the T cell mediated rejection. Now we recognize that it is T cell mediated rejection, but at that time it was just labeled as acute rejection. And this is the chronic, category 5 was related to chronic allograft nephropathy. The BANF 93 classification was soon modified. In fact, it was modified in 1997, modified into the BANF 97 classification by the merger of BANF 93 classification and CCTT classification, which was being used in USA. So here you can see the category 2 has changed to antibody-mediated rejection, and the role of antibodies was expanded a little bit. And it was divided into two types, hyperacute and accelerated acute. But the role of antibodies beyond immediate post-transplant period was not still recognized. And category 4, as you can see here, it was divided into types. And in first classification, it was divided into grades, grade 1, 2, 3. But here it was divided into types. Type 1 is tubulointerstitial rejection. Type 2 and 3 both constitute vascular types of rejection. So earlier BANF classification was based only on light microscopy. And there was little focus on the role of antibodies beyond immediate post-transplant period. And T cells were considered the central part of rejection process. So why cellular theory dominated during early years? Because T cells were readily visible in the biopsies under the microscope. Antibodies could not be visualized, either directly or indirectly in the biopsies. And morphological features and targets of antibodies were also not known for quite some time. And moreover, there was no effective therapeutic options were available for antibody-mediated rejection. So this was the latest BANF classification. As you can see, the complexity, previously the BANF rejection was only half column report, but you can see how much it has expanded in the latest classification. And this expansion evolution has taken place in almost all categories, particularly the antibody-mediated rejection category. Here again you can see from single line it has expanded much, particularly this antibody-mediated category and the acute rejection category. These have expanded much. And we have already discussed that BANF introduced the borderline rejection. This is how borderline rejection looks under the biopsy. There's only mild interstitial inflammation of I1 grade, and there's no tubulitis. There is infiltrate, there's I1, but there's no tubulitis. It is borderline rejection. This is type 1 rejection. Here you can see tubulitis. In addition to infiltrate, when you see tubulitis, this is T2, moderate tubulitis. And in case of T3, this is again rejection with severe tubulitis. It will be called 1B. This is intimal arteritis, V1, focal intimal arteritis. This will be labeled as type 2A. And this is severe intimal arteritis, V2 lesion, and this will constitute type 2B. And this is transmural arteritis, type 3. So type 1 is tubulointerstitial rejection, type 2 and 3 both are vascular rejection. And these vascular rejections can be caused by both antibodies as well as T cells. So BANF has evolved substantially because of development of newer sophisticated techniques, particularly for the detection of antibody action in the biopsies, as well as their detection in the serum, and development of therapeutic regimes for antibodies also led to interest in the rejection in the diagnosis of antibody-mediated rejection. So this is a schematic diagram showing these years represent the BANF meeting years. As you can see, these are the evolutionary changes that have taken place in the category of T-cell mediated rejection. In fact, previously it was recognized that T-cell mediated rejection is only of acute type. In BANF 2017, it was added that they added this category. T-cell mediated rejection can also be chronic active, and it was divided into grades 1A, 1B, and grade 2. And in BANF 2019 meeting, they also included T-IFTA, that is tubulitis in areas of scarring were also considered for the diagnosis of chronic active T-cell mediated rejection. So previously, the focus was on I, T, and V. I is interstitial inflammation, T is tubulitis, and V is arthritis. And also some consideration was given to chronic vasculopathy. But now they have also included total interstitial inflammation, I-IFTA, T-IFTA. So rejection, and what is new in I score? Previously, BANF ignored the infiltrate in atrophic areas, but now they say that it is also important. So they have introduced a lesion which is interstitial inflammation in total, TI. It includes both scarred and non-scarred, infiltrate in scarred and non-scarred areas. And what is new in that T score? Tubulitis was also previously ignored in atrophic areas, but now they have introduced a new lesion with the name T-IFTA. So tubules in atrophic areas can also be ignored, can also be considered for the diagnosis of rejection. This is an area of IFTA. There is an infiltrate in atrophic area, so this is I-IFTA. And this is T-IFTA. These are atrophic tubules, but you have to take into account these lesions for the diagnosis of chronic active T-cell mediated rejection. Again, IFTA and T-IFTA. This is chronic, type 2 of chronic T-cell mediated rejection with intimal fibrosis. So, in fact, most spectacular changes have taken place in the diagnosis and classification of acute of antibody-mediated rejection. Initially, little attention was given to antibodies, as these are not visible under the microscope. But the turning point was the discovery and widespread use of C4D and parallel developments in immunology and clinical practice. Development of antibody drugs against antibody-mediated rejection. This is the timeline of changes in the antibody-mediated rejection category. Again, you can see from single name of hyperacute, it has evolved quite markedly. Even it has evolved more in subsequent BANF classifications. In BANF 97, it was first time labeled as antibody-mediated rejection and divided into two types. And this is how the antibody-mediated rejection has now become in BANF 2019 classification. It has expanded very much. So why antibody-mediated rejection has evolved? It took almost 10 years, numerous studies and use of C4D and more sensitive techniques for detection of antibodies in serum to make these all changes. And as you all know, C4D is a stable degradation product of complement component C4. And it is detected in peritubular capillaries and also in glomerular capillaries. So for the first time, criteria for antibody-mediated rejection was added to the BANF classification in 2001 meeting of BANF classification. So there were three criteria: histological, immunohistological, and serological evidence. So in this, you can see it was divided into three types. And in BAMF 2005, it was divided into acute and chronic active forms. And in the most latest classification, it has been divided into acute, chronic active, and chronic inactive types. Still 10 years later, in BAF 2013 meeting, some major changes occurred in this category. Microvascular inflammation was considered as an evidence of antibody-mediated infection, even if they are C4D negative. And molecular studies were also incorporated, and C4D negative antibody-mediated rejection was also incorporated into the BAF classification. This is the glomerulitis. It is a marker of antibody-mediated rejection, and this is peritubular capillaritis. Sum of both is constitutes MVI, microvascular inflammation. This shows the BAM 2013 meeting, and for antibody-mediated rejection, the lesions are G plus PTC plus C4D, CV, CG, PTCML. This, in case of chronic active antibody-mediated rejection, there's glomerulitis as well as TG and peritubular capillaritis. So we can skip this. So what is new in the full workup renal allograft biopsy? Now we have to do immunofluorescence for C4D, immunohistochemistry for C4D and SV40 large T antigen, electron microscopy is still optional, and gene transcript molecular markers are being increasingly used. So to conclude, kidney transplant pathology is still evolving, and major changes have taken place in the diagnostic criteria and classification of rejection, and increasingly more sophisticated approaches are being used to refine and optimize biopsy interpretation, and transplant pathology diagnosis has become a multidisciplinary undertaking. Thank you very much.
Thank you so much, sir. Moving towards the fourth lecture of this session, I request Dr. Nayyar Salim to deliver his lecture on hurdles to set up a transplant program in a resource-constrained country.
It is commendable that Dr. Nayyar Salim has started a transplant program at Multan Institute of Kidney Diseases and is leading a successful center which has done more than 60 transplants. Dr.
Okay, thank you for the nice words. Thank you, Dr. Tasadduk, for arranging this very comprehensive transplant symposium. At least I have refreshed whole my transplant knowledge in one day, at least. So thank you very much. So let's start with the presentation. It's not very much academic or studies are not. It's mostly a health policy related presentation and what the difficulties we are facing and how can we overcome it. And the few slides about the deceased donor program, how can we proceed with that, which I think is the future of the transplant program in Pakistan. So brief introduction, you already know me. I'm just working as a transplant nephrologist at MIKD. So nothing to disclose. So brief outlines, what we would like to discuss is just the burden of the disease in Pakistan, the cost comparison of the different forms of renal replacement therapy, and then what are the obstacles in the Pakistani program. Then we'll discuss about deceased donor program and what are the way forwards to increase the transplant in Pakistan. So kidney disease, it's a public health problem. It's not only in Pakistan, but all over the world, this is a problem. Roughly 200 per million population new ESRD cases are reported in South Asia. So it's, if you convert into Pakistani population, roughly 30,000 patients are on dialysis every year. Mostly living in the rural areas with no access available to the healthcare facility. And they are coming with, suddenly coming with small kidneys with a creatinine of 15, and they start with the uremic symptoms, and you have to put them on the, so relatively healthy population, not much comorbs, good candidates for the transplant, and a young patient who can be very productive even if we transplant them. the problem is that no access available to the dialysis. So either, even if they are started on the dialysis, the quality of the dialysis is also not very good. So most of them, they die within a few months or years. So even in the urban centers, there's too much, they are crowded centers, and twice a week dialysis is actually a norm here, which we don't see that in the Western population. So renal replacement therapies in Pakistan, so hemodialysis is the most predominant. It's received large amount of allocated funds. So government spend a lot of money. At least in Punjab, they are supporting it with the insurance system, which is Sehat Sahulat program. The other form is the peritoneal dialysis. It's largely neglected owing to the high cost of the fluid, especially with this devaluation of rupee, and because all the fluid is imported. So it's almost negligible. Only the people who can afford are getting it. The centers are very scattered. Trained manpower is not available. Then comes the renal transplant. Is considered the expensive option, but also as a problem because of not trained manpower available. Not specialized transplant centers are not available, especially in the rural and peripheral areas. So this is just a slide from the Medicare, actually. So the small number of the ESRD population has a big impact. So if you see, so this is the the ESRD population accounts for only 1.5% of the whole Medicare patients, but they take the budget of at least 10% of the whole Medicare expenses. So 1.5% of the patients are taking at least 10 times the allocated budget which should be spent on the other patients. So this is also another slide which shows the total expenditure, Medicare expenditures per person per year by the modality. So you can see per year they're roughly on spending $87,000 on hemodialysis, $66,000 on peritoneal dialysis, and $32,000 on the transplant. So a previous myth that the transplant is a rich boy's toy, I don't think it's true anymore. I think it's the choice of RRT should be the transplant in Pakistan. So this is a study actually done by Dr. Salman Imtiaz and Dr. Ashar Alam, published actually in 2021, which showed the cost of dialysis in Pakistan. It was roughly 54,000 rupees for one person for 1 month. And then there was associated cost with that, like water consumption of 350 liters in one session. It's a 100 machine with 3 sessions per day. Then electricity consumption, and then solid waste production, and the CO2 production in generating the electricity. So if you combine all this, it's roughly 700,000 to 800,000 at that time. It was in 2020, I think. And of course, the devaluation and things have gone up since then. The peritoneal dialysis cost was also about 30 to 35,000. So I just applied that same formula according to the current situation. And if you see, this is the cost in rupees as per the SSP. The Sehat Sahulat program in Punjab, government is paying 6,250 rupees per session. And if you count 3 times a week dialysis, it roughly accounts, the government is paying 900,000 PKR per patient per year. And the other cost is the water consumption, of course, which you can see, electricity consumption, solid waste production, CO2 production, and I'm not including in this the cost of hospitalization, access loss, medication, absenteeism from the work, and the transport cost, taking the patient, bringing from the home to the dialysis unit. And not only patient comes, usually there is an attendant or a family member also comes with the patient absent from the work. So it's roughly speaking, easily it can reach 1.5 million rupees per year per patient. So roughly, so you can imagine this is what the government is spending at the moment. So this is our experience. We are doing transplant free of cost. Government of Punjab is actually paying the money. So this is the last year cost of the transplant we calculated. Human resource was around 600,000. Upfront cost of surgery investigation, including immunology and drug levels, was around 1.1 million rupees. And post-transplant drug levels and immunosuppression was 347,000 rupees per year. So it was roughly in 2 million rupees. We did surgery plus 1 year medications. And after that, post 1 year follow-ups and drug levels and immunosuppression was, you can say it's 240,000 because of the reduced follow-up visits and need for drug levels. So the question arises, is the dialysis is the most feasible RRT modality for Pakistan? Clearly not, but we are spending we are taking the most expensive option, which is the hemodialysis in Pakistan. So, so why transplantation? As I mentioned, it's less symptom burden, better quality of life, increased productivity, and more cost effective than other modalities. Now, how the transplant is being done in Pakistan, so it's kind of a haphazard situation, actually. So we have a free of cost dialysis, transplant, mostly run by the philanthropic organization. A small portion is funded by the Baitul Mal or Zakat. Then we have hybrid models, which with, you can say, a co-payment in majority government-funded hospitals, like the patient bears the cost of investigations and hospital bears the cost of doing surgery. And then immunosuppression is also, its cost is borne by the patient. Then we have a private model in which total cost is paid by the patient. And then there is a significant number of commercial or illegal transplants is also going on, in which total cost and plus reimbursement to the donor. And there is also, I forgot to mention, is the third or middleman who also getting a lot of money with that. So I just looked at the regional countries. I worked in Middle East. I worked in the Western countries as well. I did spend 1 year in China as well. So I've studied all those models. So if you see a majority like the countries, rich countries with high tax to GDP ratios, they are giving the universal health coverage, which are state funded. Some countries like India, they are doing the insurance coverage, like there is a state insurance plus there is a state funded, there is a personal insurance which the patient can buy. And I spoke to my colleague there and they said in 70,000 rupees, they can get the insurance which covers all the kidney and liver transplant. Then there is a regulated private practice. To somehow we can say in Pakistan, there is a regulated private practice. Iran's have a unique model that is based on the willing to pay by the recipients. The government plays brokerage role between the donor and the recipient, and donor gets the reimbursement from both the recipient and the government. Good thing is that you cannot exploit the donor, and the donor is getting some reimbursement as well. And they have started, since they started this program, the waiting list has gone down. There's no waiting list actually. So they are doing it actually combined disease donation and living donation. They're a very good disease donation program as well. And it proved to be very cost effective, although it raises a lot of ethical questions, but it's a kind of unique model. No other country in the world is doing that. So let's come to the Pakistan. As I mentioned before, haphazard, not organized. Everybody is doing something good, but it's not uniformly available to everybody in Pakistan. The other problem is the no unified command. There is a HOTA, Human Organ Transplant Authority, but that's a regulatory body. Their mandate is legislation and some monitoring. So, but there's no monitoring at the level of society. No central registry or wait list of for the recipient available, lack of awareness among the physician and population. Religion and organ donation, of course, the cadaveric program, we have a problem. Though we have a fatwa which came in 2007, but still the people have some hesitancy. And then there is a lack of trained manpower. So we cannot have it expand this program into the rural areas. There are some studies I would just go through with that this is a Turkish study. I just brought it because it applies to Pakistan as well. The physician thinks that the lack of information regarding the donation process, there was concern about the sale of the organs, so it's kind of a mistrust. And then, of course, there was some Islamic religious beliefs. There was another study, actually I brought it because the Pakistan was included. It was done in 2005. The people wants to donate, but similarly, they don't know how to donate. Just like they want to give the tax, but don't know how to donate, how to give the taxes. There's no system in place to give them the guidance. This was another study in the Singapore done, and the important misconceptions and fears were like the fear of death in renal failure after donation, belief that the removal of organs violates the sanctity of the body. There was a desire to be buried whole, and dislike the idea of kidneys inside another person. Idea of donation being against the religious conviction. Deceased donor program, we have some fundamental problems here. There is still no reporting of the brain dead. In ICU, the ICU staff, they're not sensitized to recognize the people or who can be the potential donor for the organs. Of course, because this program is not there, so the hospital infrastructure is not there. So we need infrastructure for organ harvesting, storage, and transportation. And of course, the legal aspects, the P-HOTA Current Act has discrepancies for some important terminologies. So this is the same problem, the government problem, no funding, hospital problem, there's no practically brain dead donors we cannot identify. Community, there is no awareness of the brain death concept. They still think that people are alive. Another problem which I would like to emphasize is the qualified transplant coordinators. I mean, if anybody has worked in West, they will know that how important is the transplant coordinator. It's not like us who can do some computer work is a transplant coordinator. They are usually medical professionals and are very good sometimes they are running the show. So way forward, we need some organizational changes. I need a national action plan for this whole problem. We need a national transplant service or a transplant society, just like we have Trillium in Canada or NTS in Ireland. We need to establish regional network for organ sharing, like with the SARC or other countries, employing and training more transplant coordinators and having a separate body for the transplant coordinators. Other than this, the government official, we need to allocate more resources. Philanthropic model, not sustainable for long term and probably not for large population. We need more insurance-based coverage and mass awareness campaigns for deceased donor programs. Fatwa is not enough, actually. And setting up the registry would be ideal for this. I think the PSN is working on it. So I think we already, PSN is working with the registry. We need national paired exchange program, and we also need transplant waitlist from different blood groups. So just few ethical questions to increase the organs in our country. Should we allow a legal market for the transplant organs like we have in Iran? Or should we allow the prisoners to donate their organs to reduce their time in the jail? Maybe voluntary, although it raises some ethical questions, but I think that's the food for thought for you tonight. I would end here. Thank you very much for your attention.
Thank you so much, Dr. Nair. Now we are moving towards the last lecture of this symposium. I would like to call upon Dr. Shahnila Javed to please come and enlighten us on the topic of pre and post-transplant immunization.
Dr. Shahnila Javed is well known to our transplant unit as she has worked with us till a few years back. She has been trained in transplant ID from SIUT, and now she's serving as an expert in infectious diseases in Patel Hospital, Karachi.
Assalamu alaikum, everyone. Thank you, Dr. Tasadduk, for inviting me to this wonderful symposium. And so I would start my talk with with a case scenario of real life case scenario of 15 years old male who underwent life-related renal transplant. He had a good match. He did well post-transplant. 2 months post-transplant, he presented with disseminated chicken pox complicated by pneumonia. Patient was in severe respiratory distress, got intubated, but couldn't survive and died with a functioning graft. So I put this slide just to emphasize, just to highlight the importance of vaccination in transplant population. And transplant vaccine preventable infections can be vulnerable to transplant recipients and infections after cardiovascular disease are the second most common cause of death in CKD. Impaired immunity, immunosuppressive medications, or dialysis are the predisposing factors for infection in this population. So we have generally low vaccination rate in our general population, which is even lower in transplant population. And several barriers have been identified to the vaccination, which included the social and financial status, lack of healthcare access, personal perception of vaccination and increased skepticism of vaccines, lack of adequate knowledge on immunizations. Specialists caring patients with CKD may overlook vaccination, and there is reduced efficacy of vaccines and safety concerns for transplant candidates or recipients. And the main obstacle in vaccination of transplant population is the fear of rejection after vaccination. You know, while there are concerns in the clinicians that vaccination can trigger allograft rejection, however, there are numerous clinical trials which show no association between rejection and vaccination. So what is the optimal timing of immunizations? The vaccination status should be evaluated pre-transplant, and appropriate vaccines should be offered at the time of listing. Live vaccines can be offered 4 weeks before transplant, and inactivated vaccines can be given 2 weeks prior to transplant and 3 to 6 months post-transplant when there is less immunosuppression. With the exception of when anti-B cell antibodies are given, you have to wait for 6 months. So this is a normal recommended vaccine schedule for the adult patients. Same is for the transplant patients. But there are few vaccines which are live vaccines and cannot be given in the transplant. This includes the influenza live attenuated vaccine, which is given through the nasal cavity, the MMR vaccine, the varicella vaccine, and the BCG vaccine. So I would briefly describe the few of the important vaccines, like influenza vaccine, which is available in inactivated and live attenuated forms. Inactivated vaccine is recommended post-transplant, and live influenza vaccine is contraindicated in the post-transplant period. Next is the pneumococcal vaccines, which are very important, and it is also an inactivated vaccine. Comes in 2 types: protein conjugate vaccine, which is highly immunogenic and induces a T cell dependent response, which leads to the formation of antibodies and memory B cells, and the polysaccharide vaccine, which elicits T cell independent response, but it has the advantage of covering more serotypes. So both vaccines are needed to prevent the transplant patients from invasive pneumococcal disease. And the dosing schedule is like, if the patient is naive and has not taken any pneumococcal vaccine, and he is greater than 19 years of age, you can give conjugate vaccine and have to wait for at least 8 weeks after conjugate vaccine, then administer the polysaccharide vaccine, then wait for at least 5 years, and then give the second dose of polysaccharide vaccine. If the patient have previously immunized with the polysaccharide vaccine and is of 19 to 64 years of age, then wait for at least 1 year, then give the conjugate vaccine, and wait at least 8 weeks after the conjugate vaccine and at least 5 years after this vaccine to give the second dose of polysaccharide vaccine. In the patients who are greater than 19 years and has received the conjugate vaccine, wait at least 8 weeks after this conjugate vaccine for the polysaccharide vaccine, and then after 5 years, second dose of the polysaccharide vaccine. Next important vaccine in the transplant population and then CKD population is hepatitis B, which is also inactivated vaccine and can be given pre or post-transplant. 3-dose series at 0, 1, and 6 months are recommended. Anti-HBs is a marker of immunity in these patients, but due to impaired immunity in the CKD population as well as in transplant recipients, the response is less intense and less durable. Titers waned with the time, and transplant and higher doses are required. So this was a meta-analysis published in the Journal of Nephrology 2020, in which they assessed the hepatitis B virus vaccine immune response in dialysis patients. And 6,628 dialysis patients with HBV vaccination were included, in which 4,582 were responders, which makes 69% of those patients, and 2,046 were non-responders. So this is the schedule. This is a monitoring of the anti-HBs titers in this CKD patients. So anti-HBs titer is the marker, and you have to test the anti-HBs antibody 1 to 2 months after the last dose given. If the anti-HBs titer is greater than 10, then it's, the patient is vaccinated, and annual screening of anti-HBs titer is recommended. If after 1 year the titer is less than 10, give the booster dose. If it's greater than 10, annual testing, continue annual testing. If the anti-HBs titer is less than 10, repeat the whole vaccination series. If greater than 10, now do the annual testing. If it's not greater than 10, evaluate for hepatitis B surface antigen, and if positive, treat for HBV infection. If negative, prevent infection from post-exposure prophylaxis. Next, the very popular COVID vaccine, which is also inactivated vaccine, and the COVID is new virus, so recommendations are changing. The joint statement of the American Society of Transplantation and American Society of Transplant Surgeons recommended that whenever possible, give the COVID vaccine prior to transplant, and with a primary series with 3 doses of mRNA vaccine. Next is a varicella vaccine, which I mentioned is the live attenuated vaccine. History of chickenpox or vaccination before. If there is a history of chickenpox or vaccinated before, antibody titers should be done. And it was roughly estimated, it's unpublished data, that 25% of our population is non-immune for VZV, and it's contraindicated post-transplant. Another important vaccine is tetanus, which is inactivated vaccine. Adults who are not previously immunized for tetanus should receive a 1-dose Tdap and then TD booster every 10 years. But for our population, as we don't have this Tdap or TD, we should give 2 doses of tetanus toxoid 4 weeks apart, then booster every 10 years. Other vaccines which can be offered in transplant population include the meningococcal vaccine, hepatitis A, but according to the compelling indications. Vaccines for the household contacts of the transplant include the annual vaccine, influenza vaccine, annually, varicella vaccine, COVID, and rotavirus for the infants of transplanted mothers. And so take-home message is vaccination remains an important yet frequently overlooked component in caring of transplant population. Response to many vaccines is diminished in organ failure. Transplant candidates should be immunized early in the course of their disease. Thank you.
Thank you so much, Dr. Shanila. Any question from the audience or from the panel of experts, please?
Considering the time constraints, we have decided not to ask questions, but just to give the concluding remarks. I would like to congratulate Team Transplant Dow International for organizing another successful symposia on this important topic. And so this was the end of day storm with knowledge from the distinguished speakers and experts in their fields. I would just like to comment on one of the speaker from the recent session. It was about the HOTA, the Human Organ Transplant Authority. This authority is very well aware of the terms DCD and DBD, and also there are long-term sustainable models, philanthropic models existing in Pakistan. Thank you.
Thank you so much, ma'am. Now we are proceeding towards the shield distribution ceremony, for which I would like to request President, Pakistan Society of Nephrology, Professor Ijaz Ahmed, to please come up on stage and
Firstly, I would like to request Dr. Rubina Naqvi from the panel to please come on stage and receive your shield. Next, I would like to call upon Dr. Rashid bin Hamid to please come on stage and receive your shield.
As a chief organizer as well, because Dr. Rashid and me has done a lot for the last 1 month in organizing this symposium. So give him a big round of applause for arranging, because he was all the time with me for arranging this conference or this symposium. It was not an easy task. Thank you very much, sir.
Now I would like to call Dr. Ashar Alam to please come on stage and receive your shield.
now I would like to call upon the speakers from the fourth session to receive their shields. Professor Salman Imtiaz, please come up on stage. Dr. Naveed Sarwar, please come up on stage. Dr. Muhammad Mubarak Saab, please come up on stage, sir. Dr. Nayyar Salim Saab, please proceed to stage. Dr. Shainila Javed, please come up on stage. There are a few other renowned physicians and surgeons who have joined us from other parts of the Pakistan. I would like to call upon Dr. Mohkamuddin. Dr. Mohkam, please come up on stage.
Thank you very much, Dr. Mohkam, for coming all the way from Quetta for attending this symposium. I really appreciate, and we want to encourage all the participants who have come from different cities. Thank you very much. Next, Dr. Hayat Kakar from Quetta, a transplant surgeon who has done a marvelous job in starting a transplant program in Quetta and he is doing transplant individually as a transplant surgeon. Give him a big round of applause. Next, I would like to invite Dr. Salman, who has come all the way from MIKD Multan, and he is also a transplant surgeon, and give him a big round of applause because he has started the transplant program individually, and he is a transplant surgeon over there. So we have a shortage of transplant surgeons, so we should really, really appreciate our transplant surgeon. Yeah. So everybody knows that he has been trained from SIUT. Last one, doctor? Dr. Khurram from Multan. He is also a transplant surgeon. Please come on the stage to receive a shield. Is he here? Dr. Noman, sorry, I'm so sorry. We have been communicated wrong name. So Dr. Noman, thank you very much coming all the way from Multan and participating in this conference, and thank you very much. So now I would like to invite Professor Rostaing to please come on the stage and receive a special gift from the Renal Transplant Unit.
Now, I would like to call upon the organizers of this symposium, and I will ask Dr. Rashid to please present this shields to the organizers. Dr. Sidra, please come up on stage and receive your shield.
Dr. Sidra has worked really hard in preparing all the things for this transplant symposium. So thank you very much, Dr. Sidra, for being a part of an organizer. Thank you very much. So next, Dr. Hassan, who has always been so kind and give his all time for the last 3 nights. I'm sure he hardly slept for 2-3 hours. So thank you very much, Dr. Hassan. Dr. Anam, despite of doing all the clinical works, because I have given over to her for last couple of days, she will look after patients very well, and along with that, she managed to give her time for this event. So thank you very much, Dr. Anam. Mr. Naveed, our manager of Renal Transplant Unit, he has also worked day and night in managing all the shields, all the outdoor works, and thank you very much for being a part of our unit and worked really hard in for this successful event. Mr. Jahzeb, our transplant coordinator, who has also worked very hard in arranging this transplant symposium. Thank you, Jahzeb. Now I would like to invite Ms. Nasreen Jokio. Everybody knows her. She is our oldest transplant coordinator, and she has also worked really hard for this transplant symposium. Thank you. Now, Ms. Norina, our transplant coordinator, Where is she? She's always lazy, but she is very intelligent and she remembers everything. She does my transplant OPD with me like a doctor. I really appreciate her. She remembers every patient and every even labs, and she makes me not to forget anything. So thank you very much, Norina, for participating in this event.
Lastly, but not the least, the backbone of renal transplant unit and the symposium, today's symposium and the last year's symposium, one man only, Dr. Tasadduq Khan. Please give him a big round of applause. स्टैंडिंग ओवेशन बनता है वैसे. Thank you, sir. Larib Khan, please.
In the last, for this successful transplant symposium, I thank all the audience who have spared their time on a working day. Thank you very much. But last, not the least, the most important part, the pharmaceutical companies who have sponsored us for arranging this transplant symposium. So I would like to invite from Martin Dow, who are our platinum sponsor for this event. Anyone from Martin Dow? अभी देते हैं. अभी पहले करना. Alliance Pharma, Novartis, Allmed, please line up so that we can spare some time. Thank you very much for supporting us in arranging this huge educational activity. And we hope that you keep doing this great work. Allmed Pharmaceutical, Kaizen Pharma, Sinovo Pharma, Getz Pharma, Sequino, please, Sinovo. They have launched a new product. That's why, yeah, it's a company. Kaizen, who is from Kaizen? Please come on the stage. Sinovo Pharma. Bosch Pharmaceuticals. Getz Pharma. Anyone from the Bosch Pharma? I think they have left. And there are few letter certificate of appreciation who have worked hard from our department, Mr. Amir. Oh, one pharmaceutical has left, Mector Pharmaceutical, please come on the stage. I'm so sorry that because of shortage of time, we are just trying to wrap up as soon as possible because we have a gala dinner. No, but done. Any pharmaceutical who is left? No. Eastern Trade Pharmaceutical, please come on the stage. They have their immunoglobulins. Done. There are few all other participants who have done really hard. Mr. Amir Malik, please come on the stage. ये पे छोड़ दो ना और काम Mr. Ikramul Haq, Miss Lareb, Mr. Fahim, Mr. Zaid bin Hamid, Zaid bin Hussain. Amjad, Mr. Amjad. And other pharmaceutical who are present who have partly participated, Avior, Gentech, Tabros, anyone who wants to come on the stage? Tabros Pharma, yes. Platinum Pharma, RG Pharma, ये platinum वाला है, platinum वाला, देखो. Tabros, RG Pharmaceutical, Feroz Sons, Feroz Sons, RG Pharma, Platinum, given Platinum का बस ठीक. Gentech Pharma. Thank you very much. So I'll invite Dr. Rashid for the concluding remarks.
This is a very informative and very, I think, successful as far as audience is concerned and the speaker is concerned. And I am thankful to all my friends who came from outside the Karachi. Thank you very much, everyone, to make successful event. Thank you.